but every once in a while, somebody has their favorite. Well, Thank you, and I hope everyone's wide awake now. My name is Bill Kahn. I'm an associate professor of percussion at the Eastman School of Music. And with me is a freshman percussionist, Hannah Dick, playing on the Ghanaian rattles called ahatsis. And I'm playing on a Ghanaian drum called a breakout. It's our pleasure to open the Rochester Global Health Symposium with music, which is widely regarded as the international language, and in this case, highlighting dance rhythms of Ghana performed on Ghanaian instruments. The relationship between music and the sciences, including medicine, is over 2,000 years old, dating back in time to the ancient Greek philosopher Pythagoras, who discovered mathematical connections between the musical vibration of strings and the rhythms of the cosmos. The two of us have volunteered our time to teach drumming, including the music you just heard, to grade school students from the Rochester City Schools. We have found that music is also a pathway into the hearts and minds of young people, inspiring and motivating them. So we hope that your time here will be inspiring and motivating, and we wish you all the best for this day of symposium. Thanks very much, and on with the program.
Thank you very, very much. That was wonderful. Good morning. I'm Nana Bennett. I'm one of the directors of the Clinical and Translational Science Institute here at the University of Rochester, and I'm also the director of the Center for Community Health. And it is my great pleasure and honor to welcome you to the second annual Rochester Global Health Symposium and UNYTE Scientific Session. As you know, the UNYTE group has been in existence for almost 10 years, and it's a consortium of biomedical and academic research institutions across upstate New York. And it's our great pleasure to produce symposia periodically for all of the UNITE members. Did I do that? I didn't mean to do that. So this is one of that series, but more importantly, this is also the second annual global symposium, and we're very excited to have this today. And you may wonder why someone who directs the Center for Community Health is welcoming you to this symposium. And I think it's obvious these days that we live in a global world. And fundamentally, what we do on a local level has implications for what we do on a global level, and vice versa. There's much that we can learn from global solutions that we can apply locally. I think this was, very obvious back in the days when we had SARS. That was probably one of the first episodes where working in local public health meant that you had to be completely aware of what was going on at a global level. Now we have more recent examples, which you will hear about today, but fundamentally we're all working together. And I think that global health and local health will become one at some time in the future. So it's my pleasure to welcome you. It's also my pleasure to introduce Dr. Timothy Dye, who's professor of obstetrics and gynecology and also the chair of this symposium. Thank you.
Good morning. Welcome to Rochester on this nice, brisk, sunny day. And we are very happy to be broadcasting live on YouTube through our channel and also tweeting on our Twitter account. So this is our second annual Global Health Symposium, sponsored this year by our Global and Territorial Health Research Network, funded by the Centers for Disease Control Prevention Research Center program, and the UNITE initiative from the CTSA program here at the University of Rochester. We're very excited about the program that we have. We have speakers this morning. We have some breakout sessions this afternoon. We have about 30 or 40 posters submitted to our poster competition over lunchtime. So we're hoping that we cover a wide area of topics that might be of interest to the people who are physically in attendance and to those people who are online. A little bit about our mechanics for the day. We, like I said, we're streaming live, and for those of you who want to follow or tell your friends to get online and watch you or hear what's going on, you can get to it, our YouTube channel at tinyurl.com /rockglobal, and that'll be our live feed. Our Twitter handle is @_global_network, #rockglobal2016. We also have an app for those of you who would like to follow along on our app and get more information about our speakers and the program for today. For those of you who are registered for the conference, you would have gotten an email about how to download the app. If you didn't get the email, or if you'd like to have access to the app, both for people physically here and people online, email Solomon Abiola, who is one of our PhD students here, but is also the tech brains behind our app. So please email Solomon, he'll get you set up. So the symposium is funded by the NIH CTSA initiative and the CDC's PRC initiative here at the University of Rochester. But we've additionally obtained funding from a variety of different groups within the University of Rochester, including the Office of the Provost, the CFAR group, Center for AIDS Research, the Department of Public Health Sciences, the School of Nursing, and through the generous time donation of the Eastman School of Music. Our partners at the University of Illinois have also donated funds to help support our streaming initiative. The Yale Griffin Prevention Research Center is one of our partner groups, and our implementation partners at the University of Hawaii and University of Puerto Rico. So we have a very active group here called the Global Network, and you might be wondering what the Global Network is. You can go to our website, which is globalresearchnetwork.net, and read all about what our group is. We have a coordinating center. We're here at the University of Rochester, which is the coordinating center for the initiative. Collaborating centers, Yale University and University of Illinois. Our implementation partners from Puerto Rico and Hawaii, and our affiliated members in North Carolina and South Florida. And we're nested within the CDC's Prevention Research Centers program, which has dozens of locations throughout the country, so we're directly connected to all of them as well. We're a rather new initiative. We started last year, had our first symposium last year, and we conduct research in other countries and in U.S. affiliated groups in the Pacific and the Caribbean, particularly focusing on things that we could bring back here to the mainland and serve our own population. So we look bi-directionally at global and local health, learning from local geographic places and bringing that information back here to the mainland United States and applying it here. This symposium is primarily a networking opportunity. We have short bursts of presentations on a wide range of topics to stimulate interest and to generate some conversation and contacts. So we're all about networking, which is why we have all the connections that we have on social media and the YouTube channel and all of our partners that are involved throughout the globe. But we're also interested in identifying research partnerships and education partnerships with other institutions. So please feel free to contact any of us involved if you have a project you're interested in, or if you're located somewhere else in the world and you'd like to network with our researchers. So we have a busy agenda. It's all identified within within the app and also on our YouTube channel. And we'll be covering a wide range of topics ranging from cancer to Zika, chronic disease, all throughout the world. And so we're looking forward to our speakers talking with us today. A lot of people have pulled this conference together. We have our CDC sponsors who are here. We have our representatives from UIC and Yale who are also in attendance, a wide range of people from the University of Rochester. And I might add that we've pulled people in who are quite talented in their fields, and they may be doing something different for us. So we have a lawyer who's helping us with our technology. We have a senior computer programmer who's taking photos for us today. So we've engaged everybody around us who can do anything, and we're very appreciative of that. We're also nested within the University of Rochester's PRC, which is directed by Dr. Steve Barnett, and we've received support from the Provost's office, and we're very grateful for that. We also have a Twitter team of some of our staff and some of our students, and we're very pleased that they're helping us out with that, and we're very grateful for all of our speakers coming here today. So without any further information, I would like to introduce our first speaker. And generally, I'd like to say to all of our speakers, please speak here into the microphone, because that's what goes to YouTube. If you feel compelled to move around, we're going to have to outfit you with this and turn it on. So if you want to move around, tell us and we will adjust. But otherwise, please stand here and speak. We do have complete bios that are available through our link on the app and also on the cover of your packets for today. But I will give a little bit of information about each speaker as they come up. I'm exceptionally pleased to introduce our first speaker, who is Dr. Neil Palafox from the University of Hawaii. My students know Neil well because he's featured in the series in Sickness and in Health, which is a series on PBS that focuses on the social determinants of health. And all my students for the past decade have watched that video, and they see Neil talking about social determinants. And he was talking about social determinants before the rest of the world sort of caught on that we should be paying attention to social determinants. So we're very pleased to have Dr. Palafox with us. He's professor of family medicine and community health at the John A. Burns School of Medicine at the University of Hawaii. And he's worked throughout the Pacific, spending a decade in the Marshall Islands. And he's worked with cancer survivors and populations affected by the U.S. Atomic bomb testing sites located throughout the Pacific. And he's done a lot of work on cancer. He leads several cancer initiatives funded by the NCI and through CDC. And he's a very important person in the Pacific, and he's a very important person to us, and we're happy to have him with us. Dr. Palafox.
Thank you very much, Tim. It's an honor for me to be here. I have 3 hours worth of presentation in, I believe, 20 minutes. So I'll just start in very quickly. And but again, it's my honor to be here, and I thank you very much for the invitation to this great conference. So today I'll be speaking on really global policy and how, in my context, it affects Pacific Island health. And so global policy, as you know, it affects many different things, many domains. It affects geopolitical alliance, economy, and therefore military events. It affects weather and climate. It affects social determinants of health. It affects individual choice. So all of these things, all these bullets affect health. And so global policy can actually trump anything you're doing. And so that's why I think it's a very important topic in doing global health measures. And so this is where I work, and as you can see from this slide is all the underlying places are the U.S. affiliated Pacific. But just to start off the conversation, the Pacific has been dominated by lots of different powers. So you can see there's French Polynesia, which also includes, the French domain includes New Caledonia. There's the United Kingdom, which, and the British Commonwealth, Australia, New Zealand, many of the countries. And then there's the U.S. part of the Pacific, which I'm the most familiar with. And so where this map outlines is the U.S. affiliated Pacific. American Samoa is the most south. As you can see, the target is the Republic of the Marshall Islands. The oval is Federal States of Micronesia. To the left of that is Palau. North of that is Guam. And to the north of that is the Commonwealth of the Northern Marianas. And so this is a U.S. affiliated Pacific. Largely, except for American Samoa, we call it the North Pacific. And so the North Pacific is the U.S. stronghold. And so what do we have in the U.S. affiliated Pacific Islands? We have two territories, Guam and American Samoa, are territories of the United States. We have a Commonwealth, like Puerto Rico, it's the Northern Marianas is a Commonwealth. Then there's three freely associated states. And the freely associated states are freely associated with the United States. They're independent nations, former territories of the United States, but there's a treaty with the United States that says the United States has all U.S. military oversight over them, and the quid pro quo is that they give them some economic assistance, some federal grants, and they allow them to go back and forth to the United States and work without a green card or visa, though they're independent nations. So the first part about global policy is that it affects military events. And so from 1946 to 1958, the United States tested 67 thermonuclear devices in the Pacific. It was the equivalent in megatonnage to 7,200 Hiroshima bombs. We can't go into all the health effects of that. They were tremendous. One of the things about the nuclear weapons testing, and to show you what global policy is about, the testing went until 1958. In 1954, the Marshall Islands asked the United States, they said, we kind of had enough of this. There's been so much testing and so much contamination. We want you to stop. The United States said, no, we're not going to stop. We're going to continue the testing, and they continued testing through 1958. So that's global policy in one frame. And so this is not only about the United States. So where else did nuclear testing happen? Everybody wants to test in the Pacific. So the French tested in French Polynesia, the capital is Tahiti. The British tested in the Aboriginal deserts of Australia. Again, you can see global policy. Where do you test? You test in distant sites where there's less economic power and political power. So one of the other things that global policy affects, it affects finances. And so this is to show you in the U.S. affiliated Pacific, the lowest line is the United States, how much we spend per capita in the United States on healthcare. But look at the other parts of the U.S. family. American Samoa, 500, CNMI, 793, and you can look down the list. But look at Chuuk, one of the Federal States of Micronesia, $140. Okay, and this was in 2013. So again, even within the U.S. family, the U.S. family is not part of the U.S. family, is not part of the U.S. family. Global policy has a lot to do with this, and I'm sure the people from Puerto Rico and maybe the U.S. Virgin Islands might have similar stories to tell on this. And so that's the part about the finances. Then there's a part about education. One of the things about the freely associated states is they were former territories, and the compact, they were supposed to bring them up in health and education and so forth. So what does their education look like? Which is one of the social determinants of health, as is finance. So 35% of the people who have less than a high school education, 34% have a high school education, but in the Federal States of Micronesia and the Republic of the Marshall Islands, of those who graduate from high school, most of them read at the 4th or 6th grade level, though they graduate from high school. So again, as a social determinant of health, you saw the first slide, finance, this is about education. 15% have some college or college education. So therefore, if you look at how it plays out, what is the infant mortality like in the freely associated states? Federal States of Micronesia, 21 per 1,000 live births, RMI, but I want to compare it to the U.S. The U.S. is 6. Look at the longevity. In the U.S. affiliated Pacific, in the Federal States of Micronesia, it's a full 10 years less than the United States. Part of the U.S. family, former territory, aligned with the compact, but you can see the difference, and it aligns with, as Tim mentioned, social determinants of health have a big part to play in it. Global policy has a big part to play in the social determinants of health. So this slide really is about obesity rates. And so if you look at the very bottom, the obesity rates, so it's overweight plus obesity, and this was put together with a colleague of mine, Dr. Lee Buenconsia alum. And you can see in the United States, obesity plus overweight is about 63% of the population. But if you compare that to the US Pacific, look at American Samoa, 93%. Commonwealth Northern Marianas, 86%. Chuk, 76%. Krashai, 92%. So again, social determinants, Pacific, very different. And therefore, it plays out very differently. And why is this important? Obesity, as we all know, lots to do with cardiovascular disease, strokes, and so forth. But there's 10 different cancers that are also associated with obesity. So it plays out in cancers and all types of non-communicable disease. This is on cancer itself. And if we look at the cancer rates, and again, this was some work put together by Dr. Buenconsia alum, in the Marshall Islands has 7 times the cervical cancer rate of the United States, and actually has the highest cervical cancer rates in the world, part of the US affiliated Pacific. Pohnpei has 4 times the rates. Liver cancer is twice the amount, and the carrier rate for hepatitis B in the US affiliated Pacific is about 15%. In the United States, the hepatitis B carrier rate is about 2%. So, again, as a comparison, I just wanted to show you what happens, what plays out with global policy as it moves through the social determinants of health. This is about cancers, because I do a lot of work with cancers, and the big parts of the pie, lung cancer, breast cancer, prostate cancer, colon cancer, liver, and so forth. So those are the big pieces of pie, but what's unique about this is all of these, either there's a good screen for it or they're preventable. And look how big the piece of the pie is, it's huge. So in the Federated States of Micronesia, there is no mammography. US affiliated, it doesn't exist, it's not there. Republic of the Marshall Islands, they have 1 functioning mammogram to cover 750,000 square miles of ocean, a lot of atolls. It's not functional. So again, this is the cancer picture, and it looks like this, and a lot of it's preventable, and it plays out in a very specific way, global policy. So global policy also determines weather. So as you know, whether or not you believe in climate change and all the rest of it, most of the scientists in the world believe in it. Some of the politicians do not. But it's one of these things that it's moving, it's going forward. The Sentinel sites are actually in the Pacific because they're already flooding. There's flooding of the taro fields in Chuk, and tons of pictures. There's bleaching of the coral in not only in Australia, but in Palau and so forth. So the trends in weather, more droughts, more severe and so forth. There's water shortages. This picture is from the Marshall Islands. And the most vulnerable spots are small island states, coastal communities. So a lot of these places in the Pacific. A lot of places in the Pacific, the Federated States of Micronesia, Republic of the Marshall Islands, the average height above sea level is 6 feet. So any kind of change in climate and water change is going to have a big effect. Global policy determines their environment. They have very little to do with the climate change. It's the large countries that have a major part to do with fossil fuel burning, methane release in the atmosphere, and so forth. So again, global policy affects this environment. The tail of turkey tails, and why am I talking about turkey tails? Turkey tails are a turkey tail. It's composed of the uropygeal gland, which is really the gland that produces oil and feathers. So it's a fat content. It's over 40% fat. It can't be sold in the United States, so it's exported from the United States. It's dumped into the Pacific, large part of the Pacific, and it's pushed into Pacific nations. And it's really an unhealthy food. We can't sell it here, so we sell it abroad. And so in 2007, the government of Samoa, not American Samoa, but called Western Samoa, they call themselves Samoa, at the request of the Prime Minister, said, we're going to ban turkey tails. It's because it's bad for the health of the people. In 2013, Samoa had to formally lift this ban on the importation of turkey tails in accession to the World Trade Organization. global policy said, if you want to borrow from the World Bank, you will lift this ban. So they lifted the ban because the World Trade Organization mentioned that. So really briefly, I'm covering World Trade Organization, IMF, in about 30 seconds, so stay with me. So another parallel story is mutton flaps. So in New Zealand, mutton flaps are the meat that's in part of the sheep's ribs, but it's really low fat, it's grizzly and so forth. So New Zealand dumped it into different parts of the Pacific, and there were attempted bans by Tonga and Samoa because they said this is low stuff, and in fact in Australia they use it as dog food. But the World Trade Organization told Tonga and Samoa, you can't ban this stuff. And so World Economic System, global policy, is really dictated by the World Bank, World Trade Organization, IMF, International Monetary Fund, and it's enforced through what's called structural adjustment. And so the World Bank, in summary, there's tons of courses at Harvard that last 5 years about this. The summary is they lend money. They lend money to developed nations. What they're composed of is they're composed of countries in the industrialized nations that donate into the World Bank, and they lend money to developing nations. The World Trade Organization is a global international organization dealing with the rules of trade and agreements. And the goal is to lower trade barriers. That's why you can see that's what happened in Samoa and in Tonga. They said, we need to lower the trade barriers, so therefore, that's what happens. But that's what the World Trade Organization does, is it, deals with rules of trade. The IMF really is about stabilizing currency. The sum of this is that the World Trade Organization and the IMF, again, I'm talking about global policy here, is they regulate how to restructure government systems to strengthen the private sector for foreign investment. So in many of the Pacific nations that need money from the World Bank, if you want to borrow, you have to meet the World Trade Organization IMF rules. So you have to decrease the bloat of your government. And it means that the private sector has to step up into what the government's paying for. So, and health and education, therefore, sometimes has to be pruned because you have to decrease the bloat of the government. You have to decrease spending in all government sectors. Consumers should pay for all this. So very much the private sector model, very much the Western idea of how economic patterns should work. And so, and it wants to liberalize import controls. So, Tim teaches a course on medical ecology. Why am I talking about this? All of this that I talked about has to do with political ecology. Medical ecology is about how all the medical systems interrelate that actually form what happens with health. Political ecology is the relationship between politics, economic environment, and social environments that affect health. All of what I showed you was what happens with the policies that affect health. So the common denominators are the power differential. So a lot of times in global policy, whether it's the WTO, to France or United States, the power differential and who you're working with. In the Pacific, what is a power differential? They don't have any power. So who dictates what happens is World Trade Organization, United States, France, and all the rest of the larger countries. The second thing about political ecology is it people and community centered, meaning who is at interest here? Is it the people you're serving who the atomic testing is happening on? Or is it the institutions that are doing the testing? And so you can see from this, it tends not to be the people where this is occurring. And that's one of the natures about global policy that is important to understand, is that it often is not about the people that need the money or that are in these countries. It's about the interests of these larger global institutions. The third thing is about community engagement, and many of you know about that. That's the way you work. It's about, are they at the table and have meaningful dialogue when these decisions happen? We want to stop the nuclear testing. No. What kind of community engagement is that? There is none. And so it's my way of saying that global policy, and we would like to ban turkey tails. Well, you want to borrow money? No. And so and one of the things about political ecology, and the people who I believe use it have a very little understanding about what it does to the social determinants of health and healthcare in general. They're administering what they believe is good policy from a reductionist standpoint, meaning that reductionist is you're reducing it to one thing, that to liberal open borders for trade, to do things in the Western way is clearly good for everybody, clearly. So therefore, we want the Pacific and other countries to look like us. That's the way we do business. And so it's one of this reductionist way of thinking, which then lends itself to what you saw. Social justice, it's one of these things when we see that, because what this does is it takes away individual agency and individual choice. Do these countries really have any choice? They probably do not. And so in this model, what global policy has done is taken away their choice about climate change, about nuclear testing, all these different things. And in so doing, it's affected their health and the social determinants of health. The last bullet I want to discuss is structural competence. And what that idea is that a lot of people think that structural competence is that a lot of people think that when you have bad health outcomes, it has a large part in culture. That's what transpires. Structural competence says, is there something out there that trumps that? And oftentimes, the political ecology and global policy does in fact trump that. So I can tell all of you without even any hesitation, whatever you're doing, whether it's cervical cancer or technology, the digital divide, global policy will trump you in 1 second. And so unless it's addressed and that environment's addressed, you'll be at some level spinning your wheels and working really hard at what you're trying to do. But because of this reductionist thinking and the lack of the social justice, which gives these people the choice, I believe, because I've worked there for a long time, we will be spinning our wheels. And so understanding political ecology, like you have to understand medical ecology, is so central to global health. And that's what I'm trying to engage in this conversation. And thank you very much for this discussion.
Thank you, Dr. Palafox. We will have the group come up as a panel toward the end of the session, and we can ask questions and make comments at that point. So thank you very much for setting the tone and highlighting the importance of political ecology and social determinants in our thinking for the day. And I'm very happy that we're next moving on to a specific example that many of us are familiar with, that's certainly an issue in the Pacific as well, which is cervical cancer and global cervical cancer screening programs. So next we have Dr. Jennifer Smith, who is with the Gillings School of Public Health at the University of North Carolina. Dr. Smith has worked for a long time in the field around cervical cancer particularly, and is the principal investigator of an NCI R01 study that looks at HPV self-screening, and Dr. Smith has also started and directs a coalition, the Cervical Cancer-Free Coalition, which is a global initiative aimed at preventing cervical cancer through vaccination against HPV. So at this point, I would like to welcome Dr. Smith.
Thank you. Oh, thank you. Okay. Thank you, Tim and colleagues, for inviting me to come and speak today. It's great to be back in Rochester. Last night we went to meet the incoming incumbent provost, who gave a very nice talk. And I wanted just to start my talk with a reference to what he was talking about last night, which is about networks and building networks in terms of how can we actually make an impact, like Neil is talking about, in terms of how can we make a global impact on whether it's another global health outcome or global cancer prevention. I think we need to do it through networks, through policy, and we've been working, really state by state in the U.S. and then also now working with countries to think about developing coalitions, country by country. And these coalitions are groups of individuals who may be researchers, but policymakers, it's the advocate, it's the media folks, it's folks who are involved in the private sector, in the public sector. And I think it's really important that we think about this occasion today to continue to build these networks and learn from each other, because I think ultimately, although I might be talking about a particular technology development or a technology approach, I think we really need to think about behavior and think about a multitude of factors as we try to move forward on really making an impact on these global outcomes. I'm here from the University of North Carolina, and I'm going to start not just talking about cervical cancer today, but talking about how does global cancer fit in terms of projections, in terms of global burden. So these are the global projections for selected causes of incident deaths. And these projections are from 2004 to 2030. And you can see here that cancers are becoming more prevalent and important. Heart disease is becoming more important, and stroke is becoming more important. And if we were in a small class session, I'd say, well, why do you think this is? And so why do you think this is? Why do you think that these are increasing in terms of the incidence over time? Aging populations, thank you very much. So you can see here that these are increasing in terms of their burden, and as we are actually looking at the other causes of mortality, we see that acute respiratory infections is going down. We're learning how to control those better. You can see that road traffic accidents is kind of stable. I'm not sure what exactly, we can discuss that later. Perinatal is pretty much stable, and HIV and AIDS is stable or at a plateau, and TB as well. So some of the big causes of death are, in terms of infectious disease burden, are either plateauing or declining in general. So if you think about your future and you're a young investigator, I would say, why don't you put global cancer control on your agenda? It's the second cause of disability and death. It accounts for 1 in 8 deaths annually. And more people die from cancer than AIDS, tuberculosis, and malaria combined. And as I showed in the previous slide, the number of, the total burden of cancer is increasing dramatically. It's predicted to be roughly 17 million by 2020, and expected to rise to 27 million in 2030. And there was also a really very well-written article in The Economist that you can see here, and I'd be happy to send it to anyone who's interested, or you can just Google the global burden of cancer, challenges and opportunities, which I think really lies out a lot of the issues related to global cancer prevention. So where are we if we just look at, often I talk about, well, let's just look at the data first, and when we try to think about, well, where do we want to go in terms of our focus in terms of our efforts, and that includes also research and policy. So you can see here, when I started working on cervical cancer, which is here, cervical cancer, which is here, cervical cancer was the most common cancer among females. So this is actually just a GloboCan data that looks at the estimated incidence of both incidence and mortality. Incidence here being the number of new cases of cancer in blue, and mortality estimated deaths due to cancer in red. And the IR colleagues actually compile data that's based on either cancer registries, which are rare in many countries of the world, or they use data based on hospital frequency estimates, or they actually use data based on neighboring countries in some instances to try to get an estimate of the overall incidence and mortality of cancer stratified by cancer type. And so here there's a depiction of the comparison of the incidence in blue and mortality in red in more developed countries as compared to that in less developed countries. And as I was saying earlier, that if you look at cervix, which is here, when I started working on cervix in the mid-1990s, cervix was the most common cancer among females. And breast was right afterwards. We've done a lot of good in terms of we're seeing that cervical cancer now is the fourth most common cancer among females. So we're seeing it drop in terms of its overall. Sorry, I'm having a hard time seeing the screen. So cervix is here. Is that correct? Okay. So okay. So I will look at this screen. So cervix is here. As you can see, it's the second most common cancer, but it used to be the first most common cancer. We've done some good, but I think as time has progressed, breast cancer has become more important. You can see it's the most common cancer in females in both more developed and less developed regions. So you can see here, breast is the most common. We need to do a lot more in order to better diagnose and screen and treat this cancer and to prevent it. Cervical cancer I'll talk to you more about, but you can see it's quite a big problem in the developing countries, but a relatively smaller problem in more developed countries. What are some other things that we can see from this particular graph? Well, we can see that liver cancer, which I think is here, wish I could see the. Yeah. Okay. I'm having a hard time seeing between the two, but in any case, I won't point anymore. So liver cancer, we can see that liver cancer is a problem in less developed regions. You can see, and a relatively smaller problem in more developed countries. And again, we have vaccination against liver cancer. We have vaccination against hepatitis B, and the coverage of the vaccine is variable in some regions, which may explain some of this differential. We can't, as you know, screen for liver cancer. There's some other interesting things I would just want to point out. As you look at down lower on the graph, skin cancer is more common in developed countries than less developed countries. That's probably secondary to differences in surveillance. And you can also see that stomach cancer further up on the graph has a higher incidence in the less developed countries as compared to more developed countries, and may be attributable to higher rates of H. pylori in less developed country regions. And lung cancer is a pretty big problem in both areas, as well as colorectal cancer. Looking at the data from men, we see very clearly that in terms of burden of incidence, that prostate cancer is the most common cancer among men. And this may be largely attributable to higher rates of PSA screening. We could have a lot of discussion about the benefits or the disadvantages of screening for PSA. I was on a panel recently when my co-speaker gave these slides of people punching each other, trying to figure out whether they should do PSA screening, and so there's a lot of debate right now in terms of PSA screening, but it does lead to higher incidence rates. You see that the mortality rates of prostate cancer are pretty similar in less developed as compared to more developed countries, perhaps slightly lower for prostate in developed countries. Lung cancer, as I've said, is a big problem in both more developed as well as less developed countries. It's the most common cancer cause of death in men in less developed countries, which is clearly not only a policy issue but also a behavioral issue that needs to be addressed. You can see here dramatic differences again between stomach cancer. You can see being much higher in less developed countries as compared to more developed. Liver cancer, again, very different types of patterns that we see in less developed as compared to more developed countries, and as well as esophageal. You see much more esophageal cancer in less developed as compared to developing countries. Some other small differences you see, again, skin cancer being more prevalent in more developed countries and less developed countries in terms of its overall incidence. And with many other cancers, slightly higher rates in less developed countries. But a lot of them look very, very similar, actually, in terms of their profile, in terms of incidence. So another thing that is not really an unexpected finding, and we've seen it also in our studies of China, is this phenomena of late-stage presentation. This is actually a study that was done and that was published in Cancer: A Global Perspective in 2009 that looks at the breast cancer stage in the U.S. as compared to Egypt. This is based on U.S. National Registry data with SEER, and you can see here that in the U.S., the majority of breast cancer cases are diagnosed early, and that's defined as in situ, localized, and as compared to late, which is just described as regional or distant. And in contrast, if you look at the distribution in Egypt, you see that most is late. And we also looked at similar data in our studies in China and found very, very similar patterns in terms of diagnosis being much later in the China breast cancer cases as compared to the U.S. breast cancer cases, which just actually shows the benefits of an effective screening program. So in terms of major risk factors for cancer and how they differ quantitatively in different settings, I just wanted to just point out the fact that tobacco is a relatively important cause of cancer in developed as well as developing countries. Areas. I've mentioned that infections are a bigger cause in developing countries, and you can see that mapping out on the incidence mortality. You see diet and nutrition being an important cause in both, but a relatively larger proportion in developed countries. But this dark blue areas is just, we should have a moment of pause and say, we really have a large proportion of cancer risk factors that remain unidentified. And that, I think, should be a really top-level research priority, is identification of these unknown risk factors for cancer burden, which would certainly help us in terms of our prevention efforts in the future. My favorite topic is the fact that infections are an incredibly important attributable cause of cancer. This is a story that was actually published by the BBC News Online, and it was also on the cover of Lancet Oncology in 2012, that says 1 in 6 cancers worldwide are caused by infection. And so I was quizzed about, what are these infections that cause cancer? I'm sure you know H. pylori and stomach cancer, hepatitis B, as I mentioned, and C, and liver cancers, and there's many other bad culprits in terms of this associations. I think as we move forward in time, we'll find other infectious agents that are going to be important causes of global cancer moving forward. This is, I think, a very hot area of future research. And, in terms of global priorities, I think as I was kind of looking through these data and very interested in trying to reduce mortality among middle-aged women, you look at the magnitude of a problem and what you can do about it, and that gives you your check for a priority. And if you're looking about, global cancer prevention, I think we can think about, as I've mentioned before, tobacco cessation should be really high on the list. Health style changes, there's a lot of research going on right now about the role of obesity in cancer cause and how we can actually think about prevention efforts through lifestyle changes. Very clear evidence on aspirin use. We should all be taking a small baby aspirin every day to reduce our risk of future cancer. Of course, vaccination against hepatitis B that I've mentioned and HPV are critical for prevention of cancer causing infections, and then screening. And I wanted this is one of, I think, a really important slide, and I wanted to go through it just to make sure that we all understood that, there are types of cancer that we know by research that we can really actually strongly recommend these types of screening to reduce death from cancer. We have evidence-based that these types of screening will reduce cancer. That includes breast, cervix, colon and rectal, and lung cancer among heavy smokers. And this is a relatively higher technology input. But for other types of cancer, I think we just want to make sure that we understand that these screening methods are in use or being studied, but their ability to reduce the number of deaths from cancer has not been clearly established. I mentioned the debate over prostate cancer and other types of cancer. So I think we have a real role that needs to be played in terms of developing novel, new diagnostic technologies in order to increase our ability to screen for other cancers. And really high on that list, I think, right now is oral cancer, but many other cancers that we need to figure out how to make a big impact. In terms of cervical cancer, this actually is a relatively dated slide, but I do like the fact that it has the same exact distribution now. And it will not change until we make better efforts to actually, number one, vaccinate, and number two, increase the coverage of screening. And so we need to really think about these areas that are highlighted, and mainly in the Southern Hemisphere, and how we can do more to increase the coverage of needed vaccination and screening programs. HPV is the primary cause. There's over 120 types of HPV, of which 40 infect the genital tract, and about roughly a dozen are high-risk types. But HPV is considered a necessary cause for cervical cancer. Kaposi's sarcoma is caused by Kaposi's sarcomic herpetic virus in nearly also 100% of those cases. HPV is very common, and you can see that as most cancer etiology, it takes 10 to 15 years to cause cervical cancer. There's a long time frame and many different things that will impact. We now have prophylactic data on prophylactic vaccination against HPV 16 and 18 for up to 8 to 10 years. But it's not clear that booster doses will be necessary, and the current generation vaccines are still underutilized among U.S. females and globally. We have some very good news in terms of cervical cancer prevention, and this hit the headlines several months ago, that a vaccine against 9 types of HPV that has the potential to prevent roughly 90% of cervical cancer has now been approved and will be rolled out in countries soon. This is a very, very exciting as we move forward in terms of our cervical cancer prevention platform. This is the most beautiful slide I have in my deck, which is the picture of what has caused this ability for us to revolutionize our cervical cancer prevention activities. It's a virus-like particle. These are self-assembling pentameres that are based on the late protein that self-assemble, that are not infectious, and that are used for the development of these vaccines, for intramuscular injection, for the prevention of persistent infections due to vaccine types and lesions that are caused by them. We did some systematic reviews of the literature, and these are the 7 most common types that we find in cervical cancer, and these are the types that are actually included in the current generation nine-valent vaccine. It includes these 7 high-risk types, as well as 2 low-risk types against genital warts, HPV type 6, and 11 against genital warts. And so this vaccine will improve on our ability to prevent. The current generation vaccines prevent 70%. Now we'll be able to prevent roughly 90% of infections. There has been an issue in our marketing strategy. We have to talk about vaccination prior to first sexual life exposure, because we want to actually vaccinate young girls and boys before they become sexually active. And then on the same time, we want to turn around and say, well, this is not a vaccine that has to do with sexual activity. So I think as we move forward in our prevention efforts, we know the vaccine prevents many types of cancers, including cervix anal cancer, vaginal vulvar cancer, penile and oropharyngeal cancer. These fractions for the non-valent vaccine that you can see here in terms of prevention potential are very similar to that of the 16 and 18 vaccine, because 16 is really the primary type that causes these other types of cancer. So these are really driven by HPV type 16. In comparison, cervix will see roughly a 90% protection potential. So I think that as we move forward, we're changing our message a lot around how we think about promoting HPV vaccination. And in this efforts, we are talking a lot more about HPV vaccination being for cancer prevention. The new CDC materials are actually talking about HPV vaccination as a cancer prevention tool. And then furthermore, if you want to learn more about HPV vaccination, there's a very nice slide set called "You Are the Key to Cancer, Cervical Cancer Prevention," and I can be happy to send it to anyone. It's a wonderful slide set that the CDC put together on cervical cancer prevention that is extremely helpful in walking you through all of the important aspects of the vaccine. So I just wanted to close my talk today just to remind ourselves about the lack of screening in many areas of the world. Last year I went into a more detailed talk about screening, and just to remind us that if we are thinking about moving forward on global prevention activities, we really have to think about HPV testing. And I think that we have our alma mater pap smear, which works very well. But I think as we move forward, we have to really think about HPV testing, which is a very, very highly sensitive test. And that is going to really improve our ability to do once-in-a-lifetime screening in global populations. And furthermore, I think we can move away from the pelvic examination table to self-collection. Self-collection will allow us to actually move the technology out of the bench into a woman's own hands to collect, for us to be able to scale up prevention activities in many countries and triage populations into those that are negative, that have very low risk for future disease, that don't that have kind of finished that current cycle of screening and won't need to be screened for at least 10 years, as compared to those that are positive that need a follow-up. Thank you so much.
Thank you. We need to do a little technical switch. We need to get our captioning going. So I'd actually like to ask Dr. Smith and Dr. Palafox, while we're doing that, perhaps you could address a question. Are they able to answer the questions up here? Sure. Maybe, Neil, you could come up. While we're doing this switch over to our captioning, I would just like to ask you a question that intersects with your two presentations. Neil talked about the importance of policy and health systems, and the lack of health systems in the Pacific, particularly to be able to deal with cancer in terms of mammography and other large, expensive technological infrastructures that are required. I'm wondering if the two of you could comment a little bit about where the technical innovation potential is with respect to particularly cancer, since it's an intensive, technology-intensive disease, and we know that small island nations and other countries can't afford the technologies or sustain the technologies. Where's the intervention potential?
So, at least relevant to the Pacific, and should I go to?
If you can, he'll be doing something around you, but.
So, relative to the Pacific and what where I work, I think one of the things about technology is that it goes through different stages. But I think sometimes you need to use appropriate technology for resource-limited settings. So I think, for instance, as was mentioned with lung cancer screening, that's even a debate in the United States about using, advanced CT scanning and helical scanning and so forth. But sometimes the technology, for instance, with cervical cancer screening, there's visual inspection with acetic acid, which is in many U.S. circles now is poo-pooed because there's more advanced technologies. And then they put in the pap smears, which they're finding out doesn't work well in these settings. So I think it's really working with understanding what technologies, even if they're not considered advanced, still work, and then applying, the maybe what's the more basic type of technologies that can be employed in these areas. And then also one of the things we did in the Pacific was we actually changed the standards of healthcare. So before it was required that women had pap smears, but we found out it couldn't be actually put in place because there's too many steps to pap smears. They had to send the pap smears off island. They couldn't track them. They couldn't pay for them. So the new technologies are actually more practical, the ones that were just talked about by Dr. Smith. So I think it's really looking at appropriate technologies, the amount of money that you can invest. And in fact, there's many technologies that are older technologies, if you do it well, can be almost just as good.
I think it's an excellent question. Thank you, Tim. When we are trying to increase, for example, HPV vaccination, I think that we can think about integration of, for example, mobile app reminders. And I think, though, the struggle in that particular, we can also use the text reminder system for cervical cancer screening in terms of recall if we can't do a one-time shop, see and treat on the same day screening program. I think that the real struggle is how to get those technologies accessible on applications that may not be smartphones. Because I think if we really want to get the technologies used, it has to be on phones that people actually are using that may not be the highest tech Android or smartphone in some of the communities where I work. And the issue also becomes an issue of, even with the texting, an issue of cost to the participant. So we do a lot of work with underserved women in the US and also in Kenya, and we are working to integrate some of this technology to do recall in our screening programs and also in our vaccination programs. And one of the, it seems obvious, but one of the real obstacles we're having is women either don't have the phone that we want them to use for some of the more exciting technologies, or they don't have the minutes to actually be able to spend, they don't want to use their minutes. And so I think I'm trying to think about how we think about technologies. And I think that we're working a lot on self-collection. I think it's really exciting. I think that we need to really get input from providers and from communities about the acceptability of self-collection. We have a lot of that data that tells us very acceptable. But the real challenge is getting people back for that second dose, or back if they have HPV result and we don't have a secondary, we don't have a mechanism to do we don't have a point of care HPV test right now. So trying to get, until we have a point of care, which we need desperately, a point of care HPV test, we often are in the situation of trying to have to recall people back when we want to use this exciting new technology. And I'm working with a group at Duke, Dr. Nemi, who's developing a very, very interesting, innovative digital colposcopy, handheld colposcopy device that might help to do the secondary screening at the primary level, even by a woman herself. But I think we have to wait as these new technologies develop and make sure the cost goes down, so that these new technologies can actually really be used, particularly in the underserved areas that we want to reach, to really make an impact on cervical cancer. Otherwise, we're just still in the higher levels of healthcare provision. We need to really get down to the levels of provincial and all the way down, so we can actually really have these technologies be used where they're most needed.
Great, thank you very much for that preview of what our questions may focus on when we get to that part of our agenda. So are we ready with our captioning? Great. So thank you very much. We'll carry on here. So next, I'm very pleased to introduce Dr. Mehran Massoudi. Dr. Massoudi has extensive global health credentials, having served in Afghanistan with the Ministry of Health on an assignment from the CDC, and also having been deployed to West Africa working on Ebola, and also working through the immunization program and other programs at the CDC. Dr. Massoudi is the chief of the Applied Research and translation branch of the Prevention Research Center's program at CDC, and he directs the program there. So he provides our spiritual guidance to our coordinating center here, the Global and Territorial Health Research Center. And we're very pleased to welcome him today, where he'll be talking about Zika and health diplomacy. Welcome.
Thanks very much, Tim. And again, I wanted to welcome everyone here on behalf of the PRC program. I'm delighted to be on the panel here with all the distinguished speakers. I think that as far as looking for the credentials and a number of people with expertise, I think they needed somebody with the uniform, so I picked that particular role. Which one of the... There, okay. All right, so I am different from other speakers, have a disclaimer slide that says the findings and conclusions in this presentation are those of the author, me, and do not necessarily represent the official position of the Centers for Disease Control and Prevention. We could be stuck in this loop for, there, okay, great. So unlike the previous presentation that went to very much in depth by the subject matter experts, I'm going to be covering this on a very high level. I know that later we have a session devoted to Zika virus, and we have some world experts here today. And I'll talk about global health diplomacy and our efforts in terms of U.S. government, and give some examples from CDC with the global health security, and talk about how best we can respond through trained and prepared workforce. So on January 22nd, CDC's Emergency Operations Centers was activated and went to a level 1, which is the highest activation level, on February 8th. So to give you a perspective as to Zika virus disease in the US, as of April 13th, total 358 cases, and of those 31 pregnant related, 7 sexually transmitted, and among the US territories, 475 total, and 58 related to pregnancy. So here's a distribution of the map of the US and also the territories, so you can see the widespread reporting of disease across the country. And again, this is showing a world view and looking at where the Zika transmission is taking place. And so some of these girls you've seen before, the mosquitoes that are carrying the vector, serve as the vector for Zika, as well as dengue and chikungunya. Of the two, the Egypti is is better at transmitting the disease. They lay eggs in domestic water holding containers and live in and around households. They're aggressive daytime biters, so some of the prevention efforts, such as those commonly used for West Nile virus, may not be as effective. So in terms of other modes of transmission, maternal fetal has been shown both intrauterine as well as perinatal, and others, so sexual transmission has been shown, blood transfusion, laboratory exposure, and theoretical risk from organ or tissue transplantation as well. Zika virus was first isolated from a monkey in Uganda in 1947 in the Zika forest, thus its name. Before 2007, only sporadic human disease cases were reported from Africa and Southeast Asia. In 2007, the first outbreak of Zika was reported in Yap Island, one of the federated states of Micronesia. So, of course, we heard earlier speaker. On 2013 to 2014, more than 28,000 suspected cases were reported from the French Polynesia, with subsequent outbreak reports from other Pacific islands. In May 2015, Brazil reported the first locally acquired cases in the Americas. Currently, outbreaks are occurring in many countries or territories in the Americas, including Puerto Rico and U.S. Virgin Islands. And further spread to other countries in the region is likely. So, All right. Thus far, local transmission of Zika has not been reported in continental U.S. Since 2011, there have been laboratory-confirmed Zika virus disease cases identified in travelers returning to the U.S. from areas with local transmission. With current outbreaks in the U.S., cases from among U.S. travelers will most likely increase. Imported cases may result in virus introduction and local spread in some areas of U.S. with appropriate vector and ecology. Unfortunately, there are no vaccines or medications to prevent infection or disease. The primary prevention measure is to reduce mosquito exposure. CDC issued travel notices advising pregnant women to consider postponing travel to areas with ongoing Zika virus outbreak. Data on pregnant women infected with Zika virus are limited. The limited data available do not suggest that pregnant women are more susceptible to Zika virus. Pregnant women can be infected with Zika virus in any trimester. However, the incidence of Zika infection in pregnant women is not known. And there is no evidence to suggest that pregnant women experience more severe disease during pregnancy than non-pregnant individuals. Because there's neither a vaccine nor any medication available to prevent Zika virus infection, CDC recommends pregnant women in any of the trimesters should avoid postponing travel, should postpone travel to any Zika virus transmission where it's ongoing, and as well work with their healthcare provider and follow strict guidelines that they have placed for her. So in 2015, the Brazil Ministry of Health reported a substantial increase in the number of babies born with microcephaly. However, the true baseline of microcephaly incidence is unknown. Zika virus infection was identified in several infants born with microcephaly, including deaths and early fetal losses. Some of the infants with microcephaly have tested negative for Zika virus infection or been attributed to other cases or other causes. The incidence of microcephaly among fetuses with congenital Zika virus infection is unknown. So here are some images of infants with microcephaly. To give you a sense of what the increase in rates of microcephaly, these are two maps comparing the rates in the Americas and the Caribbean from 2010 to 2014, with those in 2015. The smallest purple dots represent rates of 1 per 1,000 live births, and the largest purple dots represent rates from 45 to 89 per 1,000 live births. So in summary, Zika virus continues to circulate and cause locally transmitted diseases in the Americas. Healthcare providers should consider the possibility of Zika virus infection in travelers with acute fever, rash, arthralgia, or conjunctivitis within 2 weeks after return from an area where Zika virus transmission is ongoing. Reports out of Brazil indicate a substantial increase in the rate of congenital microcephaly, and studies are underway to help characterize the relationship. Pregnant women in any trimester should postpone travel to areas with Zika transmission. So in terms of CDC activities and plan, this is what CDC does best, and that is coordinate responses with other partners, including PAHO, and assist with investigations of side effects and attributable cause associations, microcephaly and Guillain-Barré syndrome, and continue to evaluate and revise guidance as new data become available, and then to also distribute guidance through healthcare health advisories, MMWR publications, and the CDC website, and then to communicate regularly with physicians, professional organizations, and state and local partners. So I'll turn next to global health diplomacy. So this is the definition from the World Health Organization. It brings together disciplines of public health, international affairs, management, law and economics, and focuses on negotiations that shape and manage the global policy environment for health. The relationship between health, foreign policy, of course, from the first speaker that we heard, and trade is at the cutting edge of global health diplomacy. So again, data-driven, building capacity, maximizing impact. I'm sure everyone here knows the U.S. Secretary of State, Mr. John Kerry, is the #1 diplomat in terms of U.S., so I'll stop there in terms of Department of State activities and turn to our department, Department of Health and Human Services, Office of Global Health Affairs. At core of the OGHA's work is the intersection of public health, foreign affairs, fostering and maintaining critical relationships with international organizations, foreign governments, and ministries of health, and representing U.S. in key negotiations to advance policies that protect and promote health worldwide. The collaborations also demonstrate the goodwill of the American people on a global stage. And of course, as we all know, there are challenges and strong disagreements in many international matters. However, when it comes to health, there's a broad consensus that nations must work together. So in terms of the global health security agenda, this is an effort among U.S. government, other nations, international organizations, and public and private stakeholders to accelerate progress toward the world safe and secure from infectious diseases. And coming to the mission of CDC, again, working around the clock to protect America from health, safety, and security threats, both foreign and in the U.S., whether disease start at home or abroad, are chronic or acute, curable or preventable, human error or deliberate attack, CDC fights disease and supports communities and citizens to do the same. I think this slide will summarize very well where we are in today's worldwide travel. So a health threat anywhere is a health threat everywhere. So again, with the world travel that we can see here, no country can work on its own. Needs help from everyone. We've seen over time that global health risks have increased through the emergence of new organisms, drug resistance, and international events. HIV raged undetected for over a decade. Drug-resistant organisms, including TB, are a growing public health threat. In 2001, targeted mailing of anthrax spores drew the world's attention to the reality of international release of dangerous pathogens. In 2003, SARS spread to 37 countries across 3 continents in only 4 months. The more recent emergence of Middle East respiratory coronavirus, MERS, the Ebola epidemic in West Africa, and now the emergence of Zika virus in the Americas have kept the world on high alert. So international health regulations, there was some discussions about setting a goal by 2012 to see the world, the countries to be prepared to respond. But by that time, only 20% of the countries were deemed as meeting the goal. And with an extension of 2 years, that percent only went up by 10. So altogether, only 30% of the countries are currently fully prepared to detect and respond to an outbreak. So let me talk about some CDC examples as it relates to the global health security. So why do we care about global health security? So as we talked, diseases spread and faster and farther. Not being prepared, as we saw, at least 70% of the countries are not prepared, and a huge economic impacts. SARS, over 40 billion, Ebola, nearly as much. President Obama, during September 2011 speech to the UN General Assembly said, and we must come together to prevent, detect, and fight every kind of biological danger, whether it's a pandemic like H1N1, a terrorist threat, or a treatable disease. Nope, I'm going backwards. I'm not going to put you through this again. All right, so that's where the global health security agenda comes in. And so preventing avoidable catastrophes with detecting the threats early and responding rapidly and effectively. And these are the 4 departments in the U.S. government, U.S. Department of Health and Human Services, Department of State, including U.S. Agency for International Development, Department of Defense, and Department of Agriculture. So I was here last year talk about Ebola and the West Africa response from CDC, And again, as we talked about that, in December 2013, Ebola emerged for the first time in West Africa. Cases crossed the border from Guinea into Liberia and Sierra Leone and spread unnoticed for months. It quickly became the world's largest Ebola outbreak in history and world's first Ebola epidemic. Previous Ebola outbreaks had been controlled quickly. So what was different this time? The three countries lacked public health infrastructure to quickly detect and respond to the outbreak. There was delayed reporting, and border control was spotty in areas with high population mobility. And there was a lack of infection control in healthcare facilities, including absence of basic protective gloves, soaps, and running water. By late July, Ebola had reached densely populated capitals in all three nations, the first time the disease caused widespread transmission in crowded metropolitan areas. So I'll give an example of a success story that was hidden within the response, and that is how Nigeria responded. They identified 894 contacts and completed over 19,000 contact tracing visits, implemented a social mobilization strategy that reached 26,000 households, and they established an Ebola treatment unit in just 2 weeks. And as we had seen, Ebola, with only two elements of, I didn't go into this detail, but Global Health Security Agenda has a number of items that folks must have, and Nigeria only having two of them, and that was an emergency operations center and a trained workforce, they were able to contain a potentially disastrous epidemic. So let's now talk about some of the other successes as it relates to global health diplomacy. Smallpox, last endemic case 1977, eradication certified in 1979. These hospital wards, iron lung, are a thing of the past now, but they were prevalent during the height of the polio outbreak. So in 1988, World Health Assembly resolution sought to rid polio of the world by having being it headed by national governments with 5 leading partners: World Health Organization, Rotary International, CDC, UNICEF, and Bill and Melinda Gates Foundation. And so here's wild polio cases worldwide, 1985 to 2014. As you can see, the 1988 World Health Assembly resolution to eradicate polio by 2000, cases were over 300,000 worldwide. By 1991, Western Hemisphere was last isolated the wild polio virus, and in 1999, wild polio virus type 2 was isolated. And so the success goes on. 4 regions of WHO have been declared polio-free: the Americas, Western Pacific region, Europe, and most recently Southeast Asia, and 3 countries remain that are still endemic in population: Pakistan, Afghanistan, and Nigeria. So we have to remember the legacy of polio, and that is that over 13 million cases of polio have been prevented, more than 650,000 deaths from polio have been prevented, more than 1.5 million deaths prevented by administration of vitamin A during the polio campaigns. And by 2035, it's estimated that $40 to $50 billion have been saved. So the way we try to protect the world as part of the global health security is through what CDC is doing, is training and having a prepared workforce. CDC needs a capacity to surge trained and prepared staff faster to global public health and emergencies, composing folks with skills in epidemiology, coordination, management and operations, logistic, health communications, etc. What is CDC's Global Rapid Response Teams? These are agency-wide assets. They're US-based, and they're 3-tiered structures designed to provide 50-plus CDC staff on call at any given time. So we have one that is a core team, dedicated staff working in the area, fully ready, trained. 17 of those teams are based in Atlanta, 5 overseas. Tier 2 is 10 to 15 staff on call, routinely work in international emergencies, and are subject matter experts in emergency in public health emergency response. And 3 is the surge, tier 3 is surge capacity, and this is agency-wide roster, and there are 40 on call at any time on a variety of skills and expertise, and together all 3 comprise the global rapid response team. So I'm getting the time, and so I'll go to closing remarks. Global health diplomacy matters. I hope that you've gotten a glimpse of what's important, and that is people cannot achieve their potential or contribute to economic growth when their health is poor and they lack access to health systems. And also, second most important point is that living up to promised commitments, which is key to global health diplomacy. And then I'll leave you with one quote from Maya Angelou when she said, "I've learned that people will forget what you said, people will forget what you did, but people will never forget how you made them feel." A very important quote as it relates to global health diplomacy. Thank you.
Thank you again. We'll have questions and discussion in a few moments at the end of this session, where all of our speakers can come together. So we're going to move on to the next speaker. We need to do a little switch on the phone so we can get our captionist correct. But as they're doing that, I would like to introduce our next speaker, who is Per Pinstrup Andersen. He's currently Professor Emeritus and Professor of the Graduate School at Cornell, and was most recently the Babcock Professor of Food, Nutrition, and Public Policy, the Thomas Clark Professor of Entrepreneurship, and the Professor of Applied Economics at Cornell. He also headed he was chair of the Science Council of the Consultative Group on International Agricultural Research, and is past president of the American Agricultural Economics Association. Dr. Pinstrup Andersen will be speaking to us today about mobilizing food systems for improved health and nutrition. Dr. Pinstrup Andersen, please. Thank you. You may need the slides.
Perfect. Thank you very much.
Maybe one you can advance.
All right.
Thank you very much for inviting me to discuss with you how to mobilize food systems for the benefit of health and nutrition. This is something that has been discussed a great deal lately. We have lots of flow diagrams that show the interaction between food systems and health and nutrition. We have lots of suggested pathways, we have lots of recommendations, and we have very little implementation. It still stays on paper. We now have to move to implement all these wonderful recommendations, or at least test them to make sure they are correct. What I'm going to talk about over the next 20 minutes, I'm going to very briefly list the competing goals in the food systems. In other words, if the food systems were aimed exclusively at making sure everybody was well fed and healthy, then we wouldn't need to talk about it. There are many other goals, many of which override the nutrition and nutrition goals. So I'm going to talk about that a bit. Then I'm going to talk about the drivers of these food systems that, if we can manage to change them, would improve health and nutrition. I'm then going to talk briefly about the stakeholder groups who are actually making the decisions in this business, because that is where we need to move towards. So we understand why are the decisions being made as they are, and how can they be changed for the benefit of health and nutrition. Then I'm going to end with a set of illustrative areas of action focused on a food value chain. I'm not going to finish that list. I'm going to go as far as I can within the 20 minutes, but the PowerPoint will be available to look at those I don't manage to cover. Before I start on that outline, let's make sure we keep in mind 3 things. Challenges, if you like. Deficiencies, whether that's dietary energy or nutrients, combined with infectious diseases caused in part by unclean drinking water, poor sanitation, poor hygiene. Secondly, overweight, obesity, and related health issues. And third, the health of the ecology. Those are the three key challenges that we need to keep in mind as we move ahead to change the food system for health and nutrition. So here are some of the goals, and there are presumably many more. Food security and good nutrition. Yes, anybody in this business would agree that we need to have a food system that assures food security and good nutrition for all. But they also want efficient and sustainable resource use. And they also want reasonable incomes for farmers and agribusinesses. Some would like unreasonable incomes. They want reasonable prices for consumers, meeting non-food demand, biofuel, cotton, cut flowers, and so on. And of course, the agricultural sector in low-income countries is very important to support general economic growth. So the question is, which of these goals are going to override the others? And can we come to some kind of a trade-off among these goals so everybody can be happy? If we can manage to do that, let's send the recipe to Washington or to the presidential candidate so maybe they can find a way of all becoming happy as well. In the meantime, here are some of the drivers that are mostly related to health and nutrition issues. Food price changes. Right now, dietary energy is inexpensive. Nutrients, particularly micronutrients, are expensive. So what do consumers do? They buy, to a very large extent, empty calories. And we know where that's getting us. And that's the consumer demand part. We have an unholy coalition between the producers of empty calories and the consumers who want them. How do we break that link? If I talk to the food processors who are putting in oodles of high fructose corn syrup, sugar, fat, and other inexpensive calorie sources into the ultra-processed foods, they tell me that that's what the consumer wants, that's how they can make money, so that's what they have to do. I talk to the consumers and they say that's all that's available or that's all we can afford. We need to break that two-way causal link. Government price and subsidy policies can contribute to improved health and nutrition, or these policies can make matters worse. Again, if you subsidize those raw materials, such as corn, from where we get high fructose corn syrup, we are in fact making corn syrup less expensive than it would otherwise be. And there are, of course, many, many other examples of that kind. Now, governments, of course, are not trying to make life miserable for us. It's a matter of where they focus their attention and which goals they try to achieve. Economic growth, urbanization, and globalization, yes, of course, income is very important. Poverty is a major cause of deficiencies. And in high-income countries, it seems to be a major cause of overweight, obesity, and chronic diseases as well. I already mentioned the increasing role of processed foods that may have very few micronutrients and lots of calories. We need to look at the agribusiness market power. Where are they taking the food system? Are they taking the food system in the direction we want to go? Those of us in this room, and presumably everybody who has taken time out to listen to this. Or are they taking us in a different direction? Yes, we know what's driving them. And there's nothing wrong with that in a market system. Profit is driving them. The question is, can we combine profit goals with health goals? My answer, yes, we can. But we're doing a lousy job at it. Research and technological change. Agricultural research throughout the world, whether it's in the United States or elsewhere, is prioritizing stable foods, producing more calories. That's Priority number one for a very large majority of the agricultural researchers around the world. We need to reduce the unit cost of production of calories so that the price of food can become lower so that more people can get access to it. That's absolutely wonderful. But why don't we make at least a slight change towards reducing the cost per unit of production of micronutrients? Remember, 2 billion people are probably short of micronutrients. We don't know the exact number, but it's a very large number. More than half of the Indian women are iron deficient. Many of them suffer from iron deficiency anemia. Many children suffer from this. Around the world, micronutrient deficiencies are an extremely important health problem, yet we continue to focus on our agricultural research to produce more calories at a lower price. More nutrients per unit of land and water. Why couldn't we make that the goal for future agricultural research? We're producing biofuel, we're producing cotton, we're producing cut flowers and coffee and a whole bunch of other things, which of course take resources away from food production. Right now that's not a problem because food prices have dropped by 50% during the last 3.5 years. We have oodles of food, we have an immense amount of food out there. Unfortunately, we also have a very large number of people who don't have access to it. But producing more food, unless it's done in the right places, isn't really going to improve health. But back in 2007 and 2008, when food prices skyrocketed, it did matter that we took a lot of land and water out for biofuel production. Climate change, of course, it's a joker in this whole game. We don't really know how climate change is going to influence health and nutrition through the food system, but we know we have to begin to prepare for it. We have to be able to adapt because there's very little political support for mitigating the effect. Let's just wait until we see how bad the problem is. Well, that may be very late. So let's get ready to adapt. And there are a number of policy interventions that can be done to do that. So if we are to set action priorities, we need to decide whether they should be preventive or curative. Do we want to focus on helping those people who suffer today, or do we want to try to make sure that there will be fewer people in the future that will join the group of malnourished and unhealthy? Do we want to change the behavior of people or the agents or the environment within which they make their decisions? Very important decision as to which of these two we want to modify. And now this is taking on a life of its own. Let's see. Okay. So food security that we talk a lot about is really nothing but access to a healthy diet. That's really what food security is all about. But if we are interested in health and nutrition, we also have access to clean water, good sanitation, we have access to nutrition and health knowledge, and women have to have access to breastfeeding, childcare. Those are the things that come together to help us have good nutrition. As I mentioned before, the profit motive is probably going to override the nutrition motive among decision makers in the private sector. Couldn't we develop win-wins? Yes, I believe we can. And even if we can't, we need to look for trade-offs that are acceptable to the relevant stakeholder groups. One of the problems is uneven power structure that the previous speaker talked about. There are basically three things that governments can do. They can provide incentives. It would be good for you to do this. They can regulate, you shall not do this, or they can provide more knowledge. Now here's the thing when we start talking about designing action. Good action is context specific. We cannot sit in Rochester or anywhere else and design solutions for the rest of the world. These things are context specific. That's why what I'm going to do towards the end of this is to give some illustrations of things, but certainly nothing concrete that has to be done tomorrow unless we have a specific context we can refer to. Here are some of the stakeholder groups, and you can divide those up into subgroups and so on. Governments, of course, have different units, and they frequently operate in different directions with different sets of goals. Agribusiness sector, I talked about. We got different citizens groups, civil society groups. Some are advocates in advocacy groups, others are doing other things. We talked about the international agencies earlier today. Some are wonderful, some sounds like they're not quite so wonderful for health and nutrition. Wouldn't it be nice if we asked intended beneficiaries, what would they really like to have? No, we're not going to do that because they're not really very smart. So we tell them what they should have, and if they don't do what we say, they don't comply. That's the wrong approach. That's really the wrong approach. We need to understand what the intended beneficiaries want, what they can accept within the environment with which they work. Farmers and consumers, again, play their subsequent roles. Now let me just show a few illustrations of areas for health-sensitive policy interventions, and I'm going to use the food value chain as the skeleton or the foundation. But I want to make one point here. Food value chains are commodity-specific and based on the economic value of the food as it moves up the chain. Why don't we change that and talk about the nutrition value chain? Why, if we are really serious about nutrition and health, we ought to talk about what's happening to the raw material that comes from the farm, enters into storage and transportation and processing, the supermarket, and to the consumer. What happens to the nutritional value of that? The economic value usually goes up, or the commodity stops. The nutrition value can either go up or down. And I think I've given you some illustrations of that. Farmers can produce absolutely wonderful stuff, which we really need, but by the time we get it, it's not what we need. So let me give a few illustrations. I still have a couple of minutes left. If we look at the natural resources and inputs, we can improve water management systems to avoid waterborne diseases, clearly. We can improve the quality of drinking water to reduce the risk of infectious diseases. We can add micronutrients to the soil, for example, zinc and iron, which would increase the micronutrient content of the commodities that are produced and therefore help reduce the deficiencies in human. We can control interaction with wildlife to reduce the risk of zoonotic diseases, a very important issue. As I'm sure you all know, more than half of the diseases humans suffer from actually have their origin in animals. Looking at farming or the primary production, we can promote increased productivity and production diversity through research and policy. I talked about that. More nutrients per unit of land or more calories. We have a choice. Research and incentives to develop and facilitate adoption of biofortified crops. Building into the seed the micronutrients that people need into those seeds that produce the food commodities that poor people can afford to buy. For example, some of the grains, some of the pulses, some of the things that poor people can afford to buy and need. We can also, of course, fortify industrial in an industrial way, and that would be under processing, which I won't get to, but it's on the overhead. We should enhance gender-specific productivity and activities traditionally undertaken by women. Study after study in developing countries show that one, if not the most important limitation to improving nutrition among low-income households in low-income developing countries is lack of women's time. Yes, it is also lack of income. but lack of women's time is an extremely important component. We need to strengthen the gender equality in production decisions. If women are doing most of the agricultural work, they probably know more about how to do agriculture. Yet, if only men are being informed about how to do agriculture, we've got a bit of a schizophrenic situation. We need to improve the interaction between humans and animals. Again, it has to do with the zoonotic diseases. We need to introduce labor-saving technology and production practices in households with HIV/AIDS affected members. And let me just do the last one. We need to improve sanitary conditions in the production process. I'm just going to skim through these. We have a number of areas we can work on in transportation, storage and exchange, in processing, secondary production, transportation, storage and exchange, consumption, and I'm going to go through these real quick. They are on the overhead, but if I don't stop now, something really terrible is going to happen to me. So thank you very much for your attention.
Thank you very much, and fear not, we're nice people, so, though we do have a schedule, so, but we are looking forward to the panel discussion in just a few moments. I'm very pleased to be able to announce our next speaker, who also hails from Cornell and crosses several of the disciplines that we've talked about today. Dr. Saurabh Mehta is a physician who has worked in nutrition, infectious disease, and global health epidemiology, and he does a lot of interesting stuff in terms of technological innovation. So I'm not exactly sure which he's going to produce today, but he's got toys and equipment, and last year he did as well, so we're looking forward to seeing what he brings us today. So Dr. Mehta will be speaking on global health and technology, new solutions for development. Welcome.
Thank you so much, and thank you for that introduction, and thank you to the organizers again for inviting me this year. Can everyone hear me? Okay. I'll try and stay. I'll usually walk around a little, so I'll try and stay in one spot. And thank you for all the wonderful talks this morning. I think I can be relatively quick because the groundwork for a lot of things that I'm going to present has already been laid out for me, and I don't really want to stand in, between you guys and coffee or the coffee break. I believe that's a coffee break after this talk. Okay, so last year I've just focused on diagnostics. I'm going to talk a little bit about how we have been able to integrate technology in most of our work internationally and where we are coming from. So basically, the idea, let me start with the research focus on my group. My group focuses on identifying, diagnosing, and intervening on modifiable risk factors to ensure optimal nutrition and health. And it's basically most of the technology work that I'm going to present has been borne out by our own needs for things that we have needed, solutions that we have needed in our own work internationally in these settings. And before I continue forward, for us to be on the same page, what are modifiable risk factors? And the cartoon here, for those who can't read in the back, I need some medicine for an infection I'm going to get next week. So medicine or something else. And why we care about modifiable risk factors. This is not an international one, but we can easily substitute something for a global burden of disease. But this slide came out from a nice paper in JAMA earlier this year, which shows the top 10 causes of death and risk factors in the United States. And if you look at the top 10 risk factors, and this kind of explains why I'm in nutrition with my background, you can look at 50% of those risk factors have got something to do with nutrition. So dietary risks, BMI, glucose, cholesterol, low physical activity, and if I have to be generous, or if you will allow me to be generous, I will also include blood pressure in there. So, but that's the risk. Those are the kind of risk factors. When I say identify, diagnose, and intervene on modifiable risk factors, that's what we are trying to do. So in practice, what this means is that the elements of my research program include, on the identification side, surveillance. And we have surveillance projects at our field sites in India as well as in Ecuador. And currently we are working in 3 sites in India, 1 site in Ecuador, and also in partnership at a site in Kenya. For diagnostics, then we are looking at what I'm going to talk about, and I gave a glimpse of that last year as well, is our inventions, what we call the cornal Nutriphone, and then we also have a cornal fever phone. We just got an NIH 1 for that. And then some of the surveillance work also leads to identification of novel biomarkers. The interventions are both clinic-based and community-based. We have trials such as a vitamin D and TB trial going on at our field site, which is a clinic-based trial, but then we also have community-based or sustainable agriculture-based interventions, and we have a couple of biofortification trials going on in the urban slums in Mumbai among infants. So I don't think I need to really justify why we need surveillance after the excellent talk this morning. But this is the location of a living lab. It used to be an old TB sanatorium. Now it's a general hospital. It's 2 hours outside Bangalore. Bangalore is a big cosmopolitan hub in India, but you travel 2 hours outside and it's you feel like you have been transported maybe 50 or 100 years back in time. So it's a very rural area. It's the people that we are following up is a population of about 75,000 people living in 10 to 12 villages around this hospital in the catchment area. And are basically the way we look at a living lab, we have 4 components. One is the surveillance, then capacity strengthening, training of local field staff, and then also ability to do trials when we need to. I had this slide to justify surveillance because I just was on the WHO guidelines committee for Zika virus infection, and we have a paper on that coming out hopefully next week. So I had some of these slides ready justifying why surveillance is needed, but Dr. Masoodi already did an excellent job, so I don't really need to add that. But this was one quote that we had used, which is an effective response requires international surveillance that is led and guided by organizations like the CDC and the World Health Organization that ascertains a need to act and has the capacity to implement immediate action. But a lot of this can be done if active data collection systems are not in place or active surveillance systems are not in place. So one example one of how we have used technology in this context is to solve one of these problems. So you go to any of these sites or any old hospital, you'll have these massive paper records. So what we have done at our field site is eliminated the need for paper records with an electronic system. We built this system to be used on tablet devices, and that's what we exclusively use in pretty much all of our research studies. And this information system, let me see if this will play off here, but basically somebody can come, I should stay here. All right, somebody can come in and we can do informed consent forms. For those of you who don't know, in India, for example, if you have to do any kind of clinical trials, you need audio-visual consent forms. So we can record their audio, we can record video, and so on and so forth. And all this, the system is built in place. It gets uploaded in real time to a third-party server that people in India, people in the US, or the investigators or the key personnel anywhere in the world can access. And I can even, actually on the iPads that we have been using, I can turn on the camera remotely and even see if somebody is like sitting under a tree filling out this data or actually interviewing people in the field. But that's I thought that would be invasion of privacy at the IRB level, but the IRB for some reason loved that idea when I mentioned that. So this is just an example. There are lots of solutions, but this is something that we have built in-house just to be able to capture this data, but also helps us trigger some of these things. So we have an SMS system, which was also mentioned earlier this morning. We have an SMS system. It's not an SMS system, basically. It's an emoji system, to be real. My graduate students, for some reason, really love emoticons. And we track the number of emoticons that are used in every message between the team. We have a separate solution for messages so that the team I don't miss mails from my team, so we don't use email. But I can track the number of words and the number of emojis. Number of emojis usually outnumbers the number of words that are used in those messages. So we have this system, which is basically to remind people that triggers based on if somebody misses a visit. Nobody has to manually do it. It automatically triggers an automated text to them, and they don't have to pay for it. It gets paid on our end, and they are really inexpensive third-party solutions now available to do that. And we can do that from here. We can do that in India. And so those are some of the motivations for building this. The second piece is, again, biofortification, like Pierre already mentioned. It's also the use of technology. It's a technology to increase the amount of micronutrients that are present in different grains. So the problem, as was already highlighted, particularly in India, malnutrition is really widespread. Most estimates peg malnutrition as a cause of 40 to 50% of child deaths worldwide every year, directly or indirectly. So our interest is in looking for sustainable solutions rather than delivering nutritional supplements to everyone. And we think that biofortification might be a possible solution. So we are testing it out in 2 efficacy trials in the urban slums of Mumbai. So one of them is going to be among 700 infants, 700 12-month-old infants. We are going to follow them up for 9 months. We are going to feed them 3 times a day with biofortified food, and we are then going to look at things like growth, their nutritional status, and look at some of the we are going to look at cognition. We are going to also look at their immune function, and then secondary things that we are looking at are things like microbiome as biomarkers of disease risk or immune response. The first trial in that is going to focus on pearl millet with higher levels of iron and zinc, about 4 to 5 times higher levels of iron compared to conventional crops. And the second one is going to be a combination of pearl millet, wheat, lentils, and orange split sweet potato. So we want to deliver about 70% of the requirements of vitamin A, iron, and zinc through a food-based solution. The third example is diagnostics. And I had started talking about this last year, but then I had prepared a much nicer update for this year, but then I realized I'm going to be recorded. And I can talk to you as a side conversation about some of the work that has been going on, but some of this work is more than now 6 months old. So I can't really present what's currently on our plate. Sorry about that. The context, of course, is that especially when we talk about precision nutrition or what biomarkers to measure, there has been a lot of work that has been done by NIH, CDC, and WHO through things like biomarkers of nutrition and development, but how to measure is still a major challenge in most of these settings. Are these tests accessible? Are they accurate? Are they available for a decent enough price? And so on. And if you look at nutrition, there are very few labs around the world that are equipped to do micronutrient assays. I don't know about Rochester, but I can tell you, if I have to get my vitamin D tested in Ithaca, it will most likely go to the Mayo Clinic. There are not even enough labs in the US who can do a comprehensive panel of micronutrients at the point of care. So maybe in India, there are maybe about 5 or 6 labs which can do it, and maybe another 10 or 15 which we can improve the capacity, or they have the basic infrastructure to be able to do it if we train their people. But it's very limited. So most of the point of care diagnostics, of course, are based on simple lateral flow assays. They are mostly non-quantitative. The quantitative one that is popular is the blood glucose one. It's been successful, partly because the readers can be given away for free, but if you get a customer, then you have to tie them in for a long time. Our solution was why don't we use smartphones for most of this work? They already have cameras. Today's, the last version of iPhone is as popular as the entry-level MacBook. So the computational power in these smartphones is amazing and continues to increase, and have, of course, added benefits like GPS and ability to upload things right away. If we need to upload to a central server or a notification agency or something like that. They're also ubiquitous. They are present everywhere. And there is no need for a cold chain. We only need about 20 microliters of blood for the test that we are doing. They're inexpensive. It costs us right now only about $1 per test to do. Cost, not the price. The cost is about $1. And then, of course, we can upload results to servers. We can also build downstream apps like health advice, triage, and refer patients if we need to. This started as a partnership with a faculty in engineering, David Erickson. So we have been working on these two major areas, nutrition and infectious disease. On the nutrition side, we now have prototypes for vitamin D, B12, A, iron status, which includes ferritin and soluble transferrin receptor, cholesterol, sodium, and then inflammation such as C-reactive protein and AGP. On the ID phone side, we just got an NIH R01 to use this platform to build out what we call the fever phone. We are not very creative in names. So we also have an iron phone and so on. But the fever phone is going to let us do differential diagnoses of dengue, of chikungunya, malaria, leptospirosis, Chagas disease, and typhoid. So those are the 6 pathogens that we had identified for that. And we already have done the dengue and chikungunya because it's taken about 9 months for NIH. As we all know, it takes time for the money to actually come into the account. So we were told that we are getting it last maybe July. And yesterday we were told that it will take about a month to get the money actually in. But we have started the work on it. So we have the first paper ready on how to do dengue and chikungunya on a single strip. And that's sitting in my bag that I need to review. But we are able to do, basically the principle is, and I won't get into the technical details since some of these papers are already published. The principle is that any competitive protein binding assay, any ELISA, or most PCRs, we can adapt to this platform at a fraction of the price and eliminate the need for cold chain and so on and so forth, or any training. So some of these papers are already published. Again, I won't go into the technical details in the interest of time. This is one of our V2 prototypes, which basically is just printed off a 3D printer for a few dollars, and everything can be run on the iPad, so it mounts right on the iPad. It just like comes off and on, and then we have test strips that, if I can find one, we have test strips like this for, this one is B12 that can go right in here, blood drop can be put in, and it can be read on the camera. It takes about 10 minutes. Let me run through the slideshow here, see if that will show you all the steps. So it gives you a result, which is an actual quantifiable result. And of course, one of the issues with iPads or iPhones is that they are not everywhere, as was pointed out this morning as well. So our current version that I don't have a slide of because I couldn't share that is a third party. This is not very pretty. We still haven't gotten the design or aesthetics worked out on some of these. But this is our first generation new device, which is basically independent on an iPhone or an Android platform or a Windows platform. What it has is, if I can open it, it has a Raspberry Pi chip, has a CMOS imaging sensor, so it ensures repeatability and reproducibility across different samples. And all right, it's gonna get stuck today. All right, I can probably struggle with it later, but the idea is that what we want to make are things like our eventual device is probably going to look something like this. We call it an egg, and the test strip goes right in here in this slot, and it can be read. But the idea with this is that they can be lined up. Each of these test strips have a barcode, so we know exactly whose test it is. And I can have 50 of these lined up in a clinic, for example, and not have people wait for the iPad to be free to do a new test. Okay. So that's basically just an example of this technology, how we have been able to integrate it with some of our work. And the key thing, a couple of key points that came up this morning as well, is that typically advances in modern technology only help the rich, only help the elite. They don't necessarily bridge the divide to help the poor. I think with this mobile stuff, as we are transitioning to this technology being available on mobile platforms, I think we can bridge that gap. We can bridge that divide and make this really accessible across the world. And what we anticipate is that this can revolutionize lab-on-chip diagnostics, as well as basically be the hub of the healthcare universe. So something like the Nutriphone can do data collection, can be a mobile lab, can also provide triage and referral, can be used to modify behavior, and so on. So I will stop there. A lot of people to thank, including my group and David's group. A lot of collaborators all across the world. A lot of people. Most of this funding, the initial start came from National Science Foundation through 2 major grants. A lot of National Institutes of Health funding, and Harvest Plus, Micronutrient Initiative, and so on. So thank you.
I'd like to ask our morning speakers to please come up and take a seat up here, and we will take questions. If you'd like to ask a question, if you could go to the microphone. I think is there a microphone over there? There's not. So maybe if you're going to ask a question, perhaps come over here to the microphone on the side. And if you're online on the YouTube site, you can put a question live in the live chat function. And just so you're aware of the schedule, we're going to have this question and answer till about 11, and then we'll have a bit of an abbreviated break until 11:15. So, questions? Yes, please.
Thank you. This has been just a wonderful presentation, and I wish I could actually ask everyone a question, but just going to ask you. First, thank you for your presentation, and it certainly reminds me of the challenges we have in Puerto Rico also in terms of global versus what are specifics, and happens with prematurity. Puerto Rico has very special reasons why our babies are born too early, and but the recommendations that come from a national level are for things that actually are not key factors for us. So, and I think that when you were talking about the global economy and then the reduction approach, it's also like, let's look from the top and try to impose those, say, solutions to the local level. How would you change that paradigm, and what would you suggest that can be done to educate, say, global partners in terms of new approaches to address what really need to be local solutions?
So I think part of that is it's often said that when you talk to someone, that you have to talk in a dialogue and a currency that they understand. And so sometimes just explaining knowledge or even the scientific facts doesn't ring any bells for them. It's not where they operate. And so on a political level, making the case of why they need to pay attention to you. And so sometimes it's stuff like, in the smaller countries I work with, is, you're talking about our military alliance, and, we provide that. And if that's a value for you, then you need to dialogue in a way that we need this medical care. But I know that sounds draconian drastic, but I do find that a lot of times, unless they value who you are, and they don't even understand, or they don't even want to understand, what you're talking about. So I know it's what I'm saying is it's a really political and it's an activist type of solution, but I think I've seen it happen too much. As they wait till something bad happens to them, then they help you because they need your help to solve a problem that's theirs. But it's never or very rarely the other proactive way. So I don't know if that answers your question, but it's a difficult paradigm because I think a lot of times scientists and people like myself who are a physician believe, and as a family physician, maybe if I explain it to them and I go to their office, that I'll somehow convince them that it's an important thing, and it turns out they don't care. So, I know that doesn't directly answer your question, but.
I want to thank Professor Max, I'm sorry for your name, for that presentation. I was wondering, you made a very eloquent speech about global forces that shape ordinary people's life. I was wondering, in terms of what could be done on the local level in terms of, say, taxation, public health communication, in something like what you were talking about, the turkey tail, in order to reduce consumption. What can be done on the local level? We know it is very difficult to influence the bigger agenda. What local things that can be done that can improve health and well-being?
Again, I think this is my individual opinion, but I think what's happening in a lot of these small areas is they forgot or have been disenfranchised from the systems they've had before that actually worked very well. And they've adapted or maladapted by buying into systems, whether it's technological or, in the case where I work with, the U.S. health system was given to them. So they automatically start adapting into that, feeling that that's the way out. So to answer your question, it's reviving the values that they had and the way that they lived. Mind you, it's very difficult to do with how globalization works, and coming to terms with that, maybe I really don't want and I don't need what they're trying to sell me. And that they had answers for thousands of years, whether it's with navigation, their own medical ways, the way that they grew food. We had a good, in the native Hawaiians and a lot of these places, they had massive amounts of food that they had that were very healthy, and somehow it got destroyed in the Westernization era. So I know it's not an easy answer, but I think it's recognizing the value that the culture already had and internalizing that and feeling it, as opposed to, I need somebody else's help to solve my problem.
Hi, I wanted to thank all of the speakers for great presentations today, and not to put Dr. Palafax on the spotlight again, but in particular the South Pacific, because I think it is a very forgotten region of the world. I actually was living in Western Samoa in 2007 when the turkey tail ban happened, and you would have thought they had asked the Samoans to give up their firstborn. It was a pretty big deal. At any rate, my question is concerning the nuclear testing that happened in the South Pacific, and in particular, the Marshall Islands. I'm aware of a lot of studies that have looked into cancer prevalence in Japan after the atomic bombs were dropped. But what kind of studies are being done looking at cancer prevalence, in particular thyroid cancer, in the South Pacific and the Marshall Islands?
So, as much as I don't believe in conspiracy theories, so no, it's one of these things where, as we all know, being scientists and the public health people that we are, and just people who work with, is when you do something like nuclear testing, one of the first things you do is you put in a system to study, figure out baselines, and then see where things go. So in the Marshall Islands, specifically where I work, that was never done. There's no baseline. So in fact, the current studies that have come out of the NIH where they had to do modeling to kind of figure out a lot of these things, what they did was the comparison population was, Hawaii in those years. That's to show you how little data that they actually had, so they had an accurate comparison. So what they've done is they've done a lot of modeling, And there was a report done in 2004 by the National Institute of Health that showed that the nuclear testing in the Marshalls alone would have caused at least 500 excess cancers above background, and many of them are latent. But why talk about conspiracy theories and other things is, it's one of, even as a scientist, it's hard to know what the truth is, because they took that study and they redid it in 2010 and said there's still background cancers, but the number was a lot less. And they said they're refining the data, but some folks said they want to make their culpability less. So to answer your question, there are studies that show excess cancers, and there's 26 different types of cancers that are related to ionizing radiation, and all of those have been elevated in the Marshall Islands. Thyroid cancers in particular have been elevated. And then there's, but the bigger destruction with the nuclear testing wasn't actually the cancers. It's what it did to the social infrastructure and the contamination to land and the entire food chain. So, but that's not even talked about. It's so that people tend to focus on what are the health effects from in cancer, but what it did to the food chain so they can't grow their own food, what it did to destroy the culture. So the net effect was, if you can't live on your land, and the land is where your energy comes from and what you grow, and you're not there anymore, it changes your whole being. And so it did that in the Marshalls, and I'm sure in French Polynesia and other places. So the health effects are tremendous, and many of them aren't even talked about or quantified, like you said. But in specific, there's two NIH reports, one in 2004 and the second one in 2010, that looked at the Marshall Islands nuclear effects, but it was only around cancers from ionizing radiation.
A question for Dr. Masudi. I hope I didn't mispronounce your name, from the CDC. I appreciate your Maya Angelou quote very much, and how important it is that of how people feel. And on that note, were there any data on how these communities that have become the world's focus in a source of risk in their sort of victimization, displacement, loss of income, and sort of mis-quarantine leading to more diseases? Because I would submit that that lasting feeling of victimization would affect how in the future they can cooperate with prevention strategies.
Thank you for that question, and I would have to agree. I think that what people remember well, the next time when you want to come back, and even if you say you're there to help, as is oftentimes said, we're here from the government, we're here to help. So you've heard that before. So I think as acknowledging what has happened in the past, I think is probably one of the most important things to do, and it will only happen very slowly. I think relationships have to be built, and trust has to be developed. And just as, again, it can be lost quickly, but it takes years to develop. So in trying to get to the positive side of things, I think that in terms of what you had said, it's absolutely true of how people relate to those things. So as it relates to Zika, at least, in looking at the effects in Micronesia and other places like that, I know at CDC, when they're sending folks, they really are digging back to make sure that they send people who have actually stayed there and worked there and have experience on the ground, recognizing one of the most important things is relationships, and to have them be the ambassadors. So I think that's probably one of the most important things is, again, acknowledging what has happened in the past and saying that we're, and then slowly, and that's the only way that can happen, is to develop the trust over time. And then that's the only way then to try to get at some of the root causes of the issues.
Additional questions? Anything else? One, two. Okay.
Oh, me first. My question is also for Dr. Masudi. Most of what we've heard about Zika has come from South America, and Yet there was a large outbreak in Micronesia prior to that. And I just wondered if you could comment on what we've learned from that outbreak. And also, it seems like it relates to everything we're talking about the lack of recognition of what's going on in some of these countries.
I'm not an expert on that, so I'll maybe even turn to Dr. Cordero, who will probably have some more information about that. But I think that it's the lack of the data that were collected is oftentimes what we're finding in these re-emerging cases. And so, of course, getting back to Ebola. So all of those cases, and there have been a number of subsequent, previous outbreaks, but they were limited and very small and hardly studied. One of the things that was being done in Ebola is the survivor registries. So looking at some of the health effects that people have, again, having the increased capacity for surveillance, I think that's one of those things that hopefully from this point moving forward, we should have a lot more information. But unfortunately, those cases, and again, the case that I talked about in French Polynesia, those were suspected cases. So of course, not having the laboratory capacity to find out was it truly Zika, and having some of the symptoms are oftentimes the rate-limiting step in identifying and attributing certain lessons learned to previous outbreaks.
Morning. Thank you all. This question is for Dr. Mehta. I'm very intrigued by all of the mobile diagnostic technology applications you're working on, and I'm wondering whether your grant requires or whether there's other opportunities for you to do beta testing at different locations that some of us might be affiliated with in developing nations to actually get it out in the field and use these things?
Definitely very open to collaborations and collaborative opportunities and where it can be tested. Part of it is right now what we have been doing in the development process is we develop a prototype in the lab in Ithaca, and then we are testing it with commercial samples or with spiked samples and with then archive study from our archive, from a biorepository, and then we want to test it in the field because there is no replacement for real life field testing, both in terms of usability and in terms of whether it will function, especially like in one of our field sites in India, we get temperatures up to 50 degrees Celsius, and whether that will, what the shelf life of these test strips is something that we are actively looking at to investigate with temperature, with humidity, and those kind of things as well. So, but happy to talk about it.
Can I just ask a follow-up question on that? At the current prototype, how much is the cost of each strip that you used? And also, for each strip, is that only suitable for one item of testing? You mentioned like chemistry testing, 4 or 5 of them. Do you have to poke them 4 or 5 times?
Right, so we right now for a single one, the most advanced ones like vitamin D and B12 that we have already published, or B12 is in press, those are about $1.35 per test, the cost. And of course, these are done in a lab. It's not done in a manufacturing facility, so they are not done at like massive scale. So they are like, we produce maybe 200 or 100 test strips at the most when we have to do a human validation study. But those are the current costs to us. We are moving into multiplexing, so our probably the first multiplex one is going to be a ferritin, STFR, vitamin A, and AGP and CRP product, which is going to be by the end of this year. But right now we are looking at maybe $5 to $10 range for that right now. But commercially in the US it will cost several $100s, and in India it will cost about $50 to do. So we have I think a still huge, and that's just the cost of the test. We are not figuring in the cost of trained people, the lab, transportation, and cold storage. So that's the kind of factor that we are looking at right now.
Thank you.
One final question.
Good morning. Thank you all for your presentations. In the last couple of seconds here, I was wondering if some of the speakers could share some advice to some of my fellow students and professionals who are just getting started in global health and health policy research. Some advice you could give from your perspective.
If we could, in response to that question, maybe we could start here with Dr. Mehta, and if each person maybe could give us one key piece of advice that you'd give the students who are participating today in terms of their work in global health.
That's a tough one to start. I will have started with the most senior people coming down this line. But I think I think the world of global health today is really exciting, and interdisciplinary collaborations and talking to people and not just being siloed in a one discipline. I think that's the most exciting part, personally speaking. Like, we have been able to work with people in engineering, people in veterinary medicine, people people in demography, and so on. So having that conversation, whether in a formal or an informal capacity, to keep your horizons kind of open, I think that would be what I will recommend.
And I will second that. I think the multidisciplinarity is extremely important. Make sure you have in-depth understanding, in-depth in one discipline, but enough understanding of the other disciplines so you can actually solve problems which are multidisciplinary. I want to make one other point, which is take a look at who is making decisions in this business, whether it's in public health, whether it's in nutrition, whether it's in agriculture. Try to understand why they're making the decisions they make and see if you can change them in favor of health.
This is a tough one. I think that maybe two things to say. Understanding the issues that you're going, I'll use polio eradication as an example. It's very important to get the world leaders sort of behind the one cause and trying to achieve the eradication effort and to concentrate on it. Having firsthand experience, as was have others, is when you visit the villages and to offer polio vaccine, and when they tell you that, do you have food for them? Do you have clothes? Or some of the other issues, I think that those are the toughest questions I've ever faced. But we bring that back and to use that as an example of now with polio eradication efforts, as I said, vitamin A has been added on to it, a lot of other multifunctional looking at other diseases that you can then use the trained workforce to help with. So that's the other thing. And then also one last thing is that bringing solutions to a global setting from developed countries, I think, is flawed unless we have some way of thinking about making adaptations to on the ground. So because oftentimes things that work here don't always work there. So being able to adapt things, I think, and recognizing that is very important.
Thank you for your question. If I was to give advice for young researchers who are wanting to move forward on global health and academics, I would say to think big and try to get funding. And to try to get funding, you need to be innovative and have innovative ideas. And so find a mentor, locate a mentor, and try to get as many copies of applications that have been successfully funded, and then learn how to find the RFP, learn how to write a specific aims page that you circulate to all the multidisciplinary partners that you can find, to spend the time to really take the time to write, to write a really good grant. And then from that, you can start to build. But you need to have the pieces, and the toolbox is not only the idea, but it's also the how to actually put it together to get the funding that you need to move forward.
And I would say from my perspective that, one of the things about the work we do, being scientists and so forth, and physicians and academics, is we think that it's objective, but the whole Western science is highly culturally nuanced. And I think unless we understand that and understand what our cultural biases are, then I think we're going to do harm. So in the paradigm of first do no harm, to understand that we are coming in with a nuanced and heavily influenced way of thinking. And at the end of the day, I ask myself, do I really care about these people that I work with? And if I can say yes, then I'm willing to do the work it takes to make the understanding and the science work. If I sort of even hesitate, I know I'm going the wrong direction. So.
Thank you. Thank you all.
Thank you very much to our morning speakers, and we have a bit of an abbreviated break, so we would like to reconvene in 15 minutes for the next session, but then we'll have an extended lunch, so hopefully you can connect with people then. So we'll reconvene in 15 minutes.
That's why you couldn't share everything. Sorry.
presentation. And we have Evan von Weingarten, who's here from the University of Rochester. And he will be speaking on mercury exposure from fish consumption, a global public health concern. Welcome, Edwin.
Thank you. All right. Can people hear me? I'm a little taller, so maybe I can't reach me. It's a pleasure to be here. I guess the emphasis of this session is on rapid, so what I'll do is summarize 30 years of research into 8 minutes, I've been told, plus 2 minutes of slippage. I'm looking for the person who's holding the sign up to warn me about time. So mercury, there you go. Mercury is in the environment naturally. It's widespread. This slide shows you that as far as we can measure back from glacial ice cores, that mercury has been in the environment. A natural primary source of mercury would be from volcanic eruptions, which are the blue peaks there. And there are man-made sources of mercury. One of them is the yellow one there, which is the gold rush from the mid-1800s. And then currently we have industrialization, mostly the burning of fossil fuels. The primary exposure sources for us for mercury are from fish, the organic type of mercury, as well as the inorganic type of mercury, which is from dental amalgams. Today I'll talk just about methyl mercury exposure from fish. There you go. It's well known from poisoning episodes that methyl mercury is neurotoxic to the developing child. The two primary episodes of poisoning that have occurred were in Japan in the 1950s and 60s, where industrial waste was emitted into the Minamata Bay, and people who relied on subsistence fish consumption ate contaminated fish. This picture here is a very well-known picture of a malformed child and his mother. You can see from that picture that the mother has no health effects from eating contaminated fish, whereas the child is severely malformed. The other episode is from Iraq, which is obviously not based on fish consumption, but pregnant women were eating seed grain treated with methyl mercury as a form of pesticides. Investigators from this university, actually, Dr. Gary Myers, who is still here and involved with our research in the Seychelles, as well as Dr. David Marsh and Dr. Clarkson, went out to Iraq and studied child development in this population. And they found the infamous hockey stick, or up to about 10 parts per million in maternal hair. There didn't seem to be any kind of delayed walking or neurotoxic effects, whereas above that level, there appeared to be a dose response with increasing exposure causing neurotoxicity. So why is this still a concern? So for us, the primary source of exposure is from fish consumption. About 20% of the world's population, we're talking about billions of people here, rely on fish as one of the primary sources of protein intake. Fish is the primary source of exposure to mercury, but also the primary source of exposure to the omega-3 fatty acid DHA, which is necessary for brain development, and about 10-15% of all fats in the brain is actually DHA during development. So one of the questions is background exposure to methyl mercury from regular background contaminated fish consumption associated with any health risks? So dose response becomes a real issue here. This issue has gained a lot of attention internationally, so there are some recommendations from the FDA EPA, which were established in 2004 on the left. In terms of fish consumption, they recommended eat up to 12 ounces of fish a week, which was interpreted by most pregnant women as eat no fish. 2 years ago, they revised this. It's still a draft, and right now, highlighted in red, it says eat 8 to 12 ounces of a variety of fish a week, but really the emphasis is on eat at least some fish. Okay, so there's a little, most of it hasn't changed, but the philosophical change is really you need to eat at least some fish. And international organizations, WHO and European Union, agree with that statement. So what have we done here? In Rochester, we have conducted, and I've been involved in for the last 10 years. This study is 30 years old. So this is a long-running study, probably one of the longest running of its kind in terms of environmental exposure. We conducted the Seychelles Child Development Study. Seychelles is in the Indian Ocean. It's about 1,000 miles east of the African East Coast. They consume a lot of fish, about, at least historically, 10, 12 fish meals a week. They're a socialized country, so healthcare and education is free. They don't have a lot of other industries. They don't have malnutrition, and their birth outcomes are similar to that of developed countries. And really, this can be considered a sentinel population for the study of methylmercury because their exposure levels are about 10 times higher than you would find in the US. Just to point out that these poisoning episodes in Iraq and Minamata are really 1 to 2 orders of magnitude greater exposure than what we would find in the US or even in Seychelles. So what have we found? And this is where 30 years is condensed into 3 slides. The first cohort was a cohort of 779 mother-child pairs. The children were followed. About 740 were eligible. They've been followed for 24 years. The retention rate has been about 80%, so the last follow-up at 24 years, we still had 600 of those participants in the study. And what we have found is no adverse health effects associated, developmental effects associated with prenatal mercury exposure. What we have found is some beneficial associations with prenatal mercury exposure, which mercury being a neurotoxin at high levels of exposure, it seems implausible, and we attribute that to probably confounding by nutrients in the fish, such as polyunsaturated fatty acids. We didn't collect any of that information, which is why we conducted another cohort study. This is the first nutrition cohort, almost 300 mother-child pairs followed for 9 years, 9 to 10 years. In this study, we found some early signs of adverse outcomes in relation to prenatal mercury exposure, but that was only at 9 and 30 months, and after 5 years, at 5 years and 9 years, we found no associations. What we did consistently find was beneficial omega-3 fatty acid associations, where increasing fatty acid status in the mother results in better performance on especially language-related tests, which in the first slide, in the previous slide, was also beneficially associated with methylmercury exposure. So, we think that some of the confounding in the first study was really due to nutrients. What we couldn't do in this study was look at nutrient-mercury interactions to say, well, what if you have higher inflammatory state or higher PUFA status? Among those people, is mercury toxic or not? And what does mercury do in people that have lower nutritional status? So, and for that study, we looked at another cohort, which is 1,500 mother-child pairs. It's a delayed clicker here. 1,500 mother-child pairs. And we followed that for 20, there you go, I'm just using low tech here. We followed them for 20 months, and currently we have an R01 ongoing for a 7-year follow-up. And in our first follow-up, we didn't find overall adverse associations with methylmercury, but we did find an interaction with fatty acids. And this figure shows that where if you have a low omega-6 to 3 fatty acid state, meaning your maternal inflammatory milieu is more pro-inflammatory, mercury seems to have adverse associations, whereas where if you have higher 6 to 3 or if you have lower 6 to 3 ratio, there's no mercury toxicity. If you have higher 6 to 3 ratio, you have more mercury toxicity. So overall, the highlight for me was being quoted by Sanjay Gupta's website. That made my day. We found no overall association between prenatal exposure and child development, but it's complicated. And what we have found is that there are probably pretty complicated nutrition interactions as well as genetic factors that play a role in the metabolism of mercury as well as fatty acids and other nutrients. And that's kind of the working model at the bottom that we're working with. So what have other studies found? Other than popular belief, other studies have actually been rather inconsistent. The one here on the top, which is the Faro study, they actually are, that's the study that the EPA has used for setting regulatory limits, and they have found consistent adverse associations, but that's a population that eats whale, which some people call the Superfund site of the ocean, and there's a lot of PCBs and other contaminants there. Some other studies in Europe, in Spain, as well as in the UK, they haven't found adverse associations with mercury. In the Spanish study, 65% of the population actually was above the EPA reference dose. So it was not an unexposed population. It's relatively high exposure when you compare it to the EPA level. And then studies have suggested that selenium, which binds to mercury and makes it less bioavailable, really makes it, modifies the effect of mercury. So globally, and I'll wrap this up in 10 seconds, it's complicated. It depends on the source of mercury exposure, whether you eat fish versus seafood, whether you're in a mining community versus not. There's geographic variability in genetics that modify toxicity, and there's also wide variability of research methods across the different studies that would probably drive differences in associations. And I just acknowledge the study team here, NIH, as well as all of the different study sites that are involved with this research, and the study team that comes here every year, every other year, and we go to Seychelles probably about once or twice, once every other year. Okay, and I'll stop there.
Thank you, Edwin, for reminding us not to go whale fishing here in Rochester. So our next speaker will be Samantha Sitole, who's here from the University of Buffalo, and she will be speaking on capacity building in Zimbabwe, linking patient support groups with HIV clinical pharmacology research initiatives. Welcome, Samantha, and thank you for joining us.
Thank you. So good morning, everyone. I'm here from the University of Buffalo Translational Pharmacology Research Corps, and today I'll be speaking about HIV support groups and their role in research and capacity building in Zimbabwe. Sorry.
Just use the keyboard. Just use the keyboard.
Okay. It's not.
Click to the right.
Thank you. Sorry about that. So I wanted to just begin by showing this illustration of the utility and evolution of HIV support groups in the sub-Saharan African region over the years since the beginning of the epidemic. Support groups have traditionally been recognized for their role in terms of emotional support and psychosocial support. And this was more so in the 90s when they first came out for people living with HIV. And countries including Uganda, Zambia, and Zimbabwe were among the first to institute some of these community-based systems for HIV support in the region. So as time progressed and as ARVs became more widely available in the 2000s, there was a shift in the focus of these support groups to more of the socioeconomic aspects and the physical well-being of patients. And so we saw a lot more in terms of training for specialized skills so that patients could become engaged in some of these activities in order to sustain themselves and to generate some kind of income for themselves, since the majority of patients at the time were largely unemployed, formally unemployed. And so, as we know, patients lost to care consistently report financial constraints and lack of food as limiting factors to retention in HIV care. So during this period, as I said, there were these specialized skills in agriculture, livestock rearing, batik, and all kinds of arts and crafts in order for patients to be able to generate that income. And so now moving on to what the current support group model looks like, it's more focused on sustainable initiatives so that patients can live healthier and more productive lives. And income-generating activities have emerged as an important indicator of capacity building and retention in care in this region. Members are empowered economically to address their needs, such as food and shelter. And additionally, the activities within the support groups have become a little bit more technical, so the people living with HIV that are participating in these support groups can learn more technical skills that will ultimately aid in staying healthy and just kind of integrating into society and living productively. In addition to this, we see more of a decentralization of the community support group system, where patients aren't coming into one central location anymore. They're now being sent out into the communities where the members themselves become leaders, and they assume these responsibilities to show up to the clinic once a month and collect the HIV medications for the patients that they're responsible for within their communities. They also are responsible to provide support in terms of counseling as well as adherence monitoring for the patients in their communities. So I'd like to just zoom into one support group that we've been working with for the past 5 or so years at the University of Buffalo. This one is called PARI Support Group. It is based in Zimbabwe, in Harare, and it has about 800 members. It was established in 2006. It's actually housed on the combined campus of the University of Zimbabwe College of Health Sciences and a large national hospital. So the location is very ideal and has been ideal for us to be able to collect the data that we have. For this support group, different levels of membership were created and defined to provide an organizational structure which can be utilized to discuss and to conduct some research activities. The multidisciplinary framework, which includes folks from medicine, pharmacy, research, nutrition, social work, and so forth, has certainly allowed for maximum collaboration. It is closely linked with 2 tertiary institutions, University of Buffalo and the University of Zimbabwe, and their graduate students, fellows, and residents are actively engaged in implementation research. The support group is sustained by the members themselves, and they meet monthly and participate in a variety of activities. And in terms of research activities, over 20 international conference abstracts and 4 published articles have been generated through this one support group in the areas of pharmacovigilance, African traditional medicines, nutrition, and capacity building. In addition to this, some economic benefits have been realized by the members themselves, where they are participating in these income-generating activities. From this cohort, as much as $150 was earned in extra monthly income by participants from June 2013 through June 2014. And not to say that the extra $150 puts them above the poverty line, but it certainly does present as an extra sum of money that can be used for for other needs like food and transportation to clinic visits every so often, clothing, and so forth. And in addition to this, the collaboration with academic institutions as well as the medical institution certainly allows for clinical assessment to be easily attainable in this cohort. So moving on to how these support groups can be used to advance research, I think everything depends on the structure, and if there's a way that you can structure it in an organized way, certainly a lot of data can be generated from these smaller groups. I think in general, we don't traditionally see support groups as a means for collecting data that can inform clinical research. It's more of the psychosocial research that we usually look into when we see support groups. But certainly there's an opportunity for us to gain a lot of data from these smaller groups that can inform the feasibility of implementing even larger studies. In addition to that, it encourages bidirectional exchange of ideas between the providers as well as the patients themselves in these smaller settings. One of the things that we are working on with the support group currently is trying to find objective ways to assess adherence. Adherence is usually adherence to antiretroviral therapy is usually assessed in this setting just via pill counts and prescription refills, which is, very subjective at the end of the day, and adherence is certainly a huge problem, not only in this region, but worldwide. And so one of the projects, the pilot projects that we're working on, is trying to assess adherence using looking at the drug levels in hair, which might present as a cheaper option in the long run compared to the viral load test, which is currently at about $50 a test, and it's just not sustainable for monitoring. Per the World Health Organization requirements every six months. So there are opportunities, as I said, to advance these global initiatives one community at a time. The data is available. The members of these support groups are becoming more and more engaged and wanting to participate in some of these. They're realizing a lot of benefits, not only from the skills that they're learning, but also by becoming leaders themselves within the communities that they live in terms of trying to fight the epidemic. And so, in summary, the support group model has been successfully utilized to generate relevant clinical and implementation data. The introduction of HIV treatment, eradication, and monitoring interventions in future should include these HIV support groups since they are capable of supporting and sustaining clinical research. And just looking ahead, standardization within and across HIV support groups should certainly be considered in order to strengthen their utility in research. And with that, I will end it there. Thank you.
So I have the pleasure to invite Dr. David Adler here from the University of Rochester to speak to us today on the exciting topic of HIV, HPV, and cervical dysplasia in South Africa. Welcome, David.
Good morning, good afternoon. Thanks to the symposium organizers. I'm David Adler. I'm from the Department of Emergency Medicine here at the University of Rochester. I'll be speaking briefly about my research on HIV, HPV, and cervical dysplasia in South Africa. If you take a look at the map on the upper left-hand side of the screen, that's the prevalence of HIV globally. And you can see very high concentration in sub-Saharan Africa, and even more so in southern Africa. The map in the bottom right, it's a similar looking map, but this is actually the distribution of cervical cancer worldwide. Again, a very high prevalence in sub-Saharan Africa, with even more in southern Africa. This is not a coincidence. Cervical cancer is an AIDS-defining illness. It was defined as such back in 1993. Women with AIDS have an up to 22-fold increased risk of developing cervical cancer. Now, cervical cancer is caused by human papillomaviruses, and there are literally dozens that can infect the female genital tract, but there are only about 13, maybe 12, but about 12 or 13 types that are considered high-risk oncogenic HPV genotypes. Those are the viruses that actually cause cervical cancer. Now, there is some evidence that women with HIV have a different distribution of these many HPV genotypes. It looks as if they have a disproportionate amount of the high-risk types compared to the low-risk types, and even among those high-risk types, that they have a disproportionate amount of the types that are not protected against by the first generation of HPV vaccines. The natural history of human papillomavirus infection is impacted significantly by having co-infection with HIV. It's important to know that most infections with human papillomavirus are very fleeting. If you test somebody for an HPV genotype and they come up positive, you test them again for the same thing in 6 months or 12 months, it's more than likely to be gone, to have been cleared. This is less true for women who have HIV. These are women who are more likely to have what we call persistent HPV infections. And we know that when you have a persistent infection, you are more likely to then have an incident precancerous cervical lesion that's caused by those HPV viruses. We refer to those as SILs, squamous intraepithelial lesions. And then having HIV also increases your risk of having low-grade precancerous lesions progress to high-grade precancerous lesions and ultimately to cervical cancer. Now, I've conducted this research in South Africa. South Africa is the country in the world by far with the most people living with HIV. There's about 6.5 million people in South Africa living with HIV. The prevalence of HIV among women of childbearing age in South Africa for the entire country is in excess of 17%. There are definitely pockets and communities and subgroups where that prevalence is much, much higher in South Africa. We studied women aged 16 to 21 from the township of Masafumalele. Masafumalele is a really densely populated, very indigent, peri-urban area outside of Cape Town. And what we wanted to do was compare the distribution of these different HPV genotypes and the differences in persistence of these infections between women with HIV and women without HIV. And we also wanted to compare the incidence, prevalence, and progression of the cervical lesions that are caused by HPV between these two groups. Our methods were very straightforward. We did serial HPV genotyping, that is testing for these various HPV genotypes every 6 months. All study participants had a pap smear at baseline, and then subsequent pap smears were done at intervals depending on the results of their previous pap. HIV testing and counseling was conducted at every visit, and we collected demographic and behavioral data. I did this research with colleagues from the Desmond Tutu HIV Foundation in South Africa and the University of Cape Town. Well, what did we find? A tremendous burden of HPV infection. Among women with HIV, 96% tested positive for at least one HPV. That's about twice as much as women who did not have HIV, although they had quite a significant burden of HPV among the HIV-negative women as well. Interestingly, many of these women didn't just test positive for a single HPV. They tested positive for multiple concurrent infections with different HPV genotypes. In fact, the average number of HPV infections among women with HIV was 4, compared to just 1 for those who were HIV negative. What about the prevalence of those 13 high-risk HPVs? Those are the ones we really care about because they're the ones that cause cancer. The prevalence still very, very high. 71% of the HIV-positive women tested positive for at least one of the high-risk HPVs, compared to just 24% among the HIV-negative women. What about the vaccine genotypes? The first generation of HPV vaccines very effectively protects against the two most dominant of the 13 or so genotypes that cause cervical cancer. Our HIV-positive participants had a 36% prevalence of having the vaccine genotypes, and that's despite having an overall prevalence of 71% for the high-risk type. So what this is telling us is that approximately half of the high-risk cancer-causing HPV infections among our HIV-positive study participants could have been prevented by the first generation of HPV vaccines. Looking at abnormalities in the pap smears, about 28% of our HIV-positive study participants had an abnormality at their baseline, on their baseline pap smear. That's pretty high, compared to about 12% for the HIV negatives. And then looking at persistence, remember, persistence of infection is a critical step to developing precancerous cervical lesions. The persistence of the high-risk HPVs was much higher among our HIV positives compared to the HIV negatives. About 31% of the high-risk HPV infections we identified among the HIV positive study participants were persistent at 12 months, compared to only 4%. You can see that most of these infections are in fact cleared. So overall, we found a huge burden of HPV in this population in general, but a very, very big difference between HIV-infected young women and their HIV-negative counterparts. I want to thank the Center for AIDS Research here at the University of Rochester and the NIAID for supporting this research.
Thank you, David, for a very interesting talk. Mr. to remind the audience that we will have questions and answers after all the presenters are finished, and so look forward to having a very lively discussion then. So now I have the pleasure to invite Dr. Esteban Avandayo, who is here from the Universidad de Centros Médicas de Costa Rica. Bienvenido. He'll be talking about health care system in Costa Rica.
Yes. Good morning. Hello. So I'm going to be talking about the healthcare system in Costa Rica and how it's geographically based, and what difference and how the demographics and the general health standards have become really important differently from other countries in the region, and even compared to the results in the US and other countries that spend more money, like Neil was mentioning in her slides earlier today, in general. So this is our tiny country. We're 5 million people, 51,000 square kilometers. We're next to Nicaragua and Panama. Right there, most people live where the star is in San Jose. That's big valley. It's about 2.5 million people live there. We have about, from these 5 million, we have about 500,000 immigrants or people that have migrated to the country that come from Nicaragua mainly, but also from other countries, Dominican Republic, Colombia. So we have also a big base of around 200,000 U.S. citizens that live permanently in Costa Rica on and off. Some important relevant events that happened. We had in the 1940s a big social events changing the culture and all the ways the things were done in the country. We established a social security, and also the first public university that still working, the University of Costa Rica, and that the Caja del Seguro Social, which is our main healthcare services provider, was established on the solidarity, universality, and equality values at the time. That kept going after Second World War, and after a small civil war we had in year 1948. In the early 1970s, as you might notice before the Alma Ata Declaration, we had a health expansion of primary health care and health promotion activities, such as like water sanitation, all the biological and ecological aspects of health determinants that we know now that are really important in establishing a good healthcare model. We went through the same crisis everybody went in the 1980s, but we expanded vaccination and prenatal care, child care, and also adult care, giving also at the rural sites all the prevention for all the known at the time parasites that we could eliminating or reducing a lot all the death from diarrhea and all different kinds of illnesses for small kids. So we had a system that was divided, as most countries are in Latin America, I would say, where you have a Ministry of Health who provides the public services. Then we have Social Security, which is only accessed by those who have work and can pay for it. And then there's also private services. In the 1990s, we had a reform which ended up in having the Social Security, or the Caja, providing healthcare services, and the Ministry of Health only taking charge of health promotion and overseeing that everything was done right in the right way. So Ministry of Health is in charge of policy, regulation, evaluation. Social Security is the main health services provider. We also have other public but are small providers, and about 5 to 10% of the country access private services. And now, after the CAFTA in late 2010, we have increasingly seen also the private insurance companies. So now you can access Blue Cross Blue Shield and other Latin American or international insurance companies can actually provide services as well. Complex means of the structure for financing the system. I'm not going to go into that. And this is how the country, the Social Security or the caja is divided in regions. It's not exactly the same political division of the country because it was thought of as how people could access the system and now exactly where you live. So there are 7 different regions. Each region is divided in support teams, and these teams are, and these areas, these healthcare areas, comprise about 50,000 people population, more or less. And each of these is divided into what we call a BICE, which is a team comprised of a general practitioner, a nurse or a nurse auxiliary, and a healthcare technician, who is a person who is trained in basic healthcare sciences, is a technician 1 year, and then he goes to the houses, to the households and all the community, and do all the revision of how people are doing, and if you went to the doctor this year, if you didn't, if you immunizations for kids, and all of these primary healthcare activities that need to be taken care of. So as of now, 2016, we have 7 regions. We have about 1,041 EVAI, so these primary healthcare groups. We have about 1,000 of them. And each of them has a referral system towards a national hospital that it scales up in the different complex processes of health, diagnostics, and prevention, etc. So this is how the system is structured in terms of referral and capacity building, where I'm just going to show over here. You have the device, and each one has a small clinic or a medium-sized clinic, and at the end, they all refer to a larger national hospital. And we also have the public specialty hospitals, National Children's Hospital, and has maternal and child for special care. So what are the outcomes in general for the country? So we have with a GPD per capita of about $6,000 US, we have about $1,400 per capita spending, which makes about 10% of our GDP. So life expectancy as birth is around 80, with a healthy one around 70. We had this last year the lowest child mortality rate ever in our country, which is lower than 8, and it ranges from 10 to 8 per 1,000 newborns. So it's really low for the entire region, and we have an adult general mortality of about 4.3. This is, you can see how in the 1950s the children mortality rate came really low, and then general mortality as well. This is a really impressive curve of all the actions taken during the 70s, the 60s, how child mortality came from 90 up to 19 in about 20 years. And this is the pyramid, the population pyramid, how you can see how in the 50s it was, broad-based, low in the upper numbers aging, and now we have this population structure as it is, where you see we have almost a rectangular one. And this is what we are having, this is what we're dying from. So it's a circulatory system, malignant tumors, and it's been sort of very similar for the last 10, 12 years, and it's probably going to stay as well the same. Thank you very much.
Thank you, Mr. Mann. So I have the pleasure to introduce Dr. Carmen Velez Vega, who is here from the Universidad de Puerto Rico, and she will be talking about connections between prematurity and toxic substances in Puerto Rico. From genetic research to community engagement. Bienvenido, Carmen.
That's okay. I'm going to start because my time is counting.
No, that's okay. We'll wait.
Greetings from sunny Puerto Rico, warm and sunny Puerto Rico. I'm here to talk about a context, the people, and very serious social determinants of health. I am a U.S. citizen and live within a U.S. territory, yet nor do my fellow Puerto Ricans or I have the right to vote for the president, nor do we have representation in the Senate or House, at least not a voting one. And I was actually born in the mainland, in Brooklyn, New York, actually in this same state. I am a public health worker, a social worker. I am also a woman and a mother. And social determinants of health related to my gender, to my racial and ethnic characteristics vulnerabilize me. And that's what I will be talking about. I wish to talk about our work and will refer to the social determinants of health of gender, socioeconomic gradient, geography, early development, and environmental health. Puerto Rico has one of the highest rates of prematurity in the world. Okay. It's a good thing I talk a lot, so. A little information about Puerto Rico. As I said, we are U.S. citizens since the First World War. We have 3.7 million people living there from the 2010 census. You can see there our population density is 1,057 per square mile. You can see how it compares to the United States. And there is a decline of births, as is occurring in many places in the world. There is also an increase of immigration due to very difficult social and economic conditions. People are coming to the mainland of the United States in search of many opportunities. Of course, what we don't know is how that migration behaves, because we know a lot of people come here and then go back, because it's not a panacea everywhere. Interestingly enough, this year we had more income tax returns than we had last year, which is really interesting. If so many people are leaving, how can we have more people filling in their tax returns? But that is something that we'll need to find out. Why is that occurring? We do know that we have, as I said, we have the highest incidence of preterm birth. We are the third country with the highest rate of preterm birth. And the traditional reasons do not explain it. We cannot explain it by reasons that are commonly known. So in a March of Dimes gives us a report card of an F, and you can see there how that compares to other parts of the United States. And of course, you can also see how there are other jurisdictions and states in the United States that also have an F, and they're consequently, they are, as coincidentally, they are in areas of great poverty and of great inequalities. And this is just information, talking about the reasons, the factors which we explain. Premature births cannot be used to explain the premature births in Puerto Rico, because these indicators are actually being better. Environmental and other determinants of health should be considered. So, because if we cannot answer it with the normal questions, with the typical factors, we need to look for what is the other. And we do know that this is a great concern. That is paired with the fact that Puerto Rico is a very highly contaminated place. There are more than 200 hazardous waste sites, 60 active sites located on the national priority list. Many sites include unlined landfills above aquifers and karst geology, which means that all that contamination goes into the water system that people consume. And this is the karst area, this in yellow, and that is also the area of our study. Besides being an area of great contamination, many sites, as you see, all those stars and squares indicate areas that are contamination. There is also great socioeconomic diversity, a lot of inequality. At least 40% of the women that we see earn less than $20,000 a year, which in Puerto Rico is much worse than being poor. Yeah. We this is the area of our study, and these are the contamination sites, and these are the contaminants that are present, that we have found, that are present in this area. Our team doing, and our center, our project is created as a response to this situation. We have a multi-center project where we team up with scientists from many backgrounds, different scientific areas, to search for answers to this great problem. It's, we follow a transdisciplinary approach. And as you see there, we have 5 projects that studied the non-targeted analysis, the gestational membrane inflammation epidemiology and targeted analysis, fate and transport within the karst area, and also green remediation. Because we know that these contaminants that are present are also have been attributed to adverse reproductive outcomes. Our approach is a very complex approach that asks a lot of our participants. We ask them for blood, for urine, for hair, and now we're going to ask them for their babies to follow them up. So we are very indebted to all the women that have participated and participate every day in this study. We're looking at a cohort of 1,800. We already have more 1,100 that have been recruited so far. And we've been very lucky because we have a great team and people want to participate, want to collaborate. Some of the data collection, as I mentioned, includes different methods. In the area where I am working is the community engagement core, because this research is clinical, is scientific, but it all goes back to people in communities and people that are already vulnerabilized by many situations within where they live. One of the most important things that we are going to do, and we're beginning to do, is to report back. This is the first time in Puerto Rico that people that participate in the study will receive the results of their blood, of their urine, of their hair, of that they gave us so generously. And we have to make it in a way so that it means something. It's not just a pamphlet that goes into the garbage, or it's something that scares people. So it's really a challenge. That's why we're teaming up with a group of participants to help us. We actually have within our team several nurses that have been participants in the program. So it's very important to us to have their view. This has brought to a second project that is a follow-up of the babies. It's a Center for Research on Early Childhood Exposure and Development in Puerto Rico. And that is an infographic of, again, all that we are going to be asking. We're not going to be asking babies for blood or urine, but we will be following their development until they're 4. And we have all the information, we have a lot of information on the gestational period of that child, because we collect samples from the first trimester up until after birth. There we're going to study the impact of mixture and environmental exposures. And one thing I want to say is that the environmental exposure is not uniform, it's not homogeneous. There are people that are differentially exposed, and those people are usually poor and are female. This is PIs of our project. This is not all of our team. We have a very big team, but these are our leaders. And I also want to finish with also talk about our collaboration with the Global Health Research Network. I'm very, very proud to be a part of it, and I'm so honored and humbled to be in this conference and with such distinguished guests and scientists. And so we did this project because well, part of what we ask of these women is that they give us some of their placenta and some blood from the umbilical cord to do genomic research. So, and we asked them if they let us use it and if they let us use this for future research. A lot of people do not say yes to the future research. They'll say yes to the one that we're doing because they have expressed in these interviews and focus groups that they trust the PROTECT team, but they don't know, and they want to know who is going to use it for what. And so the two things are important: who are the scientists that are going to do the study, and what they're going to do. But most importantly, who are the people? It was very interesting because they wanted to know the credentials of these other people interested in our samples. We also have plans for research on Zika response in community because we're working with a huge cohort of pregnant women. So, and Zika comes along. So we are the largest cohort, active cohort of women that are pregnant in Puerto Rico, and so our PI, Dr. Cordero, as an expert in this area, and you will listen to him this afternoon speaking. Well, this presents to us an opportunity, but also an obligation to respond. We cannot ignore the fact that this is going on when we are working. We are asking so much of them. And as I tell my students, those women are us, and we are them. And truthfully, there's nothing that should separate us, but there are circumstances that do, and that's what we want to work on. It's our team with the people from Rochester. We also consider part of our team as well. Now, I want to finish with some of the comments that our participants had said in this study that I was referring to. I have no problem with my blood being used for other studies, but I need to know first. I want to know why my babies are premature and my mother's babies, also me. I can't avoid worrying that someone that is a part of me is walking out there and maybe suffering. This is people that are worried about cloning. When you tell them about genomic research, they jump to this. So, we know that we need to give them more information when we're doing these consent. And most importantly, they have said, and this was said in a different way by many women, we want to know if our participation has made a scientific progress possible. I want to know if it has done some good. So many of our participants are there because they know they're surely not there because we give them much, because we do give them some incentives, but this is a lot. And sometimes what we give them is a lot of worry about their pregnancy. We must never forget, and I just brought this picture of where we collect the samples because our scientists, usually this is all they see of our participants. Many of our scientists, which are great and very committed people. But we can't forget that these samples belong to people, and that we have a obligation to not only study and expand knowledge, but also to make it better for them, to work on the social determinants of health that are causing these. I just want to acknowledge our collaborators and thank you.
Thank you, Carmen. So this has been a very exciting panel that's covered a wide variety of topics, and so now we have a chance for you in the audience, who we also thank gratefully for being here, to ask some questions. So please stand up to the microphones, and we welcome questions.
Thank you to all the panelists, and again, like on the earlier panel this morning, I would like to ask everyone a question, but I really would like to ask Edwin, and something that others may have asked you, and it's that you've been working on mercury in the Seychelles for many, many years, and one of the issues that have come up from the issue of vaccines and autism, it's just mercury, and can you just sort of give us just a very quick rundown? Are the rate of autism in Seychelles higher than in other places, even with the high mercury content?
It's a great question. I'll point out that the mercury that we're studying is methyl mercury, which is a different kind of organic mercury than the one that has been in thimerosal in the vaccines, which is ethyl mercury, which we have not studied and we cannot study because there is about 100% vaccination rate. So within Seychelles, we can't differentiate those that have and have not been vaccinated. And they have all received the thimerosal-based vaccine because it's hot, and that's the way you preserve the vaccines there. So I can't speak to that directly in Seychelles. What I can say is that we published a paper a couple of years ago on prenatal methylmercury exposure and autism phenotype using 2 psychological tests. And our association, this was a pretty large population, almost 2,000 kids across all the different cohorts. And our association was about as null as you can observe in an observational study. So, in terms of methylmercury, we haven't found anything. When we talked about it to people, we made sure that says not directly anything about ethyl mercury, which we can't study. But I'm not aware that the autism rate is any higher there than we would find anywhere else. But with the caveat that pediatric care is not really set up to diagnose kids with autism very well. So there are some challenges there, diagnosis-wise.
Question on the right and or left-hand side of the room, please.
Is that better?
Much better.
Okay, I guess I'll start again. My name is Jackie, and I work at NCDHR here at the University of Rochester. I work with the deaf population in Rochester, and we know that minority groups really take a long time to develop rapport with the researchers because their communities have been marginalized in the past. So my question is for the woman from Puerto Rico. I'm wondering how you establish rapport with that group of Puerto Rican women before you start your research. You have a lot of collaborators from other countries as well, and so how do you develop that comfort level with the participants before starting your research?
Thank you. We have a great team. We have these fabulous nurses that are the people that do the recruitment. Now 3 of them have been participants or had been participants in the program, so that is something that helps. But truly, one of the best of the most important elements of our success is our partnership with the federally qualified community health centers. These centers have the infrastructure. I believe they're the only people that are doing some prevention work in Puerto Rico. So this is a place where this is a win-win situation. We help them, they help us. And they help us with the infrastructure. They know their patients trust the center and trust the people that are there. So that trust extends to us, of course, if we know how to keep it, if we can. But I think that has been our success. When I became the co-lead of the Community Engagement Corps, already the community was engaged because of the work of the nurses and the people at the community health centers.
Thank you so much.
Thank you.
Thank you. Are there any other questions from the floor? Neil?
I have a question for Esteban. Esteban, in Costa Rica, besides, you showed us a fine organization of health services and so forth, how much of the improvement do you think was because of health policy and working on the social determinants of health versus the organization of health services and delivery of vaccines and those types of things?
Actually, that's a really good question. And I think it's a combination. So there's a set of different success stories, one after the other. So I think, and some things were not planned for, I believe, and other were. And I think it's a combination of all the different dimensions of the ecological system. So from the cultural dimension, so cultural aspects, you have to say that, probably when, it's been linked, and this is one of my personal beliefs, it's been linked that children and people in general have better cognitive knowledge, and they can obtain education better if they have better nutrition, like we've been talking the whole morning. So if you have a better nourished population, if you have less exposure to contaminants in the ambience, and they can absorb knowledge, so they can do actually better prevention. So I think this happened during the 70s, and then during the 80s, the model changed in some ways. So I think it's a combination, to answer your question. It's more complex than what I showed in 10 minutes. But yeah, so there's a part of it is ecologically, part of it is sanitation had to do a big role during the 70s, and then the introduction of the different prevention specifics like vaccines, and keeping up with the different models that are out there. One of the big differences I didn't mention is Costa Rica doesn't have an army, so a lot of the budget, the national budget, goes to education and towards health for many years now, so since 1948. So I believe that has made also a big difference in what people, and it's embedded now in people's culture that we don't invest in that, but also it's becoming a challenge now because of all the war against drugs. So and people have the knowledge that we don't have such a setup militarily. So it's also a challenge now because the cartels and all of these different groups are also becoming and using the country as a platform to bring drugs different places. So we have the challenges, but to answer your question, it's a combination of all the different aspects of the model.
Thank you. Have a question here?
Thank you. Hello. Oh, it's on. My question is for Samantha, and I wanted to thank the panel. I would probably have questions for each of you too, if time permitted, but to Samantha, I really appreciated sort of the idea to use the kind of naturally occurring, if you will, patient support group as sort of the target. And sort of the theme I'm hearing is, how do we kind of engage in trust building and those sorts of things throughout the presentations. I was just wondering, in the patient support group context, do you have any insights, best practices for how to engage patient support groups in research projects such as yours?
Thank you for the question. Yeah, certainly, bringing the patients back for these meetings every month and, maximizing participation takes a little bit of energy and incentives on our part. We do lunches for them. We usually have something that they can, eat for their trouble for coming, in for these meetings. And like I said, I think the most, the biggest thing that's kept them coming and maximized engagement is these specialized skills training that we have provided to them for free. They learn how to make detergents and learn how to make all these different arts and crafts and soaps and jam and you name it. They're taught how to use that, as well as other business skills so that they can market these items. So they really feel like they're gaining a lot by participating and showing up, for a nominal traveling cost. And I think that's probably been what's kept them coming back, because they're learning so much and then they're able to go back and sell these items. And in addition to that, some of the incentives that we provide, as I said, through the hospital include food vouchers, for their families and stuff. So I think they come to a point where they realize that they have a lot to gain by participating and, oftentimes they don't realize that as a result, they are actually, improving in terms of their adherence. The things that we're actually wanting them, to do ultimately is improve in clinical outcomes and improve in adherence. I hope that answered your question.
Thank you. I'm just going to ask one last question to David. It was a very interesting presentation. You started out saying that the distribution of low-risk types may be higher in HIV positive as compared to HIV negative populations. Did you find that? And I guess the other question I have is, given that you find such a much higher burden of cervical disease in HIV positive as compared to HIV negative, how is that data being incorporated into the policy of the national program? And if it's not, what do you think needs to be done to take into your results in terms of implementation?
Thanks for the question. It's that the high risk, there's a disproportionate prevalence of high risk types among those with HIV compared to those without HIV. And of those high risk types, a disproportionate of types that are not protected against by the, at least the first generation of HPV vaccines. The second part of your question was about how
they have more low-risk types?
No,
though?
high-risk types.
No, but did you look at the low-risk types?
Oh,
that was what my question.
Oh, I'm
Yeah.
sorry. I'm sorry. I don't know the answer to that.
Okay.
We checked for 39 types among all of them. Only 13, of course, were
right.
high-risk types, and those were the ones we were focused on because they're the ones that cause cervical cancer.
Right.
So I don't have the analysis of the low-risk types at the,
Yeah.
at the
I mean,
top of my mind.
Yeah, the reason why I'm asking is that the lowest types are probably reactivating, and a proportion of the high-risk types are probably reactivated infections, and so you probably will see more low-risk types in HIV positive than high-risk types. And so
I see your point.
Yeah.
That may be true, and but I can't answer it from the data I have. As far as the second thing, it really, all of this, I think, speaks to, more than anything, screening, and does screening need to be different for these two groups? And despite, the thrust of this data really suggesting that the burden is so much more severe among those with HIV positive, those who are HIV positive, I think there's actually a chance, and there's some data actually from New York City, that screening procedures are overly burdensome for women with HIV. It's generally recommended that they are tested, that they have 2 PAPs during their first year after diagnosis with HIV, and then a PAP annually thereafter, regardless of their HPV status. I think there might be room for those to be relaxed for women who are HPV negative and have a negative pap smear, that they may be able to have a less intense screening, longer screening intervals. And that's a particularly important thing in a place like South Africa, where the public system pays for 3 lifetime pap smears. They do not have, and they have quite a bit of infrastructure for sub-Saharan Africa, but the cytotechnologists and so forth required to conduct annual pap smears on every woman with HIV is tremendous. So decreasing that with an evidence base that shows that it's safe is important.
Well, great. Thank you. Oh, one more question.
One question.
Yes, please.
And I have the instructions for lunch, so I get to ask a question before I get there.
That's 2.
This is for Dr. Avendano. So we have a preoccupation now in the United States with the construct of population health. And hospitals like our hospital here struggles with defining population health because we're supposed to be addressing population health. How do hospitals, like the hospital where you work in Costa Rica, how do they view population health?
Okay, yeah, that's a interesting, tough question. But there's many answers to that, and one of them would be that has been the way the model was set up for since the late 70s. So that's embedded into the culture of health professionals and the population. Although I have to say that the population also skips the way the system is set up, and they know, like, if someone wants to try to go to a larger hospital, they will find somebody that lives near that hospital or that's in that catchment area, and then they will get registered at the healthcare place that they will need to get registered so they can access that place. And then there was during the 90s, I would say, was when this model was best thought of as a model itself. And based on different success stories around the globe. So I know that it was based also on some aspects from the Canadian model, Chilean model. So our law, the Costa Rican Caja del Seguro Social law that was built in the 1940s was actually taken after a law that was already in place in Chile. So so it's been there for a long time. So culturally, it's now embedded into the country in every aspect of it. So and it's also a matter of trying to have, we know that one of the health determinants is access to healthcare. It's a very important one. So one of the ideas behind it is trying to have people access healthcare the fastest as they can. So that means bringing is both bringing the community to the healthcare services and bringing healthcare services to the community. It's a big challenge, but that's part of it.
Thank you, and thanks to all of our speakers. I'll just say lunch is going to be out that door, and we're asking you to meander over to the posters, and you have some judging to do of the posters so we can give student awards a little bit later, and we reconvene at 1:45. So.
Yes, wanted to thank everyone for joining this lively session and thank all of our speakers for a very, very well-organized and on-time session today. And just to remind everyone in the audience that the full bio sketches for everyone here, if you want to read more about our speakers, is on the Symposium website. And so please go there to find more information, and looking forward to lunch.
Thanks.
Thank you.
It's fun.
It is.
It was fun. You did a great job.
Sure. This is Tom Fogg at the University of Rochester. I am here at the second annual Global Health Symposium. Good. Are you ready, Andy? Yeah, I've got camera mic on. Sure. This is Tom Fogg at the University of Rochester and the second annual Global Health. That sound good? Yep.
Do you need it turned up a little bit on my end, or? All right. Yep, just did that. Let's give it one last check.
All right. This is Tom Fogg at the University of Rochester.
We'll go 3, 2, 1. Ready? Ready?
Hello, this is Tom Fogg. I'm at the University of Rochester, and this is the second annual Rochester Global Health Symposium and Unite Scientific Session. We're here in the Saunders Research Building, and I'm going to take you on a little stroll through our poster session. So I'm going to turn to our first presenter right now.
Hi.
Hi. So tell us who you are first, and then I'll ask you about your poster.
Okay. Well, I'm Vicki. I'm a second-year medical student. I'm Karen. I'm also a second-year medical student here at Rochester.
Very nice. So tell us a little bit about your work.
So this past summer, we were funded by the medical school, and we actually traveled to Peru and worked with the Ministry of Development and Social Inclusion there. And Karen can speak a little bit more about our actual project. So we were looking at a large 5,000 and upward number population of infants in Peru that lived in the most poor parts of Peru, and we looked at all their ages and stages questionnaire scores, which is a questionnaire that looks at development of infants. And basically we were just trying to see if there was any variation in the scores that correlated with what age they were within a 2-month window of the questionnaire that they were doing.
And what did you find out?
Well, we found that, so for a given ages and stages questionnaire, ASQ3, you can take either a 2-month or 4-month or 6-month. So a 5-month-old and a 7-month-old can both take the same 6-month questionnaire. We found that infants that took the 5-month or that were 5 months old did a lot worse than infants that were 7 months old that took the same exact questionnaire. And those 5-month-old infants were often false positive results for having developmental delay, but it could actually just be because they're too young. So that makes a lot of sense.
So tell us, what do you think the relevance is to public health?
I think the important part of this is that the ages and stages questionnaire is actually used in lots of countries throughout the world. So Peru is just one of them. Here in the U.S., we've had experiences working in clinical offices where we use these same developmental screening tests. So I think it's really important that there are very accurate screening tests out there so that we aren't falsely saying your child has developmental delay. And that has a huge repercussion on public health because it depends what the services that these kids access, if they're diagnosed with developmental delay, will be affected by surveys like these.
All right. Well, thank you very much. It was very interesting. We'll move on to the next poster.
Hi.
Hi. So tell us your name and where you're from.
My name's Casey Silver, and I'm a medical student here at Rochester.
Great. And tell us about your poster.
So my work was conducted in rural India, and I was evaluating a community health worker program where village women were trained beginning in 2009 to go out into their communities and counsel mothers on proper infant feeding practices. So what I did was I went to villages that had these community health workers and villages that didn't, and interviewed mothers about their feeding practices to see if there was any difference between the two groups.
And what did you find out?
I found that there were differences in some areas and not pretty much the same in other areas. Areas that had differences included introduction of weaning foods at the appropriate time, whereas exclusive breastfeeding rates were pretty similar across both groups.
Interesting. So tell us, how did you get started on this? I think some of our listeners would be interested in that.
Yeah, so I was volunteering for the organization, the Indian organization that trains the community health workers, and I kind of went there just to volunteer, and it became obvious that they wanted an evaluation of this particular project, and so that's how this project started.
Very interesting. Well, thank you very much. Hi, is this your poster? Well, good. Tell us your name and a little bit about where you're from.
Hi, I'm Shweta Nara. I'm a physician by training. I work at Bryant and Stratton as a adjunct faculty. My idea is on telemedicine in ICU today.
Tell us a little bit about it.
So, as you know, that critical care is the most expensive part of healthcare system, and when we use technology, it can help the tertiary level care centers, help the secondary and the primary level care healthcare centers to combine and work together towards sick patients.
And tell us what sort of technology you used for the telemedicine.
It is originally it's a smart databases, and it helps in connecting people through audiovisual array, and this helps the intensivists talk with the clinicians there who are at bedside to treat the patients better.
Tell us a little bit about your conclusions.
As the technology is increasing, we should reap in the rewards of the technology which is now in the world, and we should help the people who are in remote areas in the US, as well as I'm basically from India, so I would like that US clinicians help the Indian people to have better health care.
Well, thank you very much for talking to us. I think is this your poster here?
No, I'm just with her.
All right. I think we'll walk down the row here and visit another person. Hi.
Hi, how are you?
Wonderful. Can you take a moment and tell us about your poster?
Sure, absolutely.
Okay. Tell us your name and where you're from.
My name is Martina Anta Accra, and I'm originally from Ghana, West Africa. I'm a third-year PhD student in the Department of Epidemiology, Public Health Sciences, as well as Emergency Medicine Research.
Okay, well, it's wonderful to meet you. I've heard your name for years, and so I'm happy to actually make your acquaintance. So tell us a little bit about your poster.
Yeah, so this is a wonderful opportunity that I've had as a student at the University of Rochester to work with Columbia University. And essentially the poster outlines how they were able to recruit in Ghana, West Africa, 7,148 patients for an injury registry that they were creating. So what they did was they had 2 sites in the country. That we have our rural sites, which is Kintampo, and our urban sites, which is Sunyani. And essentially we wanted to know of patients who are showing up for care in these 2 locations, what do they look like? Who are we seeing who's injured, and what are the outcomes? So who we're seeing are males between the ages of 16 to 30. They tend to be employed, and they tend to be mostly uneducated. If they live in the rural location, these are adult males who about 29.5% are uneducated, and only 19.4% are also uneducated in our urban site versus our rural site. And also the majority are sustaining their injuries by road traffic accidents, which is not surprising in these parts of the world. But it may be interesting to also highlight the fact that we also have quite a lot of individuals who are sustaining bites from snakes, dogs, etc. Injury mechanisms that you may not see in America, for example. Fights or disputes are also very high, and stabs or cuts are also high, but we expect that in the rural location especially, where we see about 12.1% versus 9.5%. Wonderful about this registry is that only 105 died. So you have 7,148 people who are showing up with high mechanism injuries, and you only have 105, 1.5% of our population dying. So that speaks to the kind of care that they're receiving when they do show up for care in these healthcare facilities. I will then move you on to perhaps my next poster, which is also a sub-analysis of this population. So we then thought, all right, we have this entire registry, right? And now we can perhaps inform policy. Let's see what our population looks like. So we then looked at ambulance users. So who is showing up and using the ambulance in these two facilities? So what we did this time, though, is that we didn't look at the population by location. We instead looked at them by ambulance user versus non-user. So out of 7,148 people, we had 5.2%, so 371 use an ambulance, and about 95% did not use an ambulance. So who's using the ambulance? Well, mostly males, because we expect that. We saw a lot of men who had been injured and showing up for care than women. However, when you look within the ambulance user population and look at it by gender specifically, more women tend to use an ambulance than men, than non-user, right? And then when you look at the men, you see more male non-users than users. So our women in the country are using the ambulance more, right? When you look at age, there isn't much difference in age. We expect that, right? About 28, the difference is only 28 or 27, not a big deal. Our age range of our participants, about a few months old to 98. So you have individuals as old as 98 showing up for care in these facilities. So people are living long and they may need services. Education, more educated individuals tend to use ambulances than non-educated individuals. An injury mechanism, not surprisingly, most individuals have happen to be in road traffic accidents. And vital states, again, ambulance users, now this is interesting, ambulance users actually, a large portion of them end up dying compared to our non-ambulance users. So I thought that's striking. Why is someone, dying more if they're using an ambulance? But remember, a lot of our ambulance users also had been in road traffic accidents, right? And a large portion of them also showed up, dying. And a lot of them also tend to be more severely injured. We see 19.4% with severe injuries compared to non-ambulance users. So when we decided to look at our estimates, adjusted and unadjusted, we see the ambulance users have 4 times the odds of dying compared to non-ambulance users. It's perplexing. You'd never see that in America. We adjusted for gender, age, marital status, education. We're still at 3 times the odds of dying, and that's statistically significant. And then what we did was, if people are dying, let's just look at it by injury severity, because it's not just that they're just ambulance users and they're dying. Maybe there's a variation by injury severity, and there was. But what's interesting is that regardless of injury severity level, ambulance users are dying more than non-ambulance users. So what's happening? Who is using the ambulance? People who are more severely injured. But also, let's think about what kind of life-sustaining interventions they're receiving in the ambulance. So the combination of the two posters actually tells a beautiful story, how we can recruit individuals who are showing up for care and then use that to then inform policy and interventions in a country, in Ghana. So thank you very much.
Oh, well, thank you very much. I have a question for you. So how did you find your collaborators?
So this is a great story. It's all about who you know. I have a bunch of girlfriends in medical school. I have a friend who works at Columbia University. She's also from Ghana. I bumped into her in the hallways at Strong Memorial Hospital in 2001. She said, "You look just like my cousin." And we became best friends since then. 2 years ago, she is a resident. She introduced me to this group of individuals. They needed an epidemiologist. I needed a skill. I needed to apply my skills. I needed to network. And it's come to this point. So it's all about who you know. Just, you bump into someone in the hallway, shake hands, but just remember them for a long time, because you never know what role they'll play in your life.
Very good. Good advice, and thanks very much. It's a great example of team science and epidemiology.
Thank you very much.
Thank
you.
you.
It's been a pleasure.
And nice to meet you. Let's move on to another poster.
But the novelty alone, I think is a good start.
Hi there. I wonder if you could take a few moments and tell us about your poster.
Yeah, sure.
Sure. Tell us your name first and tell us where you're from and what program you're in.
Okay, so my name is Shishan Pan, and I'm currently undergrad at University of Rochester, majoring in data science.
Ah, wonderful. Good. So tell us about your work.
So basically, we're studying how news medias behave during the Ebola outbreak. So because right now people have used a lot of social media to predict this potential disease outbreak, and we're wondering if newspapers behave in the same way. And basically, we collect 3 different newspapers: New York Times, The Guardian, and Le Monde, and we see whether the trend of the number of newspapers that are related to Ebola is associated with the number of disease chain. So basically, right now, from here you can see that number of the pattern of the disease confirmed cases is quite related with the number of articles that are reported daily. So we're wondering, we can see that the match. So right now we can only say that this pattern is, you can monitor the disease based on the news patterns. But in the future, we are wondering if we can use news patterns to predict the potential disease outbreak. Yeah, so in the future, we are looking for digging into those local newspapers in Africa, or those are more likely to be able to predict those disease outbreak. Yeah, and another thing we're working on is to use some computer science techniques to help collecting data related to disease. So basically, we're trying to build a parser that could, given a newspaper, we can see what kind of information is contained in that news article. So we're trying to classify them into different emotions. And basically, we are now trying different classifiers, and right now the accuracy is pretty great, but it's hard because they could accurately predict that what kind of information is not contained in that article. But right now, we were not able to.
Let me stop you and ask a quick question. So the data for this table, this was from published press articles, as opposed to something like Twitter or something like that?
These are all from newspapers. So we have people collecting 500 news articles, and then we have manually label what kind of information is contained. And then we use some computer programs to identify what kind of information, and then compare to see how good our prediction is.
I see. So, and how would you use that sort of information in a public health setting?
I think one main point is so that because right now people really, this is a really time-consuming job.
I think we'll pause a moment while the announcement is going on.
From the UNYTE Translational Research Network, one of the co-hosts for today's event, and I'm here to tell you how the voting for the poster session is going to take place. So most people have already received a ballot that lists all of the student posters. We have extra ballots over here at the long reception desk. If you didn't receive one, please get those back to me. You have 3 categories to vote in, 1 vote per category. Get them back to me by 1:30. That would be really helpful. The next part of the day starts at 1:45. So I will make an announcement probably at 1:25 to remind people to turn in your ballot right over here at the long reception desk. And I'm looking forward to seeing the results later today. Thanks.
All right, now let's go back to and tell us, so you were explaining the public health relevance of this work.
Yeah, so right now, so the goal is to use some computer science techniques so that you could reduce the load people have to to extract newspapers and emotions, and then probably later we're gonna have more experts that are specifically studying how people's emotion change during the public health or disease outbreak. Yeah.
All right, well, thank you. This is really interesting and a really great example of using new technologies and techniques to improve public health. So thank you very much.
Thank you.
All right, let's move on to another poster. Pardon me, if you don't mind, can I interrupt and ask if you could tell us a little bit about your poster? Sure. So tell me your name first and where you're from, what program you're in.
I'm Claire McCarthy, and I'm in the toxicology program at the University of Rochester.
Thank you. So tell us about your work.
So I am studying the effects of biomass smoke and how it causes lung diseases. So 3 billion people throughout the world, especially in developing countries, use biomass fuels like animal dung, crop residues, and wood for cooking and heating their homes. But it's the leading environmental cause of death, and over 4 million deaths every year are attributed to biomass smoke inhalation. And women and children are at high risk of exposure since they tend to spend the most time around cooking fires due to cultural traditions. And epidemiological studies associate exposure to biomass smoke from those cooking fires with an increased risk for respiratory infections. And one particular type of biomass that I'm studying is animal dung, because it's used by vulnerable populations who can't afford cleaner or access other fuel types like wood or gas.
Where did you collect your data?
So I actually collected my data. I actually work in a lab, so I make these dung cigarettes, and I've used different types of animal dung from local farms and the zoo, and then I use a cigarette smoking machine to actually generate the biomass smoke for my studies. And then I can expose human lung cells as well as animals to the smoke and look at the effects.
So tell us a little bit about some of the specifics here. Show us what you've found.
So I've actually found, I grow primary human small airway epithelial cells. So those cells actually line your respiratory tract, and they're the first targets of inhaled smoke. And so I can expose these cells to the smoke at the air-liquid interface, kind of mimicking their physiological, how they are in the body. And then I can treat them with a mimetic of a virus, and I can look at their cytokine production. So these things are produced, as an important response to recruit cells to help fight off viruses. But we actually see if you treat them with the ligand, you get this nice upregulation of these cytokines. However, if you expose those cells to smoke and then treat them with the viral mimetic, we see that response is attenuated. And kind of along with that, interferons are very important for antiviral signaling and important for recruiting important cells to fight off and kill the virus. And we see, similar to the cytokines, if you treat them with that viral mimetic, you get a nice upregulation because it's the important part of the response. But it's attenuated if they're previously exposed to dung biomass smoke, suggesting that it's impairing these important signaling pathways, which may be why people are more at risk and have more severe infections when they're exposed to dung biomass smoke.
Very interesting, very, very interesting. So the question is then, what would be next in this research? What would you do next?
So this is mostly with a viral mimetic, and I'm currently working on looking at actually using live viruses and seeing the effects. And there's, even for further long term, we could look at, therapeutic strategies to try and help, recover these responses.
Okay, thank you. This is really interesting work, so thanks for explaining it to us. Thank you. Let's move on to another poster. Hi.
How you doing?
Great. So tell us who you are and where you're from.
My name is John Oliphant. I'm a professor over at RIT in the College of Health Sciences and Technology, and also a PhD candidate at Niagara University, working on a degree in leadership and policy focused on global health.
Oh, so very relevant to what we're doing here today.
Yeah, for sure.
So tell us about your poster.
Yeah, so I am very interested in giving students the opportunity to have global health educational experiences. And through the literature review I've done, I've seen that there's quite a bit of literature about the interest and benefits of that sort of thing for medical students and medical residents, but very little literature on that same kind of experience for undergraduate students who are considering future careers in healthcare, pre-med majors or physician assistant majors and things like that. So at RIT we have the College of Health Science, which is the perfect group to kind of test these ideas with. So I put together a survey that evaluated the college students' interest in different global health experiences and what they thought was important about global health. Did they think it was important? Did they recognize it was important at all? And I was very pleasantly surprised. If we kind of pan over here, this graphic here is looking at whether the students thought it was important to get different types of global health training. And the blue bar indicates that on every single thing, they thought it was incredibly important to get global health training in their program for future healthcare providers, people in a college like ours. They all should have that kind of thing. And when I dove into, well, what kinds of things would you like to do if you had them available to you? The three things that emerged by far were being able to do a short-term international service project, doing international clinical rotations and international research opportunities, You can see, the difference between not interested and very interested was incredibly different. Then I kind of dove in a little deeper to figure out were there differences in the way the students responded based on different demographics that they might represent. And this graphic here shows, the blue line shows people that have had international travel experience in developing nations ended up being far more interested in several of the different options than people who had never been out of the country and never seen those cultures or whatever. So I think maybe encouraging, if we want people to be interested in global health, creating study abroad opportunities or things that get them to experience that would be helpful. Interestingly, if we look down here, I discovered there was a significantly higher interest in global health amongst women than there was amongst men. So that's a source for future research. Why are the women more interested in global health? I found that younger people were more interested than older people in doing international research. I don't know if maybe the older people's lives are more complicated and they just can't imagine getting away, and the younger ones are more, adventure prone. And then these two graphs up here represent what I found is people who are basically pre-med or biomedical science majors tended to be much more interested in several different items than students who were in our diagnostic medical sonography or ultrasound program. And that was also kind of similar. Our physician assistants were much more interested than ultrasound students. So I think we're basically looking at decision-making professions versus technician-type professions. I think these people recognize I'm going to have to see a patient someday that may have some tropical disease that I don't want to miss or whatever. So it's very important that I have that experience. So I hope to take this information to the administration at RIT to show them we have a big interest in global health. RIT in general is very interested in having more global connectedness amongst all of its programs. So the College of Health Science is our newest college and is still growing and figuring out what its role in global things will be. So I think we can tell them students are very interested and some specific things that they would really like to have available to them. Not shown here is also a big interest in a global health club to bring in guest speakers who do things like we're hearing about at this conference. So that's kind of a quick summary of what it was all about.
All right. Well, that was a very good summary, and thank you very much. This is really interesting, I think, to us who are interested in bringing along the next generation of global health researchers. So excellent. Thank you for doing this work.
Yeah.
And thanks for coming today.
Very welcome. Yeah. Thank you so much for having me. It's great.
Good. Thanks. All right.
Hi, how are you?
Let me turn to our next presenter. Tell us your name and where you're from.
So my name is Matt Knoll. I'm a physician assistant student over at RIT. I'm also an undergraduate research fellowship in the College of Health Science and Technology, and I also work as an EMT here in the metropolitan area of Rochester.
Okay, very busy it sounds like. So tell us a little bit about your work.
Yeah, absolutely. So I actually just worked with my faculty mentor, John Oliphant, who's a faculty member for the physician assistant program. And we did a cross-sectional study on some universities offering undergraduate educational opportunities in global health. So what we did is we utilized the Consortium of Universities for Global Health publishes a database, and we went through and kind of skimmed that just for educational programs offered at the undergraduate level. And we did a little bit of a survey on each one of those universities. So I'd be happy to walk you through some of what we found.
Wonderful.
So we ended up looking at 48 different programs. Most of them in their program verbiage were using the new term global health, and that shows a little bit of a movement away from some of the other terms that were used in the past, like tropical medicine and world health, things like that. So a lot of them kind of adopting that new verbiage. And we were finding that the distribution within the departments, most of them actually, a quarter of them had a bona fide global health department that we were really surprised to find. A lot of the other ones were kind of distributed along some liberal arts and some schools of nursing and medicine and biology departments and the like, but we really we were surprised to find the dedication of faculty and resources to a global health department like that. In our average credential type, you'll see that a lot of our bachelor's degrees kind of fell towards the bottom as far as having the most average credits, but we really found a kind of a wide variance in some of our concurrent programs of study. Those were studies, or programs rather, that students could complete while they were working on their primary baccalaureate degree. And if you look up here at some of the credential types, certainly the minor and certificate within various majors were our most common program format that we found. But 22% were actually offered at the baccalaureate level as well. So, and then we also took a look at some other variables. We weren't able to make graphics for all of them, certainly, but looking at some of the travel requirements is kind of split 50-50. About 52% in the majority did not have travel requirements, but the remaining 48% had a wide variety. Only 14% had strict mandations on travel, which was interesting. And then we found that almost 2/3 of the programs had some sort of culminating enterprise, be it a thesis or capstone or research. So we're kind of taking all this and very excited to kind of apply it to RIT. We've used the information that we found from some of the course listings and some of the formats to take a look at RIT. We just got approved for an Intro to Global Health course and are looking to draft some minor and certificate programs that are very similar to the ones that we looked at here. So I'm very interested in taking what we found here and really kind of translating that and extrapolating that to the RIT community. So.
Sounds very interesting. So what's next for you when you're done with your degree?
Well, I'm very interested in critical care medicine, but I'm also very interested in global health research and some of the health policy research as well. So I'm considering some PhD programs once I get acclimated to clinical practice, but trying to keep an open mind for sure.
All right, good, very good. Thank you very much, and thanks for coming today.
Thanks for having me.
All right, we'll move on to our next poster. Let's see. And pardon me, I wonder if I can interrupt and ask you to tell us a little bit about your work. So tell me first your name and what program you're with.
My name is Vivi Vo, and I'm an undergrad student at the University of Rochester.
Great. What's your major?
I'm a public health major, health behavior and society specifically.
All right, good. So tell us a little bit about your poster.
So last summer I went to Niger with Dr. Leo for 18 days, and we were studying disability in Niger, and we wanted to see how the community was working on helping those who are disabled. And we found that there's a big stigma against disabled people and that there's not much done to help them be integrated into society. So then we wanted to look at like the different NGOs that work with disabled people and then see what they were doing and seeing if they were implementing like cultural values and whatnot to help dissipate the stigma and to help provide resources for those who are disabled.
So let me move a little bit so we're in a better position. So tell us a little bit about your results. What sort of data did you look at and what did you find?
So we mainly looked at like the NGOs and see how they were working, and we found that like a lot of NGOs work in silos, but at the same time they also work together. Like for example, CBM and ODI were like the biggest NGOs in working with disabled people, and CBM does the funding and the financial aspect, and then they would refer people to different resources that would help them. For example, like Cara that does vocational training for adults in teaching or improving those who are disabled, like their skills in sewing or repairing like bikes and stuff, and then helping them get integrated into society again. So overall everyone works together.
How did you collect your data?
We did a lot of interviews with the NGOs and just like observational models and stuff like that, yeah.
All right, well, thank you very much. Appreciate it. Now we're going to move on to another poster.
The rest 6%. That's what the comparison is. Comparisons here,
I wonder if I could interrupt you and ask you if you wouldn't mind telling us a little bit about your work for the live stream. So, first of all, tell us your name and where you're from.
My name is Ikechi Konkwo, preventive medicine resident here in URFL, MC. And this was a rotation that was on the health department, Monroe County, and that's where the study was done.
So tell us a little bit about it.
Well, we had cases of the usual STI investigation cases. Means you have an STI case in the clinic, and you get a contact tracing out. A health worker goes out to investigate, excuse me, and interview the patient, and then ask about who your contacts were, where you met them, where you live, and where they live, and try to close that cycle. We had an increasing number of cases who were coming back saying, these guys met on the internet, we have no way of reaching them. So we thought, let's do 12 months back and see just how many of these we can find and what kind of people they were where they met and then what to do about it, what are the challenges, what are the opportunities here for us. So that's what the study was about. And we found out that around this time we had 14% of cases that met on the internet. The other cases were also met on the street and the houses and parties and all that. But the 14% that met on the internet, that little number, were more likely to have had more contacts than people who didn't meet on the internet. They're more likely to have HIV, which is not treatable. Actually, 3 times more likely to have HIV, which is not treatable, than people who didn't meet on the internet. And then when we checked them further, we found out that these guys were also, if they had HIV, the males were actually about 5 times more likely to use the internet than the females. And amongst the males, the MSMs, and that's male who have sex with males, were actually about 5 times more likely to use the internet. Given that HIV is not treatable, was a cause for concern because these people have aliases, they have multiple accounts on those internet sites, and they have no fixed addresses, they have no fixed phone numbers. You can't close the loop. They may be in other counties where you cannot give them treatment, maybe in other states or other countries even where you cannot reach them to treat or stop the spread from patient to patient. Well, then we also have some opportunities because now, thank you, because now we could use this to broker a case for more infrastructure in the health departments to deal with these cases, also increase outreach by the health department to these vendors and sites to allow them access to these patients and build a backdoor to reach these people so that we can stop the spread of something that is potentially not curable like HIV.
I think that's a fabulous idea, and this is really interesting data. So thanks so much for talking with us.
Thank you.
Appreciate it. Let's move on to another poster. Tell us about yourself. Tell us your name and where you're from. And
my name is Colleen Murphy. I'm a doctoral student in the School of Public Health of Puerto Rico. I work in social determinants of health specifically, and with the PROTECT project, which is the Puerto Rico test site for environmental contamination threats. We're studying premature birth rates and potential environmental contamination that are causing those premature birth rates. That's the hypothesis. As the high level of prematurity that exists in Puerto Rico is not well explained by the typical risk factors, which is why we're looking at environmental contamination. Puerto Rico also has one of the highest densities of Superfund sites comparatively to the mainland.
tell us about that. What are these Superfund sites associated with? Which industry?
There are multiple. It's old factories that just left contaminants when the migration out of Puerto Rico. There were tax incentives in Puerto Rico until I can't remember exactly when that stopped. It's terrible that I don't know that, but landfills and pharmaceutical companies still to this day have a high presence in this northern region. So additionally, this region of Puerto Rico is called the Northern Karst. Karst is a porous, I'm trying to think how you say it in English, limestone. Yeah, thank you. And there's also some karst down here, which also is highly contaminated due to a petrochemical company. But we chose this area specifically because the rates of prematurity in these municipalities were super high, and the density of Superfund sites was extensive. So we recruit women, pregnant women, from 5 different study sites. 4 of them are federally qualified healthcare centers, and one of them is a hospital in Manatí, which is here. So we have now, just to move on to the specifics of this project, we have collaborated with the University of Rochester and the Global Health Network. And because we take hair samples, blood samples, urine samples, as well as placenta and umbilical cord samples if the women consent, we have all this biodata from the women who have consented to the primary project of Protect. But what Dr. Tim Dye and Scott McIntosh and Jose, who all came down to Puerto Rico back in September, were curious about was how women perceive potential genetic testing, given that those biosamples will be around for a very long time.
That's a very interesting part of this research, so tell us a little bit more about that.
So we conducted 5 focus groups. My advisor and I both are in more of the social sciences part of public health. So we just used open-ended questions about what do you know in terms of biobanking. Most women didn't know that biorepositories existed, but they'd seen on TV commercials for storing umbilical cord blood and that sort of thing for future use for illness. But none of them had done any sort of genomic testing, taking to find, their the genome or their potential for cancer, none of that. And ironically, this weird, sorry, I shouldn't put a subjective spin on it, but we had a lot of comments about cloning. That when they understood what we were talking about in terms of genetics and what that meant, there was all of a sudden this interesting response about cloning. So, but it was peripheral, I should also say. In reality, we have a really good participation rate. The women trust our team, and they had no issues with using their genetic data as long as there was consent for future studies. They've already obviously consented to this work, and super happy to be part of this and understand if environmental contamination truly is related to premature birth.
Well, I think this is a great example of community engagement, and you've done a really wonderful job of working with the community and gaining their trust. So this is a great example for public health practitioners.
We have a lot of work to do still, but we will be doing it, so thanks.
Okay, thank you very much. All right, let's move on to another poster. Tell us your name and where you're from.
Okay, my name is Zhenbo Yuan. I'm from the Department of Computer Science, University of Rochester. Thank you.
All right, very good. So tell us about the work you've done.
Yeah, sure. So we're trying to test the feasibility of using big data to help in health-related problems. So there are 2 main directions of our work. The first is we use this big data and machine learning algorithms to see if we can help in traditional health-related problems. The second direction will be we use new platforms of social media data, like Facebook or Instagram, to see if we can do this novel method of risky behavior detection or monitoring, and if we can help intervention with several diseases. Yes.
So lead us through this. In this case, where are you getting your data and how are you analyzing it?
So, like from this traditional health-related domain, we have our data through the collaborators, the hospitals, and
what type of data is it?
So for this specific project, we have this video data for eye surgery. So there's a training phase of doctor before they're moving to conduct surgery on humans. So that requires some experts or senior doctors to watch the video for many hours for just one doctor and to see if they are qualified to do this human surgery. So we want to shorten the time, and we got this kind of eye surgery video, and we just do this video segmentation and automatically grading their performance to see if they are qualified. And for this specific autism detection problem, we have our data through our collaborators in hospital, and we have about 200 potential autism patients. And we have their teacher questionnaire, parents questionnaire, and some medical forms. And we build up neutral language processing algorithm to see if we can see the patterns who have this kind of disease behind all those forms, and we have quite decent performance. We have like about more than 80% of accuracy, and we have more than 90% of recall.
80% accuracy versus a human review of the same information.
Yes, exactly. That's golden standard evaluation. So, thank you.
Well, this is really exciting. Really interesting work, and promises to do some really some good things.
Yeah,
for
of
people.
course.
All right.
Okay.
Thank you. We're going to move on to our next poster.
Hi.
Oh, there. How are you? So,
Very good.
Tell us your names and where you're from.
My name is Lori DeWint, and I'm a research coordinator here at the National Center for Deaf Health Research. And I'm Kelly Matthews. I'm also a research coordinator here at NCDHR.
Great. So tell us a little bit about your work.
Okay, well, this poster, it focuses on a clinical trial that we ran here, and this is a completed trial, and we're actually starting our second clinical trial using the same intervention. The original one focused on the population 40 to 70. The next one will focus on 21 to 40. So this is the 40 to 70 results. So what we're looking at here is an intervention to make lifestyle changes to impact weight loss. We also included adverse childhood experiences measures to see how that correlated, and we noticed that many of our participants had at least one adverse childhood experience. So that was a significant finding for us, and that's a place for us to go to work some more to see what kind of impact that has. Many deaf people have a lack of fundamental information about basic health information because they grow up in hearing families and don't have access to communication.
So tell us what you found. Tell us some of the implications of what you've done.
First, we found that we had to provide surveillance for the research in the clinical trial to make sure that we were actually fitting the needs of the population we were intervening with. So with that, what we see now is that this can be applied to other deaf communities. That's a primary question that we had, and we believe that it could be applied around the world. I think one thing that I would like to add is that the survey that we did is in American Sign Language, and this is a screenshot of the format of it. The questions are in sign language, and the answers are also in sign language, so that participants can take the survey in their primary language, and we can be sure that we have accurate data. A lot of times, data is done through collecting is done through phone surveys, which is not accessible to the deaf community, so basically excludes them. So this is a very nice way that we've created to collect information from the deaf community.
Tell us a little bit about how you engage the community in this work, because I know that's one of the really interesting things about it.
I think it's important that for us that we developed relationships within the community first, and we maintain those relationships because research is so important, and we have to explain to them why it's important, because deaf communities aren't used to being involved in research. It's a novel concept for many people. So we had to talk about what is the benefit of doing research and how it can benefit the community. And recruitment is usually done on the phone or radio or things that aren't accessible to deaf people. So we did a lot of face-to-face interacting with people and word of hand, as we call it, instead of word of mouth. And we spread the word in the community. And so those relationships are very, very important for us.
This is very nice. A very great example, another great example of community engagement in public health research. So, thanks very much.
Yes, thank you.
All right, let's move on to another poster. So first, let's start off by telling us who you are and where you're from.
I'm Vince Samar. I'm from the National Technical Institute for the Deaf, and I'm also a member of the research committee of the National Center for Deaf Health Research here at the University of Rochester.
So tell us about your work and what you found.
Sure. You want to hold it? Okay. So this poster is actually about the social determinants of health and how early life events can possibly influence the amount of weight loss that people experience much later in life when they participate in voluntary weight reduction programs. People vary quite a lot in the amount of weight that they lose, even with a good deal of effort, and it's been an enigma as to why that might be. One of the proposals has been that early life events that are adverse, for example, toxicities, exposures to toxic chemicals, infections, complications of pregnancy, malnutrition, all of those factors can cause a metabolic reprogramming that causes individuals to preserve calories, to become obese as children and as adults, and basically to change metabolic efficiency so that it promotes survival in the short term, but it has deleterious consequences in the long term for health. One of the ways that we can measure exposure to early adverse events is by classifying people according to their childhood socioeconomic status. So generally, people who come from a low childhood socioeconomic status background are exposed to a great many environmental adversities, and however, not everybody is as affected as other people. So there's a lot of individual variation in the degree to which their bodies reprogram metabolically their ability to manage weight. And the evidence is that this is carried on into adulthood and throughout life. These changes tend to be permanent. So we were interested in knowing whether we could find evidence that these changes were related to the amount of weight loss that people had much later in life. Now, it turns out that trunk length, also called sitting height, the length of the trunk, is associated with the degree of dysregulation of weight control by the end of childhood. So taller trunk
And explain that. Okay, that's what I was about to ask. Which way does this association go?
Taller trunk length is associated with more dysregulation, so higher BMIs as a result of early reprogramming. Only in a low socioeconomic status, childhood socioeconomic status group, not in high childhood socioeconomic.
Is this a relative measurement, like relative to total height, or is this an absolute measurement?
Some people have tried relative to total height. Some people have, we have used an absolute measurement actually, and we find that the absolute measurement works better than the relative measurement. And I think that's because the relative measurement also takes into account other adverse events or consequences having to do with stunting, variation in growth, restrictions on growth. So the trunk length relationship, it turns out, carries through to the weight loss relationship. And let me just show you the consequences. So first of all, let me say that the sample that we're looking at is the deaf weight-wise participants from the randomized controlled clinical trial that the National Center for Deaf Health Research has created. And so we had a very convenient data set to look at. These are 40 to 70-year-old deaf community members that we're looking at. So when we classified them according to low versus high childhood socioeconomic status, and when we measured their trunk length and related it to the amount of change that they showed in their BMI, we found that the low socioeconomic status, childhood status, socioeconomic status group, which is the red line, showed a decrease in the amount of weight loss as a function of trunk length. So higher trunk length, less weight loss. You see the opposite pattern for high childhood socioeconomic status people. They actually increase their amount of weight loss as a function of trunk length, and we think that's probably related to the fact that they were not exposed to early adverse events that challenged them and created a metabolic reprogramming, but other factors are operating to control this relationship. The important thing is that we see a clear distinction between people who are have been exposed to early adversity and people who have not, and it looks as if events early on in life have a long-lasting impact on the success of weight loss programs. So this actually harkens back to what Neil Palafox mentioned this morning about structural competency, that the socio-political system that puts into place conditions that promote adversity early on in childhood will trump ultimately the success of some individuals who are trying to lose weight in intervention programs that we put into place.
All right. Well, this is a very interesting study and shows a great example of a few things, using data from one study and applying it to a different research question, and obviously something very relevant to what's going on today in terms of public health issues. So thank you very much.
Thank you. Thanks, Tom.
Good to see you. All right. Let's move on to another poster. Whoop.
How those types.
Hi, could I ask you about your poster?
Absolutely.
All right.
Actually, it's the three of us here.
Oh, good. So let me start by asking you to introduce yourselves and tell us where you're from and what program you're with.
I'm Sanuja Bose. I go to the University of Rochester, and we're in public health sciences.
Good. Are you MPH students or undergrads?
No, we're undergrads.
All right.
Yeah.
And public health?
Public health and neuroscience are my two fields.
Good. Thanks. And your name?
Brianna Taylor, also University of Rochester undergrad.
Michael Healy, also University of Rochester, undergraduate.
Okay, good. So tell us about your study and what you found.
So this past summer, a group of the three of us and some of our fellow students traveled to Ladakh, India, which is up in the northern region in the Himalayas, to conduct a rural health assessment to try to figure out the health problems that persisted in this one small town of about 1,200 people. We also worked really closely with the Ladakh Nuns Association, so while our research was focused on gathering this data, another really important component of it was capacity building among this small nonprofit in the area so they could continue to do this sort of research and programming on their own after we left.
Okay. Tell us a little bit about the methods you used.
Sure, so we did surveys in we had 5 groups of students and nuns along with some local teenagers that acted as our guides. And we went through a survey with the people that that participated in our study. And we did some in-depth interviews too while we were in the community. Anything you have to add?
How about what did you find out?
We were actually quite impressed with the results, or like what we found in terms of health in this community. So what we expected with like globalization and poor health outcomes expanding would be that this might be the same thing in this area, but because it was more rural, we found that they actually had surprisingly good health outcomes, low rates of alcohol consumption, low tobacco usage. We also looked at maternal and child health in particular, and we found that they had very high rates of breastfeeding. So the World Health Organization recommends like 6 months for mothers everywhere, and they had about 5 months, which is much better than what they do here, and it was like very impressive.
That's really interesting. One of the more interesting things about this is the location. So tell us how you made connections and ended up in this location. Who wants to answer that?
Yeah, so Dr. Chin, our advisor, she's been traveling to this area for, I believe, about 12 years now. And she's worked with everyone from the Department of Health to the Ladakh Nuns Association. So it's through her that we made these various contacts. How we actually got into this particular town, in the past Dr. Chin had worked in the capital city, so going out into the actual rural area. That happened because the director of the Ladakh Nuns Association, Dr. Ani Pamo, she actually grew up in this town. So she had all the connections with the local government officials, but also her old neighbors and friends. And so it was a really good place to bring her nuns, many of them quite young, to start doing this sort of work. And kind of for them, it was a good process to learn about public health and to learn how to, do this sort of research for the first time in a place they were quite familiar with.
All right. Well, it's a great example of global health research and perfect for today. So thanks very much for coming. Hello, Nancy Chin.
How are you, Tom Fogg?
Wonderful.
You're here to interview about posters?
Yes, indeed. So first of all, let's start by telling us who you are and where you're from. and
So-
what program you're associated with.
So I'm Nancy Chin. I'm faculty in the Department of Public Health Sciences, and I'm an anthropologist looking at Jennifer's poster here because she did something close to my heart, breastfeeding. So I'll let Jennifer tell you about what they found out about breastfeeding in Malawi.
Okay, well, and it was nice talking to you.
Thank
All
you.
right. So Jennifer, tell us your
Hi.
name and what program you're with.
So I'm Jennifer Long. I'm with the U of R. I'm a medical student at the U of R. And last summer, one of my classmates and I went to Malawi and conducted some research there, some participant observation research and interviewing. So Malawi has one of the highest infant mortality rates in the world, if not the highest. And some factors that contribute to that are nutrition and infectious disease. So we wanted to hone in on nutrition and specifically breastfeeding practices. The WHO had stated that it is best for mothers to breastfeed exclusively for 6 months, so not feeding them any other foods or drinks. And we wanted to see how much of that information has been kind of passed down to the catchment area in Goa that we went to, and how much of that information the women understand as well, and what other factors there are that are either motivating women to exclusively breastfeed or to not, and to feed children early. So we went out. Oh, sorry.
I was going to ask, so what did you find in terms of prevalence of meeting the recommended 6-month period?
So that's a complicated question because what women say is not necessarily what they do in practice, because they've learned pretty well that 6 months is the standard. So we would ask, and a lot of them really do try to do 6 months or 4 months, but the problem is a lot of information has been passing through Malawi and many other countries from the WHO where in the past, within the last few decades, it's been 4 months that's been the recommendation, and so now it's 6 months, so it gets confusing, all that information. So now they say 6 months because they've been told that 6 months is ideal, but whether or not they believe that is another matter. So when we'd ask mothers, many would say 6 months, and they would start feeding them at 6 months. But if we ask them, for you specifically, for your children, and maybe go through a list of their children and say, when did Chifundo start eating foods? She would be like, at 4 months. So the answer changes depending on how we ask it, and depending on how she's feeling about how comfortable she is with us too. There was one mother who, when we asked her the question, she just started laughing because and then she said 6 months while she was laughing. So it was great that we had enough rapport that she knew, and she knew that we knew too. But I think the general knowledge is so we noticed that they were navigating two different streams of knowledge, right? They were navigating what they were being told was from the healthcare workers, from the community health workers, from the WHO, what was ideal in terms of science and knowledge and all of that, but also navigating kind of the traditions and what their mothers were telling them and how they felt and what seemed reasonable given their time constraints, given their environment, and if they have to go to work, if they have to go work on the farm, then their motivations are going to be different, and how much access they have to going back home to breastfeed is going to be different, and so all the different factors that feed into what decisions they make around their child's nutrition.
All right, well, good. Well, thank you very much for talking with us. It's very interesting work, and we appreciate your time.
Thank you.
Hi. I'd like to ask you about your work. So let's start by telling us your names and what programs you're with.
I'm Jillian Dunn. I'm an undergraduate at the University of Rochester.
In what's your major?
Public health and philosophy.
Hi. Oh, sorry. I'm Chloe Chapikin. I'm also an undergraduate studying public health and international relations.
I'm Nicole Case. I'm also an undergraduate studying public health.
Very good, thanks. So tell us about what your work has been and what you found. Who'd like to start?
Sure. So we are conducting a 5-year investigation in the Italian Dolomites in northern Italy on mechanisms of social change. So each leg of the project has had a different aim, and this summer we're going to be returning for our 3rd year. So we can kind of go into the in-depth of each year if you'd like.
Sure. Give us the high points of each year.
So the first year we collected life histories of elderly residents, kind of looking at different functional and dysfunctional adaptations to change while the economy and the social demographics have shifted. And we frame that in the concept of taskscapes, and that is a concept that allows us to look at the intimate knowledge of the land that the residents have and how they act in cultures of reciprocity and how they dwell within the landscape they live in.
How about second?
The second year.
Second year was Project Portola, and we conducted 25 semi-structured interviews with local residents in which we investigated sources of emotional stress and also sources for community cohesion. And we were looking at the growing generational gap between the youth and the elderly, because there's an outmigration of youth as they leave for work or employment opportunities.
Very good. And third year?
So we're returning this summer to start the third phase of this project. We're trying to bridge the gap now between the youth and the elderly through a pilot study of photo voice. And so we're going to be engaging with 5 different youth groups in Borca to kind of give them the tools to go out into their community and take photos of either the elderly that have particular importance or meaning to them and have a significant part in their life. And then other places around Borca that also have significant meaning in their lives. And then that'll culminate at the end of our stay there in a community open exhibition to kind of present these photos along with narratives that will help them develop. And so the aim of that pilot is to increase communication between the youth and the elderly, to kind of bridge the generational gap we're seeing as a result of these demographic transitions and economic transitions.
Tell us a little bit about how this location was chosen.
Sure. So our PI, Dr. Nancy Chin, has his relatives who have come from the village, and they were such a cohesive village, and kind of seeing that shift recently what sparked her interest in kind of applying different anthropological and public health concepts to see how that cohesion and that resiliency has changed over time. So we've been fortunate enough to travel along with her.
And I should also mention that this project is something that the Borchese municipality has requested, so they do know that Dr. Chin has family there, it has a pretty close connection with the community, and so they sought help.
This is really interesting. Tell us about years 4 and 5. What's planned for the future, Dina?
So Chloe and I are graduating next month. I am currently interviewing for jobs to get a little more hands-on experience and then an MPH.
And I'll be heading to Yale to start my MPH in health policy.
I'm a sophomore at the undergraduate level, so I still have 2 more years.
So you'll be able to continue working with Dr. Chin on this project, I imagine.
Yes, I'm very excited.
All right, very good. This is a great example of the application of anthropology to public health, and another wonderful example of multidisciplinarity within public health. So thanks very much for talking with us. Okay, I think that's it. That's all we have time for today. Thanks for listening. We'll move on to our next set of presentations in a few moments.
environment. So this will be Zika and mosquito-borne illness session. And we have 3 speakers today. First one, Changing Global Environment, a Habitat for Mosquitoes and the Spread of Zika and Other Mosquito-Borne Illnesses, Dr. Japa from New York University. Second, Zika and Pregnancy Plan Cohort Studies, Dr. Cordero from University of Georgia. And then third, Mobile Surveillance Technology, Mr. Solomon Abiolo from University of Rochester. So, and I would just direct you to the online to get the full bios of the speakers. And so I will let the speakers now go in the order that I announced them. So, Dr. Japa. Thank you.
Good afternoon. I'm happy to be with you once again for this annual Global Health Symposium. Today, as we discuss the emerging threat of Zika virus in the Americas, I would like to focus on the macro issues. The changing global environment and the spread of mosquito-borne illnesses. The warming of our global environment as the result of anthropogenic activities such as the production of greenhouse gases and deforestation have provided a larger habitat for mosquitoes and the ensuing spread of infectious diseases. Deforestation increases the penetration of sunlight into freshwater streams. It contributes to the loss of biodiversity. It alters the eco-environment, and it increases the presence of few dominant species that are likely to serve as host or transmitters of infectious diseases. The Latin America region represents the largest estimated forested areas, with approximately 6 to 7 million kilometers of forested land. The mean annual rate of deforestation in Latin America ranges from 0.33 to 0.51%. The Brazilian Amazon basin, which has the largest share of the Amazon region, is experiencing forest loss at an alarming rate. Deforestation contributes to the increased presence of various types of Anopheles and Aedes mosquitoes, the transmitters of Plasmodium parasites, dengue, Zika, chikungunya, and yellow fever viruses. Zika virus has been found in several species. Besides the Aedes mosquitoes, we are not sure if these other species are competent transmitters of Zika virus. The rise in global temperature has resulted in increased geographical distribution of these mosquitoes. It has lengthened their lifespan, their reproductive capacity, and their infectivity. The world's forests are in peril as global economic processes takes precedence over environmental conservation. Deforestation is especially acute in tropical regions of the world, including Brazil, as I mentioned earlier, where Zika virus is currently active. In most instances, deforestation is the result of industrialized agriculture, logging activities, rapid urbanization, and the use of wood as fuel. This was a picture I took when I was in Nepal last year. Today's environmental degradation is also the result of century-long human activities of the industrialized North. With the pace of globalization, the intense circulation of people and commercial products across international borders, the spread of infectious diseases is even more rapid. The U.S. preeminent leadership role in global health issues and its quest to combat infectious diseases has been exemplary in many instances. This partially stems from the fact that the U.S. was and still is the world's foremost destination for immigrants. As such, a disease threat anywhere is a disease threat to the U.S. The U.S. military encounter with malaria and yellow fever in Cuba and the subsequent effort to construct the Panama Canal provided the impetus for the mobilization of major public health initiatives by the U.S. in the region. The U.S. employed a wide range of anti-mosquitoes measures that resulted in a successful mosquito control in the region more than a century ago. The U.S. was also instrumental in the formation of the Pan-American Health Organization, an organization that is active in these public health issues. Today, the Zika virus, transmitted by the same mosquito that transmits yellow fever, is a major public health emergency, the WHO declares. The WHO predicts that the Zika virus will establish itself in all of the Americas except Canada and Chile. In the absence of vaccine or specific treatment, the primary preventive measure is to reduce exposure. The US has a unique role to play on multiple fronts, including primary prevention such as a robust vector control, measures to combat climate change, and dissemination of scientific knowledge. The recent Paris Agreement was the right step in the right direction. How can we work to ensure economic viability for vulnerable populations while protecting our environment? How can we build on recent knowledge acquired from the Ebola crisis, but also avoid the pitfall of the same crisis? We must work together to ensure these processes are successful and reduce human suffering. Inequality in the region is very high. Brazil and other countries in the region have a large Gini index, which is the dispersion of income distribution among populations. Access to sanitation, adequate housing, clean water are not evenly distributed. These are issues we must deal with in a global context. There are many social factors that determine diseases. Brazil, for example, has a very good health system compared to what we saw in West Africa during the Ebola crisis. Community health care workers are the backbone of the Brazilian healthcare system. And because they are spread within the community, they can provide pertinent health information to reduce morbidity, mortality within this context. However, other places affected like Haiti, Venezuela, and Colombia, I'm not sure that we can rely on the health system or the social environment to reduce the spread of diseases. Zika and Ebola, these are diseases of the poorest of the poor. We must work to reduce human suffering. And I want to show you an illustration of what deforestation is within in this region. Thank you. I look forward to your discussion.
Good afternoon. Buenas tardes. I hope that you're awake after lunch. Thank you for the invitation to speak about Zika in Puerto Rico and the planned studies to understand the risk of this virus in pregnancy. I would like to thank Dr. Masudi for the wonderful presentation earlier today that describes Zika. And actually, I'm good to see that we share slides. So you already heard that Zika is an arbovirus, and it's a family of flavivirus. And so what I'm going to do in the next few minutes, 1958 minutes or 20 minutes, is to first give you an introduction on how the situation of Zika is in the Americas and it links to Puerto Rico, talk about Puerto Rico, and then what are the things we know or don't know about Zika that we want to understand in terms of Zika in pregnancy. I assume that I use this to change?
It's not working, just use the arrow.
Okay. Dr. Masudi this morning talked about that Zika was discovered in 1947 in Uganda. And there were a number of reports of sporadic cases, but it is in 2007 when we have the large outbreak in YAP that he discussed. But it gives you a good perspective how this disease has been moving to then the French Polynesia, Easter Island, and then in 2015 to Brazil. And from there, it has really spread throughout the Americas, as we can see in this slide prepared by CDC. And within that circle is Puerto Rico. And I don't know whether the
central button?
I'm sorry, the central button is right there. That's for those of you who haven't been there or no. So Puerto Rico is right in the middle of this major challenge with Zika. And here is a summary of where we are. In Puerto Rico, Zika was introduced in early December, was the first case. What happened then is that CDC, together with the Puerto Rico Department of Health, conducted a serosurvey. And from that, they did like 200 samples of a serum that actually was negative for dengue or for chikungunya. And from that, they found that the very first case was in November. So it's a recent introduction, and it's good. It's a good indication that the surveillance system can detect the introduction of this disease. So by the second week of January, of the year, really, there were 18 confirmed cases. There were 2 hospitalized cases. And as you see, week 13, which is the most recent that has been reported, it is up to 550 for confirmed cases. There are 16 hospitalized, but we have 71 pregnancies that Zika has been confirmed. It's interesting that we have both symptomatic and asymptomatic in a 65 to 35% ratio of 6 cases of Guillain-Barré syndrome, and thank God so far no fatalities. But when you look at what happened from week 2 to week 13, in fact, we're having somewhat of a doubling of the cases of Zika. And as you can see here, in the second week we were about 1821, but by week 5 we were at 63, and by week 7, 157. So it is almost doubling about every other week. And so it's likely that in the next couple of weeks, we would be getting to at least 1,000 cases confirmed. And so this is, we're right in the middle of the major transmission of Zika throughout Puerto Rico. But this just gives overall of the island, but it's important to also look at how is it distributed in terms of the entire municipalities. There are 72 municipalities, and what the Puerto Rico Department of Health has done and is that the top map here is the sum of all the cases of arboviral disease, that is dengue, chikungunya, and Zika. And as you see, we have them all, but probably and this is second week in January, the center of the island there is a little bit. In the first one, that's chikungunya, it's mostly in the western part of the island. Dengue is mostly in the San Juan area. This is San Juan over here. And as you see here, most of the early cases were in the eastern part of the region. So if we, and this is the Zika at the bottom. If you look at what's happening now, it has completely gone over the eastern part, and it's moving slowly but surely to the south. And one reason that we have a lot of cases in the south is that we have many people that work. This is second city in Puerto Rico, Ponce. Many people live in Ponce and work in San Juan. So they have good opportunity to be exposed, but it's all done by residency, so they count to Ponce. And this is the area where we have the recruitment for our cohort study that Dr. Velez told you. So we are in that stage just waiting for Zika to come and crossing our fingers. One of our graduate students have been looking at modeling of Zika using the experience from the chikungunya that happened only about 3 years ago. And the estimate is, this is a rough estimate, but it would take about 30 weeks to go from its origins to the western tip of the island. So we expect that by the fall, September, October, we would have Zika throughout the island of Puerto Rico. This is one of the slides that Moran and I shared, but the concern is really not only the transmission through the mosquito, the Aedes aegypti, but it's also the transmission, the maternal fetal transmission that has been well documented, and that is the reason why we have a global health emergency that was declared by the World Health Organization. Let's see what I did. Okay, there you go. I guess I kicked the computer. So I'd just like to make a point about the maternal and fetal transmission. And one of our former CDC directors, Dr. Bill Faggy, and really a giant in the eradication of smallpox, wrote a very nice book describing the experience in eradicating smallpox. And the title of his book was House on Fire. And the reason for using that title is that when they went to a village and have to determine who are we going to vaccinate against smallpox, the answer was, let's go to where the cases are. And the cases, and that's how the smallpox transmission was actually stopped and finally eradicated. In our case, now that we're dealing with Zika, and in the maternal fetal transmission, it's really the concern. Pregnant women is the concern. So when we talked about vector control in trying to decrease the opportunity for exposure, our house on fire are really all the households that we have pregnant women. And a lot of the effort that CDC and the health department are focusing on is how do you actually reach out to pregnant women. And we actually have been working with our cohort, ensuring that they have what's called a Zika kit that includes repellent, but also includes larvicides and other things. And we actually are adding in mosquito nets because that is a concern. For us, the transmission is really the house on fire. And now I can't get this to move to the next one. Okay, thank you. The early stages of the epidemic, there was a question whether the birth defects that we're seeing with Zika were truly related. But our colleagues at CDC, led by Sonia Rasmussen, that now is the editor of MMWR and spent many years with the Center on Birth Defects and Developmental Disabilities, as well as Denise Jameson, Peggy Honane, and Lyle Peterson. Lyle Peterson is the head of the Vector-Borne Diseases Division, and they have actually done a very elegant review of what do we know about the evidence of causality. And using Tom Shepard's criteria, they could actually demonstrate that we have sufficient evidence to say that Zika causes these serious birth defects. And I'd like to just sort of review some of that because I feel it's very, very important. And what it includes is that this is a fairly unique and rare kind of condition. This is not microcephaly the same way that we see, say, from time to time. It's about 6 per 10,000. But it is the type of microcephaly that is that the brain actually has a significant disruption. The brain develops, grows to a certain point, gets infected. Many cells and many neurons actually, and glia and other nerve cells die, and from that actually causes like a collapse of the brain. And as a result, you see that in something like half to a third of the babies, you see a lot of skin folds in the scalp. And what that is that with a reduction of the collapse of the brain, there is too much a scalp, and so that's a very unique type of syndrome. Turns out that Peggy Honane and Sonia Rasmussen have written on this is called the brain disruption sequence. And when they describe this for or their summary, there have been only like 12 cases reported in the worst literature. So we have a very unique syndrome. Second is that they could demonstrate, and there have been some reports demonstrating the presence of the virus in cerebrospinal fluid and in the tissues of the brain. And I'm not going to go into more details, but clearly I think this is a study that was just published, and already I think it's a classic. But let me just point out that some of the defects, and this is one of the recent papers describing the imaging findings. And what it does, it has some calcifications that are very, very prominent. And it's actually in the border between what is gray matter and white matter. Also, I'd like to point out that here you see that the brain, it's really very, very tiny. And it's not only affecting what is the main cranial mass, but even the cerebellum, which is over here, is actually fairly damaged, and as well as most of the medulla. So this is a very, very severe kind of disruption of the brain. In summary, what you see in terms of the imaging findings include brain calcifications. There is significant malformations in cortical development. The spaces you saw was the cisterna magna that was large, and this is because it's sort of emptied from what is the brain mass, and there is hypoplasia of the cerebellum. But there are also some other defects that are really important. Is that something like 11% of these babies have arthrogryposis. That means that the brain defects, actually, the brain effects happen early in pregnancy, because to develop that kind of basically contractions of the arms and legs, like leading to club feet, the baby has to be in utero for a long time to be actually immobile. And so that also points out the importance of exposures in the first trimester as being a cause of this condition. The other thing is that there is significant evidence now for macular atrophy, and those are some of the pictures. And again, all these pictures that you see, including this, there is a lot of loss of what is the nerve tissue that makes the retina. So again, this is a neurotropic a virus that is affecting the brain, and it's affecting other with the eye, but certainly probably is affecting other areas too. So what do we know? And we do know that there is evidence that this virus can cause serious birth defects. What we don't know is if the risk for microcephaly and all these brain defects that I'm describing are the same, whether the mother has symptomatic or asymptomatic Zika. One of the challenges of this disease is that 80% of the infections are asymptomatic, and that came from the very nice study in Yap, Micronesia. And actually what's been done in Puerto Rico and Brazil suggests that actually is consistent. So the question also is, what is the risk of perinatal transmission? If the mother is infected very early, almost about the time of delivery, which was something that in chikungunya was observed many times, what's the likelihood that the baby would then, a few days later after being born, is affected? The same question also is about maternal fetal transmission. If the mother is infected, what is the risk that the baby would also be infected? The other question is what happens with breast milk? Would breast milk contain the virus? And there have been some questions raised about pesticides and other environmental factors. Is there a susceptibility factor? That actually are things that need to be addressed. And for that, the NIH is actually have developed an initiative. It's a consortium of investigators from Brazil, Colombia, Central America, and Puerto Rico that already had an ongoing cohort study of pregnant women that now can move and do Zika, and that's exactly what we're doing with PROTECT. The expectation is to recruit 10,000 pregnant women over 2 years. And the key aims is to define the risk of symptomatic and asymptomatic infections, as well as the risk for birth defects. We are, as we speak, developing the protocol, and we hope to start the recruitment later in 2016. So I hope I can come next year and tell you what the progress is. But there are many, many questions that need to be addressed in terms of the risk of infection. And there are many other questions. For example, we don't know if we have someone in the household that actually acquires Zika, what is the risk for other members of the household? We know from dengue and from chikungunya that if one gets affected, chances that everyone else would actually be infected it's close to like 80 or 90%. In fact, when we had the introduction of chikungunya, as an example, the first 5 cases were actually in the same family. There was the imported case, and then all the cases that followed about 2 weeks later. So we have a lot of work ahead of us, and we expect that with this consortium, we will be able to get as quickly as possible to answer these very, very important questions about Zika in pregnancy. So thank you. Muchas gracias.
Good afternoon. So today I'm going to talk to you about mobile biosurveillance and also re-emphasize some of the work we had done last year around Ebola and how we can apply it to Zika in future outbreaks and preventing them. So earlier today we've been talking a lot about healthcare, nutrition, and various technological innovations, but one thing I wanted to draw a parallel to is weather. Most of you in this room before you got to this conference checked the weather either yesterday or last week before you arrived here. But how many of you were aware that there was an ongoing norovirus outbreak here at the University of Rochester? Not many. So how does this relate now back to healthcare and mobile technology? Before I start, I'd like to show this slide that I always show at presentations. This basically is known as the hype cycle generated by Gartner, a consulting company. And currently we're in the hype cycle period of disillusionment when it comes to mobile health technologies, big data, wearables, etc. So that basically means that there's a lot of interest being driven around these, but only time will tell whether these technologies are going to really turn out and be able to help us in terms of healthcare, business, etc. So I'd like to draw an analogy again here between a paper that we released in JAMA that was looking at 21st century approaches to healthcare compared to what we currently do with healthcare. A lot of our work is currently focused on paper forms, being very episodic, which means, okay, there's Zika, now let's all deploy our resources at it. But are we really ready for the next infectious disease outbreak? Last year it was Ebola, this year it's Zika, what's it gonna be next year? Will it be influenza? Will it be, even bigger than that, SARS or something worse? So what we're doing here with mobile health technology is being able to do real-time data analysis. That means tracking infectious diseases, their symptoms, and being able to isolate those and geospatially analyze that information. So a classic question I always get asked when we talk about mobile health and using these as apps is that, well, in a lot of these communities, there aren't smartphones or they're using SMS or maybe they don't have phones. Well, the good news for those of you who do research in this area is that by 2020, 70% of the world will have some sort of smartphone technology. So it's prudent that we as researchers prepare ourselves for that future and not, again, set ourselves up for being reactionary researchers or scientists or public health officials, but really start to integrate ourselves into these systems, similar to how other fields are doing so. And lastly, in this particular presentation, we're going to focus on basically disease modeling, but obviously mobile health has other applications beyond this, telemedicine, reaching diverse populations, etc. So I'm showing you guys a slide here. This is the CDC recommended flow chart for how to handle the Ebola outbreak. So basically this is just when Ebola patients came in, they'd be treated at these various hospitals, and then you'd have to do this contact tracing. And so the way that was done was that you would ask a patient, okay, well, where have you been the last 21 days? And most people in this room, even if we asked you where you've been the last 21 days, you might not remember. And so while I was in Nigeria during the actual onset of the Ebola crisis, when they had their patient zero case, that made me realize that, okay, well, where can we use mobile health technology? There's plenty of people in these countries who have smartphones or even just basic cell phone technology. Why can't we start to use that in our health practices as a way to overcome some of the infrastructural barriers that a lot of us have talked about, whether it's lack of financing for the Ministry of Health, or whether it's simply that there aren't enough hospitals or clinicians able to service those populations. So here we have a similar chart that we had put together for our mobile health study. And basically what this means is, again, as the CDC recommended, the person comes in, they say, okay, they have Ebola, we proceed to provide them with treatment, but having this application, we can now geospatially look up information about them. So on this interface that we had put together during the actual Ebola outbreak, and while there was Ebola in Nigeria over a 3-month period, we were tracking about 70 or so participants with this application. So what that allowed us to do was first we were able to locate participants. So what that means is that anonymously they had this application. If they came into the hospital and said they had Ebola, we could look up previously where had they been last 21 days. And on top of that, we could then say, well, who were at-risk populations in those areas? So what that means is if you're a public health official or a developing country with limited resources, you can now send those resources to those regions without saying, okay, well, we think, it's in the hospital when actually that's not where this person was last week. Or, who are the at-risk populations? Additionally, that allowed researchers to be able to view, okay, this is where these outbreaks are occurring, and then enact certain decisions based on that information. So this is really now moving it from just saying, oh, we're having big data in these applications, but really trying to make actionable data. Furthermore, going back to what I said about the weather, when we came here, we were able to say, okay, today's going to be a nice sunny day. We prepared ourselves accordingly. Why can't we say the same thing around healthcare? Why can't we say that, in the next 3 months, this is where we think we'll have at-risk populations for Zika, and not just looking at climate data as to where the mosquitoes are traveling or where we think these mosquito populations are. Because for all we know, knowing that Zika now can be sexually transmitted, people could go to the Olympics, come back to Rochester, and it could spread here in Rochester where we don't think the mosquito will reach us, but our health system here is not ready for that. Or you could imagine other regions in the world where they haven't prepared themselves because they're looking at it from this is just the reach of the mosquito, we'll be out of the way. Similar thing happened when we had the Ebola outbreak. People were like, oh, this is a West African problem. We'll, send our resources over there, but we won't really prepare ourselves domestically or in other countries. And we saw what happened. Fortunately, we were able to curtail that situation. But you can imagine with future outbreaks, this is becoming a growing concern. So in this chart here, what we did was we used our 3-month data set, and we were able to simulate an infectious disease outbreak. So this wasn't a particular disease or anything. We just want to show that we could actually do this. And so what now we can do is we can tell people in the Nigerian CDC, Nigerian Institute of Medical Research, that look, if Zika came to Nigeria and it was spread sexually, this is how you should prepare yourselves. These are where there's going to be outbreaks. These are where you need to send your resources instead of waiting for us to hear back in 8 months, oh, Zika has now hit Lagos, Nigeria. They're scrambling, trying to deploy teams. And before then, there's hysteria and misinformation in the population. So before I switch gears from Ebola to Zika, we've left that project and we're working with the Nigerian CDC and other officials there to make sure that we continue to emphasize the importance of these applications so that should there be a future outbreak, which there was, the Lassa fever outbreak that's going on right now there in Nigeria, that they can start to use these tools to support their infrastructure. And fortunately, our project was actually selected by the Nigerian Consortium on Telecoms. And so what they were doing is it's a telecom and private health sector alliance to try and put into place some of these technologies. So we're working with them to try and implement this into their health framework. Now, how does this relate to Zika? Initially, Zika was thought to just be vector-borne illness, and this graph here just released today shows the range of the mosquito population that is capable of carrying the Zika virus. So right now you can see it's affecting, southern United States, and we obviously have South America, Central America. There's an at-risk from the mosquito population in India, China, et cetera. So basically about 1/3 of our global population is at risk, potentially, from this outbreak. And dialing it down more clearly, we can see in the United States the various at-risk cities across the US. However, again, these models are based on climate data. They're based on, okay, this is where we've seen the mosquitoes be, et cetera. They're not based on any human mobility patterns, not based on, actual social and economic data that's available in real time. Yes, we can use our census data, but again, going back to the paper, that's static information, which we're so accustomed to using in healthcare, but if you look at other fields when it comes to handling, let's say, terrorism or handling, various geoclimate threats and so forth, they're using real-time information to help, prevent hurricane risks and prevent earthquakes. Why can't we do that as health officials? So here I'm outlining basically what we are planning on doing with NODE, focusing on the Zika outbreak. And so we have 2 transmission vectors right now, either mosquito or sexual transmission. And our phase 2, which is being done on the application, is really trying to focus on symptom assessment. So asking people things like, okay, do they have rash, fever, et cetera. And obviously the question that comes up a lot of times is, okay, well, what about the asymptomatic cases? One thing we have to think about is that we as scientists and researchers have defined these symptoms based on our previous research experiences. For all we know, one of the symptoms of Zika could be, maybe people are restless when it comes to sleeping or something like that. Being able to report and gather that information may open up new ways of detecting and differentiating Zika from dengue, malaria, and other infectious disease outbreaks. In addition to that, we're also trying to harness our ability to do computer vision analysis. So people come in saying they have a rash or they have, red eyes. Well, a lot of various diseases show those symptoms, but could we use a big data set to differentiate between, okay, this is pink eye, this is Zika, this is dengue, et cetera? Can we start to use that data and not just simply, catalog it and say, okay, well, that's a rash, and hopefully we'll develop some sort of blood test, which, we're trying to get online while there's an actual outbreak going on. And then lastly is being able to give this information back to public health officials. So being able to say as a state governor or, a local health official that, okay, I know my hospital in these regions are at risk. I have people who are ready to respond to that crisis should it arrive. So as I mentioned earlier, in these regions where you have Zika, you also have dengue, chikungunya, and other infectious disease outbreaks. And you see a common theme throughout all of them is, okay, there's fever, there's rashes, and so forth. So what we're trying to do is be able to collect the various information around that and compare that with clinical diagnosis and say, okay, this is what a Zika rash looks like because we were able to use a computer algorithm to determine that. Or this is what, dengue looks like. So being able to do that in real time now can improve health infrastructures in these nations and globally in response to these infectious disease outbreaks. So right now I'm just going to show you some of the slides that we're preparing for the next application of the mobile app. And the plan here is that we're going to have this online within the next month. So in preparation for the Olympics, which is probably when we're going to see a massive uptick in US cases potentially. And also being able to translate this into Spanish and potentially French or another language so that it can be used broadly across the globe. But basically what would happen is someone would be asked, some symptom questions, are they male or female, are they pregnant, et cetera. And beyond just the instance of Zika, really being able to feedback into what some of the other presenters were talking about, which is maybe at birth there's no symptoms, but maybe 5 years down the road, that child starts to show symptoms. Using a mobile application can allow parents to easily track this and then feedback into public health institutions such as the CDC, NIH, and various government officials and start to use that information now to determine how they're going to respond to this in the future. So lastly, as I mentioned, we're going to ask things like, okay, do you show fever, rash, et cetera? Have you had sex in the last 24 hours? These kinds of things so we can start to break down our diagnosis and be able to say, okay, in these regions, we're seeing a lot of sexually transmitted cases, but there's no mosquito population there. Maybe we're seeing there's no sexual transmissions, but we're using now humans as an indicator as to, yes, the mosquito population potentially has moved this far in the United States. Even though our current climate models and various other models have not indicated that, we're seeing those symptoms show up in our population. So broadly speaking, as I mentioned, we're no longer trying to make everything episodically focused. So that means come this conference next year, hopefully there won't be another massive infectious disease outbreak. But if there is, what are we really doing to prepare ourselves using this kind of technology? So I see this being used in four aspects. We can start to use this as a way as a preventive tool. So the same way that you're checking the weather, the various NOAA, various government organizations are telling you, hey, there's a flooding risk. You prepare yourselves for these events. So that's the value in using this application is to say, okay, from a public health standpoint, if you knew there was norovirus here, you would prepare yourself accordingly. You take extra precautions to make sure you're proper, you're doing proper hand sanitization, et cetera, and so forth. Or if you need medical assistance, who to be in contact with. And this is a huge concern because during the Ebola outbreak, while the Nigerian government, ramped up its efforts, you had people saying, okay, well, you can take baths with, let's say, sea salt or, do all sorts of crazy things because there's nobody in the health community speaking yet. And so being able to get that information out there immediately can be of great value to public health officials. And then moving to the next phase, which is really intervention. So we talk about communities which might not be able to be reached physically by roads, or they might be washed out, or they might be in remote areas, but somehow these cell phone technologies have penetrated these communities. So how can we use those to hook those people in with the health infrastructure? Because if we look at our current means of identifying Zika and various infectious diseases, we have a very hospital-centric model. And this goes back to some of the earlier discussion of, we're very Western educated, and that's kind of the way that we were taught, that the hospital is the center of our health structure. But in a lot of these countries, it's not. We're introducing these hospital structures. And so they're saying, well, they're not comfortable telling their physician and so forth. But we really need to know that that's what's going on in these communities because, we want to help them and we want to be able to access them. And then the next one is management. So people who have these chronic conditions, let's say you're looking at malaria or AIDS and so forth, how can you use the mobile health to engage them, to make sure they're receiving medications, to reduce stigma and barrier to accessing these medications? And finally, mentioning what I was discussing earlier, being able to predict these disease outbreaks. So post-Zika, post-Ebola, what are we doing? Are we ready for the next infectious disease outbreak? Because if you look at what happened in the past, as it was being mentioned, we've had SARS, we've had avian flu, swine flu, et cetera. Why do these things keep coming back as if we're not learning from our previous instances? So with that, I'd like to conclude. So thank you.
Great, thanks very much for the great discussion, great questions. And I think that this would be a good time for opening up for questions. And I want to make sure that folks go to, when they're going to the mics, so please identify yourself. We have about 10 minutes for questions. So maybe if we can have the speakers come up to the area, please. And while going, Salman, I had one question about the app. I wonder if you, because you have now so much data, are you able to predict within the outbreaks how the model would have predicted, say, how Ebola would have spread, given the fact that you know the data as of whatever time, or how any of the infectious diseases? So if you want, can you talk about that? Before spreading it, before rolling it out, to see if it can be predictive, to tell people to not, be cautious about going somewhere in real time.
So the question is asking basically about the predictive capabilities of the app now that we have this information. And so none of the people in our study had Ebola, so we can't compare it to, let's say, mathematical models like, SIR and all these models. However, we were able to send out notifications so that if there was an Ebola case, immediately people would have found out on the application that there's an infectious disease outbreak. So I don't know if that's addressing your question or.
Yeah, I think it would be helpful as rolling this up, because this has huge potential, obviously. But obviously, one has to be very careful about calling something about how don't gather here, because I predict in the next week something is going to happen. So to get buy-in for people that this is important, you could maybe use the data from each of the outbreaks that had occurred from whatever point to the end, and seeing how the data were entered, enter it at this point and see whether the model that you would have gotten, did it predict actually where you ended up in T whatever. So that's what I'm saying, is that if you
Okay. Yeah, so we haven't validated against actual data, and that's simply because we didn't, again, nobody in that actual study group had the infectious disease outbreak. But I do understand the question was just really that if we put out there a model saying that, oh, there's going to be infectious disease outbreak and there isn't, then you run to the classic problem of you lose trust in the health system, that, well, you're talking nonsense and that we don't trust you. So that's why we do have to be cautious with the information that was being put out there. I think that right now what we would probably do in terms of a next step would be to say various risk levels. So we wouldn't per se give that kind of information to the general public. It might be something we share with CDC or NIH that we think this area is at risk for Zika, but that's not something that someone on the application would see. And that way people who, we work in this area, we would know, okay, this is the validity of that data. I know how to put it into other models and information that I'm receiving.
Great, thanks. Go ahead.
I think the gentleman over here was here first, so he can go ahead.
Sorry, Neil, go ahead.
Well, thank you, sir. I actually have one comment and a question. Hi again, my name is Jackie, and I work here at NCDHR. I noticed that for the mobile applications in the most recent talk, you had the option of men and women, but I'm wondering if you have an option also for those people who might be transgender or might be transitioning. And also, my second question is, I know that you're sending and receiving data through those apps, but I'm wondering, does it work on a data plan or on Wi-Fi, and is that something that's accessible? Even here in New York, there are places where Wi-Fi connection is spotty at best, and so, and if you're using a data plan, it can be expensive, especially in those countries.
So to address the first question around the questions, this is kind of to give you a feel for what the application will potentially look like within the month. So we are going to obviously change the gender questions and so forth and get some validation just from the sensitivity of the questions in general. So that way they're better suited for the populations. Addressing the second question around data connectivity and so forth. So that was one of the key aims actually of our NSF grant, which is that a lot of people are like, okay, well, you can do these smartphone kind of studies, but we were collecting data actually on a 5-minute interval in Nigeria, which, is a developing country, but these, the users were all the way from like students to adults, so various different socioeconomic backgrounds. Because you imagine as a student, you're not going to be spending that much money on a data plan, but they were still able to participate and we were still able to get useful information out of that. So that's how we're kind of getting around the data connectivity issues. Fortunately, the app, when we did test it, we looked actually at data connectivity and battery life. Because in a lot of these developing countries, you don't have a strong electrical infrastructure. So it's not just the data that can be a problem, but also being able to charge your phone repeatedly if we're accessing this much information. So that was one of the key things that we optimized the application for.
Neil?
This question is for Dr. Cordero.
Yes.
Regarding the Zika outbreak and the 71 pregnancies. So first question is the mortality of an infant that's affected in the first trimester high? And the corollary to the question is, what is your advice now and screening for the women who are pregnant and are infected? So are they given multiple ultrasound? Are they given more this test or that test?
Great. Thank you. From the Puerto Rico data, we don't have evidence of an increased risk for adverse outcomes, but from the data from Colombia and from Brazil, and but also in a review of the data from French Polynesia, there seems to be an increased risk for pregnancy losses, early pregnancy losses, and stillbirth, and so that's something that we will be looking at in the cohort study. In terms of the recommendations that CDC has currently, is for all women living in an endemic area would be to test in the first trimester, second trimester, using serology testing to see whether they have evidence of infection or new infection. The recommendation for once there is a diagnosis or clear the definition of infection is to follow up with ultrasounds like once a month, and obviously together with that a great deal of counseling to the mothers, and that's something that's been done in Puerto Rico. Dr. Cerilla and her group actually have developed a clinic just to attend many of these pregnant women, and that's what they are doing, monthly follow-up, but also a lot of support in prenatal care, because especially not knowing what the risk is going to be, but also that if there is a decrease in the head size or there's a stop in the growth of the head size, that actually women could be appropriately counseled.
We have time for one more question. Yes.
My question is actually a follow-up to Dr. Cordero, the response that you just gave. This is kind of controversial, but given that now we can screen prenatally, a woman can be screened to see if, they're possibly carrying the Zika virus, and then recommendations are given to her on what to do. We're seeing, obviously, probably increase in ultrasounds. I'm actually wondering if we're also seeing increases in abortions. And, given the sensitivity of the topic, if you can speak towards that. Okay.
Yeah, let me say that my early background in medicine is actually in prenatal diagnosis, and this is in the 1970s. And at that time, there was this question of should you do prenatal diagnosis, and because of what it means in terms, and that was a time when abortion was not actually legal in the U.S. But I think that one of the things we learned from that experience, and I think it applies to your question, is that there are two parts to it. One is that it is important for women and for that couples to be informed of what are actually the facts and the evidence, whether in fact it is infected or not infected, or if it has a serious birth defect or not. The question of what to do in terms of the pregnancy, it's not about whether we would recommend one action or the other, but actually laying out what are the different options. And I can tell you that there is a big spread, and often it's very hard to predict what would be the decision of the woman in terms of what they would like to do in terms of the pregnancy. With a few women that we have had contact that are concerned about that, actually the point is I want to know, but even if I know the baby may have a serious defect, I'm going to continue the pregnancy.
Interesting. Thank you.
Great. Thank you very much for a session. This concludes the session. Now, thank you again.
So as you can see on the slide, we're going to move now into our breakout sessions, and the room numbers for the specific topics are up here on the screen. The global cancer control is right here in this auditorium, and the other three are right outside this door and down the hall. So just keep walking past the registration desk. We'll reconvene in here at 4.
said you're supposed to see.
Yes, we met at the
Yes. Okay, yes. And then,
her poster.
and then I think you sit here too.
No, I'm gonna take a real quick shot.
Okay. Sure, yeah.
Just so I
But
don't.
we'll wait for the audience members to come in. Becomes really confusing is the time zone. So I'll often, when I'm doing an email and put the wrong time zone, you put the wrong time, and it's or I'll recalculate So we're using all microphones, and when we begin the discussion, we'll use the microphones too. So thank you for coming to this second to the last session here, which is entitled, let's read it correctly, Policy System and Environmental Interventions in Global Cancer Control. And here this afternoon, we have our two co-facilitators, and I'm going to just read a brief introduction. And for a full introduction or for their full bio, please refer to the program. So over here to my right, we have Dr. Karen Peters, who's an assistant professor of community health sciences at University of Illinois Chicago School of Public Health, where she currently teaches graduate and undergraduate courses on global health and health policy. She currently serves as a co-investigator for the Illinois Prevention Research Center as the center's evaluation lead, and is also principal investigator for the center's special interest project on global health, which involves conducting a study on cervical cancer prevention in rural Senegal. Dr. Peters serves as the director of the Illinois Area Health Education Centers Network Program, which is a statewide network of 8 centers focused on health workforce development throughout Illinois. Her research interests includes community-based participatory research, policy and program evaluation, and interprofessional education and practice. And then we also have Dr. Neil Palafax. Again, for his full bio, please refer to the program. Dr. Neil Palafax is currently Professor of Family Medicine and Community Health at the John A. Burns School of Medicine, University of Hawaii, and Clinical Professor of Cancer Prevention and Control at the University of Hawaii Cancer Center. From 1983 to 1992, he worked in the Republic of the Marshall Islands as a physician and medical director of a U.S.-funded program to care for the radiation-affected people of the Republic of Marshall Islands. The last 25 years of his career has focused on reducing health disparities in the populations of Hawaii and the U.S.-affiliated Pacific Island jurisdictions. This work has been done through health workforce development, affecting health policy regarding standards of care, systems-based development, utilizing a community-based participatory approach, and developing key partnerships with health leaders and policymakers. He has published over 70 peer-reviewed medical journal articles in cancer control and prevention, health effects of the U.S. nuclear testing in the Pacific, cultural competency, health disparities, vitamin A deficiency in the Pacific, and ciguatera. Finally, he is the principal investigator of two CDC-funded grants to reduce cancer disparities in Hawaii and Guam. And that's the NIH grant, and then CDC disease prevention grants in the U.S.-affiliated Pacific Islands, focusing on non-communicable diseases. So we'll start. So each of the co-facilitators will do a brief introduction of their work, and then we'll open it up for discussion. So we'll start with Dr. Palafax. Actually, either way, I can advance your. Maybe you can just come up here so you can do the. Since you know how it works.
Thank you, Angela. I look out in the audience, it looks like Micronesia, one island there. So, well, what I thought I'd do to begin, but thank you again. I'm finding this conference very informative and just learning so much in a lot of different perspectives. But instead of talking about the actual projects I have, and there's a list at the end, I just wanted to make sure we start from a place that everybody understands what it means when we say policy systems and environment, working with that, because I think when we're working with it, it's a relatively new paradigm of thinking about how to work with health projects. So I was going to go a few slides through that, and then certainly as the dialogue unfolds, can talk about individual projects. And so one of the things about policy systems and environmental changes, it really should be comprehensive, meaning that it touches all parts of the community, the government, restaurants, health systems, schools, and work sites. So it's, again, a comprehensive way to look at things, and it's done in a very particular way. So policies are rules that encourage or discourage certain behaviors. Systems are changes in how things are done in an organization or setting, and environmental changes are physical changes in the places we live, work, play, pray, and go to school. So when they talk about PSE as policy systems and environment, and this is what they are speaking about. Now, how is this different than how we used to work, or at least how I used to work, I should say? Before, we used to work in events, so we'd either set up an event, there's a National Nutrition Month, or open the school gym during a community fair, promote Bike to Work Day. So that's an event that we used to do as a project. But under PSE, actually you're sustaining an action over time. And so instead of having this pass out fruits and vegetables at National Nutrition Month, you add more fruits and vegetables to cafeteria choices. So you see it reaches a larger portion of people. It's not a single event. It is a structure that you're building in over time. Instead of opening the gym during a community fair, you develop a share use agreement with the school so the gym remains open. So again, it's a very different way of thinking, and again, it's not putting on a car wash. It's really setting up a car wash that's free forever, that kind of systems way thinking. And again, it's not providing a healthy lunch at a work meeting, but you get the dean of the medical school to say only healthy lunches are supposed to be brought into the cafeteria at this medical school. So in the U.S. affiliate, the REACH projects, these are some of the things that we have, including expand tobacco-free zones, protecting against tobacco industry interference, water, coconut, water, healthy foods, settings, and organized functions, workplace nutrition policies. And they're happening across all the different areas. But I don't want to talk about these specifically unless you do or put it in the context. I really wanted to generate a conversation more about what PSC is and what it isn't, and as opposed to talking about an individual project. And again, I'm hoping that all of us discuss specific PSC projects around your areas of interest that might be helpful. So again, I'll just start there with just a conversation about what PSC is and how what I understand it to be. Thank you.
Yeah.
How do we get her slide? Thank you.
There you go.
Thank you so much. Great. How do they advance? That's the next question. Am I advancing them? No.
Just use the arrows on the keyboard.
Okay, I can do that. Or I can, there we go. Wonderful. Thank you. Good afternoon, everyone. I'm going to do a quick shout out to my city, Chicago, and I invited my students to join the session this afternoon, so I'll say hello to them as well, my global health students, and also wish my Chicago Blackhawks hockey team good luck this evening, so they need it. I'm a Chicago girl, so I have to do those things. I'm very pleased to be here to talk about our project very briefly in the policy systems and environmental context that Dr. Palafox just mentioned. I'm at the University of Illinois School of Public Health in the Illinois Prevention Research Center, and as Angela mentioned, we are one of the two collaborating centers with the coordinating center here at the University of Rochester, and our project is focused on work in rural Senegal. So the context for our project is we're very interested in policy, with one of our major goals looking at how can we work on both vertical and horizontal and vertical scaling of, in this case, cervical cancer policy in rural Senegal through a very community participatory based approach. And then secondly, in order to do that, we feel strongly that that has to sort of happen through academic partnerships. We actually are partnering with the Peace Corps as a very community-focused partner, and we're interested to seeing how can that type of a partnership result in some policy development and policy transformation. So what we've been doing to date are sort of listed here in our, in our activities. We have started working on developing some clinical guidelines outlining a cervical cancer prevention service in the areas that we're reaching. So that's a piece of our policy, to get sort of policy guidelines where they currently do not exist. We're also using Engender Health's, a modification of the Engender Health's client-oriented provider efficient COPE mechanism, which is a clinical quality improvement process, so that we feel helps to improve the health system at a very local level. We've been training local healthcare workforce in visual inspection with acetic acid, or VIA. We heard a little bit about that this morning in one of the talks, as a cervical cancer screen and treat type of mechanism that can be done in very low resource settings, where we are currently working, where there is no capacity for laboratory types of screening services. So training that health workforce in this kind of technique, we also feel kind of is a systems approach. If you think about health systems, strengthening is one of the major blocks in improving health service. According to the WHO, we feel that providing that training for local health workforce helps build that health system. Similarly, training physicians in cryotherapy as a treatment. We can't just screen, we have to treat, right? So we do VIA and then cryotherapy as treatment as needed. And then we're conducting some surveillance activities, surveillance studies in these rural areas where there is no local prevalence information about cervical cancer outside of the capital of Dakar. So we've been partnering to do some prevalence work as well. Why are we doing this? Well, we know the theory goes that if you can improve, if you can make a health system responsive to the needs of the people, that may help to increase access to their primary health care. And then if you have access to health care, the theory goes, right, that you will improve health status. So that's sort of the model that we're working with. We also know that in many low and middle income countries, the local health system may not have the capacity to deliver on basic primary care services. And so in order to address that capacity gap, which we see in the places that we're working, we have been asked by health leaders, local and regional health leaders to come in and help address the issue of cervical cancer prevention. And so we've been invited as a partner to come and do that. One way that we have been able to be fairly successful in this is then to involve Peace Corps volunteers, along with us coming from the academic side, in a model and where we feel that we can improve capacity using a very community-centered approach that has some sustainability built into it. Excuse me, this is a little map of Senegal where we're working in sort of the southern areas, both very, very rural. And excuse me, you can see sort of the health infrastructure, or the limited health infrastructure, if you will, of the two regions that we're working in. We were asked to kind of talk about lessons learned, and I hope we'll have more dialogue about this as this session progresses. But as we know, when we're working in global health contexts, right, we get our grants and so forth, and we have our timelines and our outcomes, but it's really, really important to build in some flexibility there, both on the side of the people implementing the project, and I also think in terms of the funder. For example, in our case, Ebola resulted in us kind of missing one of our site visits because we didn't want to come and burden an already very burdened local health workforce battling, Ebola, to come and sort of help us continue with the next phase of the project. So we sort of had to build in a flexibility there in our own schedule. I put in this quote again from Margaret Mead: "Never doubt that a small group of thoughtful, committed citizens can change the world. Indeed, it's the only thing that ever has." We hear that a lot of sometimes the younger generation sort of very aspirational, but in this case, I think this really does have meaning in our project. We've started out as a very small group and have done what I feel are pretty amazing things. You can't really take anything for granted, and you sort of have to make the most and celebrate what you have. I put this woman's picture up. She was one of our key partners, a midwife in our region. She was killed in an automobile traffic accident, working not in her official capacity, but putting in some volunteer time in a horrible road traffic accident. And we saw one of the slides earlier today that I think Dr. Smith showed us, and the road traffic accidents, along with the chronic diseases of cancer that she showed us, there is a trend line going up. So it just sort of brings to mind about it's not doing the project and getting the results, but it's also who are you working with, who you get to know, who becomes really part of your family. We very much miss this woman, and she has served as an inspiration to us. We ask all of our partners in sort of an evaluative way, you know, one of the questions, you know, what does it mean to you to live? And her response, to live is to be in a state of wholeness, where by giving yourself to others, you find peace within yourself. So from that, we continue with our work and to be very much inspired. I look forward to talking about the project and sharing with the group here our thoughts and getting your thoughts as well. So thank you so much.
Okay, thank you. So right now, if you have any questions for discussions or comments, this is interactive, so it's actually not necessarily just questions, but if you have comments to add, please speak on the microphone. And also to remind folks that this is live stream, so it sounds like we have a whole class listening in too. So that's great. Dr. Peters has a class. And I think I forgot to introduce myself. I'm Angela C. I'm with the University of Hawaii School of Medicine. I actually work with Dr. Palafax, and my relationship with the Global Health Territorial Group is that we partnering with the project here. We're looking at 2 pilot research projects in Pohnpei State in Micronesia and in the Marshall Islands, using some electronic communications to promote or to prevent diabetes and promote health. So if folks have questions, and if not too, I think the panelists also might have questions to generate discussion. So this will open this up. But again, also too, if you have particular questions about the policy, systems, environmental change, you know, we can talk about that more, as you could see from the 2 speakers. And I know Dr. Palafax actually had more slides too on the importance of PSE change. And I suggested that, you know, he was supposed to do an abbreviated introduction. So, but he had a few good slides on the reasons why PSE is important. And as you could see here with the examples of Dr. Peters, that you know, some of the importance of PSE is that it creates some sustainable changes in the community. It helps to build more capacity in the community. So with the PSE change, one of the goals is to make the change so that it's permanent and lasting. And we'll open it up for discussion.
So careful, if there's no questions, we're going to ask questions.
Did you also have questions for the audience too? Yeah.
I do, but I just wonder if there's questions first, and then, but if there's not, then certainly. Yes, Dr. Cordero.
Well, I'm really happy to see the table that you had, you know, before and after in terms of a PSE. And can you talk a little bit more about what are the factors that actually have allowed you to move, say, from having a day where kids come to school in bicycles versus having a system that allows for children to do that on a regular basis? I'm just using that as an example, but what do you think are the key changes or transformations have to happen or that need to be addressed in order to result in such transformational change?
So as I understand the question, for PSE to work, I think one of the fundamental things, Dr. Cordero, is that its relative impact. And so I think the way that, I'll just say that I worked before was doing multiple types of events, you know, having communities in some parts of Micronesia having a vaccination day, having their one-off type events with the idea that it's going to improve health for a very short period of time. So part of the transformational thinking is really understanding that that in fact turns out to be a one-off thing, and there's sometimes no sustainability behind that, no follow-up. And so the transformation is, how do you get the entire environment to change? And so the way you transfer the environment, as I think you're alluding to, is you have to transform the policies that make something happen, the systems that make something happen, or the actual environment. And so some of the things that we did were, for instance, in tobacco prevention, for instance, one of the things that we tried to do was, instead of having a tobacco quit day, and you go to school and you tell everybody, oh, this is the kick butts day, and then you do that, and then it sort of goes away, is we went to the churches and had the churches say that as one of their pronouncements is that tobacco is in fact not a good thing, and it's not allowed by anybody on their church grounds, not only on Sundays, but ever. You can't come on the, and in fact in American Samoa, that's what they did. So it has a long-lasting impact that is blessed, so to speak, or condoned is the wrong, is supported by the church leaders that exist over time. So it's what we call in the PSC a small p. So a lot of times when people see the word policy, they think, oh, you got to go through, all the legislature and the governor and these kinds of things. But that's a big P. But small p's are you change church policies, or you change the school policy, like there's no soda machines allowed on campus. That's changing a small p, but it's in fact a policy. And so but the transformation of thinking again is going for a long term, and it's not episodic, and that's actually measurable. So, and what's measurable about it is, for instance, in the church, things we actually drop in and then see who comes to church or walks through the church grounds and is smoking. And then you go tell the pastor and say, there are 5 people, and then he says from the pulpit, one of our policies is. And just a real quick one that also I think makes the case is, and it's around nutrition. It seems like a simple thing, but in churches, they used to have, a lot of times they have very big festive, and I'm sure in Puerto Rico like they have in very festive gatherings with a lot of big meals and so forth. So one of the things that was a declaration is, whoever puts this on, one is there can be no sodas, and 2, the vegetables have to be at the front of the line. Sounds very simple, but that kind of change gets, everybody has to pay attention because you have to listen to the pastor. So it's that kind of transformation and the thinking around that. But again, it's, but it does take a lot of work to do that, but I think it makes it more sustainable, it makes it longer lasting, and it's a small p policy change. So I don't know if that answers the question.
I might mention from our project as well, I like your comment about big P, small p, and those sorts of things. I feel that's a really critical piece, because I think people think policy, it's sort of formal government policy, and it really doesn't have to be that. In our case, I mentioned that we're trying to do both sort of horizontal policy change and vertical policy change. So we're trying to work in the small p horizontal, if you will, policy change, just to simply implement some policy at the very low, at the clinic level or at the health post level. And then hopefully kind of horizontally, if you will, scale that to other clinics and other posts. And at the same time, as we're involving more formal members, if you will, of the health infrastructure, going from, the clinic director up through perhaps the district medical director, and then up to the regional level, trying to vertically scale policy about cervical cancer prevention to try to get to that big P piece that you were talking about. I really like that that idea as sort of, you know, a way to think through how to do perhaps very localized kind of global health type of research work. In terms of systems, in our case, again, we're working in systems in the small s, if you will, simply by providing different kinds of training to help with systems transformation. How do we get some additional training that has been requested from the local health authorities? It's, I think, a way that the partnership works really nicely, because it's not us saying, you need to have this kind of new content or information. It's very much based on what they want to learn more about and know how to improve upon. So putting in very simple kinds of clinical protocols that perhaps they hadn't had before can result in kind of the small s systems change kinds of things. So I think the idea also, for me, important is the sustainability. You just mentioned that at the end of your comments, because we have partnered with the Peace Corps. Peace Corps people are there all the time. We, as coming from the academic side, can go 2 or 3 times a year. But, you know, and we have built very close partnerships and friendships with the people there. But the Peace Corps volunteers really serve as that linchpin of a constant presence, not just sort of the academic partner coming in, doing their thing for 2 weeks and sort of leaving. So I think the sustainability factor is another important kind of component to PSE, whereas you were talking about the sort of the episodic way that we used to do things. Now, if we can think through how do we sustain these efforts and think about partnerships that allow us to do that.
And what?
If I could have a follow-up comment. Thank you for the description of the small p and big P, because it reminded me that how important the small p's can be at some points. We passed a law in Puerto Rico for basically non-smoking, but it was actually a smoke-free environment for everyone, and that included all the hotels. Like, none of the hotels can smoke, and including the casinos, you cannot smoke at restaurants, etc. And that law passed, and but then the owners of the hotels and the Puerto Rico Tourism Company came back and wanted to rescind the law, and because they said it's going to make us lose clientele and we're going to lose the tourism, etc. And but the employees at the casinos have been so well educated in the process of passing the law that they said, hey, wait a minute, you're posing a big risk to us. If you do that, then we are not going to accept the current contract, which is based on non-smoking. You're going to have to pay us more and give us a bigger pension, because we're going to have from secondhand smoking a lot of cancer. And when they went back, the companies went back and realized, oops, that's going to cost us a lot more. They decided to rescind and not try to go for a change. And actually, the result, the end of the story is that Puerto Rico actually is doing very well. The casinos in general are doing very well, and the hotels are filling up until the Zika thing happened. But it has been a very positive result.
Well, thank you. And real quickly, one of the things about PSE as well is that it should be evidence-based stuff, evidence-based type PSE. So in other words, at the churches, I wouldn't just invent something like, oh, Pastor so-and-so, could you put up a statue of a person smoking and they look really ragged, and, you know, because, you know, that's my opinion of what might be a good policy, but that's really not evidence-based, that's Neil-based or something. But I think the idea of PSC should be evidence-based, but it's also, and very importantly, it can be evidence-based from the community. So the community might say, for us, you know, it's not verified at the CDC or the NIH, but for our community, we've done whatever polls. And this, in fact, is something that for us is evidence-based, but that evidence-based component is a very important part as opposed to a pastor themselves going out or me just suggesting something I think might work without having anybody else's opinion or thoughts on it.
Do you actually have questions for the audience by any chance? Maybe, go ahead.
I'm always interested in, I'm sorry.
No, go ahead, please. And then I'll.
I'm always interested in the issue of sustainability and how sort of best practices or emerging practices or how to best do that, excuse me, when we're working in the global health context. I think it's something we struggle with domestically, but you know, when we're also having then sort of the distance issues and cultural issues and language barriers and all these other sorts of things that we sometimes, you know, are perhaps magnified a little bit more when we're working in global health context. I'm always interested in people's thoughts about how to best address that question.
I'm a returned Peace Corps volunteer, and that was a key word. We used to give sustainability high fives. So my primary project when I was in Western Samoa was working with a little boy who was deaf. And my way to make that sustainable once I left after 2 years was not just to teach him sign language, but to teach his mother and to get her to become a certified instructor so she could go through all of his classes and stand next to the teachers and sign. And it all worked very nicely, which is not always the case with Peace Corps projects, unfortunately. But I kind of started to phase myself out in the last 6 months that I was there and kind of let her run the show and start, you know, signing and as I, you know, was getting ready to leave. And that worked really well for me. And I think that you had mentioned before, it's hard when you're back and forth and it's great that you're collaborating with the Peace Corps because they're there. Right. And that works really well. And so I think that it's the whole, you know, teach a man to fish and can feed himself for life kind of idea. And I think that can work with any sort of global health project. It's training the people there to work for it. And that's what I've always kind of thought of with my work then and now.
Thank you.
I have an observation. I don't know if it's best practice around sustainability. I don't know. That's not the way I'm able to really think about it. But thanks. So, two things I would say. One is, I think having a real connection. So I call it the anthropological component, but it could be community-based, whatever, but it's really, and Neil said this before, if you're committed to people and they sense that and you're really developing a commitment, it just seems to have a different nature than when you're there to help. And so sustainability is different. You know, and I've worked on projects where there definitely is this different level of commitment and level of interface. So it's kind of tough to tease out who's them and who's us because we're all kind of mushed together. So that has something to do with sustainability because then we're all kind of in it together somehow. But there was a project I worked on, and we worked on it for a long time. It was a big project, and there ended up being an uprising in this place. And we had to be evacuated, and we're never allowed to go back. So like that, I mean, 1 minute we were there, and then after they could find us and we were evacuated, we were never allowed back. And interestingly, all of our in-country partners kept going on and continued to do the project. So for us, we always saw that as a lesson in sustainability, and almost in a way that, you know, that was a way we could see that that worked because the project kept going on, and it was their project. And so we kind of saw that's not a best practice, but to me, having that way of working with one another over the years, you know, we could just kind of drop away, and the project kept going. So that's a lesson in sustainability. I don't know if it's a best practice.
I wouldn't recommend necessarily having a revolution and being evacuated, but.
Thank you.
So a comment around that, Dr. Dye, is one of the properties, I think, of sustainability. So a lot of people think it's just the financial sustainability of something, and if you can keep the equipment and so forth going. So that's one part of it. But I think in the work that I do, the most important part is finding a local champion, someone who not only understands what you're doing and has the capacity or learns the capacity, but feels that burn, because they're the ones that, after the uprising and all of that, but without a champion, and that's part of the whole PSC thing is, whether it's building a bike lane or having, no donuts at a global health conference or whatever it is. No, the champion is a person who goes out there and makes sure that that's what happens. And they continue it because it becomes part of their passion. So I think that's what you saw, is that whatever you did, I believe in your work, you developed probably a couple community champions that not only saw the wealth of this and the purpose, but kind of felt that this is important work, and they continued it. Because I find that if you do have a champion, they'll find a way. And the converse is true. If you don't have a champion, as soon as you lose a grant, the work's done.
Yeah, then it is about the money more. Because
Yeah, yeah.
I guess I have a question too for the audience. Thank you for sharing about sustainability, but does anybody have any other experiences, whether locally or abroad, with policy systems, environment change, and examples that they'd like to share? Yeah. Thank you.
It's actually a little bit of a question too, but one of the problems we have in Puerto Rico, and I think it's something that happens in other countries, is that when the government changes, everything changes. And I had the sort of sad experience that working in Honduras for 3 years in developing the policies for fortifying cereal grains with folic acid. And it took that long. We got it through, but that was like 2 weeks before the president of Honduras was going to change. And although the next one was from the same party, they were not interested, and we had to start at square one. And actually, the question then came, what do we do? And turns out that looking around for what were sustainable types of policies was that actually what happened, not within the government, but within non-government NGOs, basically. And that the NGOs were the ones that actually could get sustainability, basically that even if the government changes, that would continue with the championing for whatever the issue was, whether it's early childhood or in this case, folic acid. And taking from that lesson, we worked with the Inter-American Development Bank to fund NGOs to actually get the policies of folic acid in Central America, and that worked. But that was a tough lesson to work very hard and then see that in a day almost all the work was falling down because of that lack. And in a way, so first having the right kind of champion, but also finding a way that the infrastructure that allows it to continue from one government to the other.
Right. Dr. Cordero, that's a very good point. So certainly, like you mentioned, in the areas I work in Micronesia, and it's probably true with a lot of politics, if you align with the political system, if that system goes out, you're identified with them, you sort of kind of lose your credibility as well. So I think what you said is so astute, and it works really well in the areas we work in, is, you work with the community in a community-based fashion. and they become your champion because they're the ones that are always going to be there, and they're the ones that vote in X, Y, or Z. And so, but I think sometimes I've also seen it the other way where you want to get something, where I wanted to get something through quickly, so I had a particular legislature in Hawaii even champion something, and then it didn't work out or they got removed and the whole thing dies. And then other people who didn't like the guy, they automatically don't like you. They don't even know why they don't like you other than, the other guy liked you. But so I agree with you that being savvy of the political system and the community system and the relative balance is extremely important, extremely important. And in fact, the story that there's one of the jurisdictions I work in that the director of health changed, and he didn't like one of the coordinators of one of the programs that Angela and I work with. He won't talk to him. He won't give him the time of the day. He won't sign off on anything. So it freezes everything, but the coalition behind him sort of makes things still happen. But the director, frankly, just doesn't like the guy, and so it's a personality thing. So, but because the coalition is strong, they understand it, and they just kind of work around him as best they can. But he's still in place, and hopefully the next election he may not be in place, but it's one of these things it's a reality, and I think to face that, is important.
Okay, so let's wrap up. And so just to summarize, so this PSE, as we've heard, the PSE can take many forms, big P, small p. Also with the systems change, we've talked about changes in systems like with NGOs. Using coalitions is another systems change. In addition to the government, worksite, churches, those are systems change as well. And then bringing it back to the themes of technology, maybe something that we can begin to think about is how, both of these approaches in public health, PSE is considered somewhat innovative in public health change, technology, of course. How can these two work together? Can it work together? Is technology part of PSE change? How can technology be part of PSE change? So, for the next year, perhaps we can think about that until next year's conference. So thank you very much. Are we back? Are we back in here?
I think we come back at 4 o'clock.
health experts and people who've worked in this area. It's designed to appeal both to students and for those of you who are studying or interested in studying global health or becoming involved with global health, and also for people who are involved in research and would like to either expand the research or do more research around global health. And so we've selected some of the folks that are involved with our global network up here, and I'm going to ask them to respond to a few questions. And Deb Ossip is going to be joining us a few minutes later. She's teaching right now. So the first question I'm going to ask, and I'd like we could just maybe randomly start and go through each person. I'd like to hear just a sentence or two about who you are from a sort of disciplinary background, like what type of global health do you do? And if you can tell us what your first experience in global health was, and tell us a little bit about that experience and what motivated you to become involved in global health. So that's the first question. So maybe we'll start with Karen. Would you like to go first?
Sure. I'm happy to do that. Thank you, Tim. So my background is public health. I trained at the University of Illinois at Chicago School of Public Health. I have a DRPH, a doctorate in public health. Sometimes I have to explain that. It's different from a PhD. It's kind of the more practice-oriented degree. And actually, I was never formally trained in global health at all. We didn't really have a global health presence when I was in my training time. So for me, it was all sort of serendipity that I would find myself now teaching global health courses and doing global health work. So I'm a little bit late to the game, as it were. But my first experience in global health was in Colombia, working with some colleagues. I have a background in evaluation, and they asked me to come down to the National School of Public Health in Colombia to talk about evaluation, and introduced me to some community-based research they were working on in the Colombian Amazon, and that kind of hooked me. So it was fun. Continue to do that work.
My name is Haq Nawaz. I'm at Griffin Hospital, which is in Derby, Connecticut, in suburbs of New Haven. And my first exposure to global health was actually when I moved from Pakistan to US. And I did my master's in public health at Yale, and my concentration was in global health. So I think that was sort of, I got some introduction. I got interested more and more into it. And it happened so that I was in Peruvian Amazon as my first trip, so pretty close to Colombian Amazon. And that's how it started. And then, one after the other, every time I went, I enjoyed it. And then, so I want to have more. And then, thank God at this point, we're involved with Tim and the CDC and Meron and Karen. And it's been fantastic.
So my name is Meron Masidi. I'm with CDC's Prevention Research Centers program. And I've been now with CDC for 22 years. And I started coming to CDC. I trained in University of Pittsburgh, doctorate in epidemiology, and became interested in public health and the types of work that are done by reading, I don't know if you know, Burton Rouchet, Medical Detectives. So that was one of the books that sort of drew me towards the fellowship program, the EIS program. So that's how I got my start. And the person who got me interested in global health was, actually Dr. Cordero mentioned him earlier, it was Bill Foege, who was former CDC director, and sort of not just that he's a giant anyway in stature, but also a giant in the field. He's the one that, through many of the speeches, conversations, and talks, got me sort of interested. And I was interested before that, but not so much after. Not more than when I spoke with him. But I went to Yemen as part of the first sort of group of teams on the concerted effort for stop transmission of polio. Was there for 3 months in southern part of Yemen, so it was very isolating, but yet it was right at the cutting edge of like when they were first starting to think about polio eradication. So that's where I got most of my start.
Hello, my name is Esteban Avendaño. I'm a medical doctor, and I did my PhD here in Rochester. And So my first experience was as a student. I went to University of Miami, and I also went to Europe and back to Miami. And after that, I came here, and while I got involved in the MPH program here, I learned more about how we could transfer knowledge and how we could transcend the barriers of that I think was the conference last year was mentioned at some point that the boundaries are imaginary. There are really no boundaries in the earth we have. So basically, we can transcend that. And as Tim has mentioned at some point, health is one of those ways that we can communicate in the world, and it somehow transcends all the political and economic and other aspects. So it's a way of communicating and expanding knowledge and making a better place for everybody. So it's a very interesting field, and once you get into it, you get sucked in, knowing that there's different ways to do things, but at the end we are looking for the same things. So and it makes sense. So it's just a matter of keep doing things and keep trying, and outside we're having a conversation on where is that, what is the optimum, where is that we want to get to. So those are kind of the questions that at the end we want to answer.
Debbie?
Hi, everyone. I'm Debbie Ossip, and I'm a professor in the Department of Public Health Sciences here at the University of Rochester. I'm originally from Miami, which is a very international city. So I grew up really in a multicultural international setting and with multiple global perspectives because of the large immigrant population, particularly from the Latin American region into the Miami area. Virtually any health discussions that we would have, or any discussions throughout education, would necessarily be cross-cultural and cross-country kinds of discussions. My work in global health really came through my primary focus of my research being on tobacco control. And tobacco is a global health issue. Unabated, it's projected that it will account for about 1 billion premature deaths in this century, and about 70 to 80% of those are likely to be in low and middle income countries. Because as higher income countries like the U.S. have instituted more tobacco control measures, although it still remains a major problem in the U.S., tobacco companies have begun to look at low and middle income countries as growth opportunities. And so many of the strategies that are now banned in countries like the U.S. are now widespread in many countries around the world, in the low and income world. So my first foray was really from Quitlines research, telephone interventions, which were sort of some of the early technology-based interventions for tobacco control to reach broad populations across large geographic areas, looking in the U.S. side and also moving towards partnering with North America as a whole through the North American Quitline Consortium, with our partners in the European network of Quitlines, and then working with countries around the world towards establishing first telephone-based, now moving into web-based interventions. I've been doing tobacco control research in the Dominican Republic, NIH funded, for 15 years or so, and Tim and I now have, and the project in the Dominican Republic really came through an infrastructure that Tim and colleagues had developed around another project that gave us existing partnerships with which we could develop some tobacco intervention trials, community partnered. And now we've expanded to our MundoCom project, which works with health teams. Dr. Avendano and Dr. Dye and a group of us are on that project to work with community-based teams to focus on maternal health problems of local concern, to develop interventions, develop and test interventions using some forms of information communication technology. We have a whole training and mentoring and research program built around that.
Thank you. So if I could just summarize a bit for the 5 people that are here. So it sounds like maybe Hawk, and maybe Miran, I'm not sure. Did you deliberately go into global health, or were you more interested in public health and happened to get into global health? Or did you deliberately start off?
Well, no, I wanted to, but in '94 when I started, there were plenty of opportunities, but those opportunities were only afforded to those who had previous experience. And so having had none, I looked at the opportunity of where would I be able to best get it, and that was the opportunity that came to me. And
So what's interesting is that most people, except I think Hawk said he did get a master's in global health, so it seems deliberate.
Actually, I would say it was still happenstance. For example, when I came to US, I was here to train in internal medicine. I had no idea where we'll end up. It just happened so that MPH was part of my training, and then during MPH, I got exposed to the concentration in global health. And out of the biostatistics, you had choice between biostatistics and global health. You will pick global health. Okay? So I didn't feel I was particularly strong in that. So I picked global health, and as you learn more, and you have discussion with students and faculty, and start getting interested. So I think mine was built really from scratch. It was not planned.
So it's very interesting. So our 5 well-experienced global health people all sort of got into global health through a perhaps indirect route and non-deliberate route. So that's interesting. That's an interesting lesson. So that's the first question. Second question, and maybe we'll start with Dr. Avendano. What skills are you glad that you've had training in and are able to use in your work? And what skills, again, with respect to global health, do you wish that you had and you might recommend other people would plan to have those skills in their work? So what skills do you have that you're glad that you have, and what skills do you wish you had that you would recommend others to pursue? So.
Okay. Let's see, it's a toughie. I guess we all have different skills, and we all train in different fields. So some of us are training, for example, I was trained as a medical doctor, and afterwards I gathered more public health oriented topics like epidemiology, biostatistics, qualitative research. So in my case, I didn't have enough research background, which I gathered during school here, and then during the years I've been obtaining more of it, because the training I did was more clinically oriented. So, and that was probably one of my strengths, and still is that I know how to communicate with the community. I know how to communicate with patients. I understand the diseases, understand the pathophysiology, and that translates, and that can be it's like I was saying, that's something that can transcends barriers, transcends all the boundaries. So that's a good skill to have. It's a knowledge of something that can transcend a boundary, because we're talking about global health. So if you have a set of skills that can transcend a boundary, then you'll be doing fine. And as we've been talking during the morning, one of the important things to know is that we all have different thoughts, and we all think differently about what is good for us and what is not good. Our definition of well-being is different everywhere. So how when I feel good and what's well-being for me might not be for anybody here in this panel. So if we are aware of that, then I think we can do a good job in global health. So basically, those will be my good and bad.
Okay. Debbie, would you like to go next?
Okay. I think my background, my degree is in clinical psychology, and I think that's given some good skills because psychologists are trained to listen, and I think that's really been just a critical component of global health to understand that you come to the table as a partner. Not necessarily as a leader. Even if you're the PI, you're still a partner at the table, and listening is so critical. I think having research skills has been good because that's something that I can bring to the table. That enables me to bring some resources and also enables me to bring, without being wedded to a specific idea of what we're going to do, to bring some tools or some resources, as long as it's with the understanding that everyone else brings resources too, and somehow we've got to put the pieces together. I never had the benefit of an opportunity of formal training in global health, and I think perhaps there's some things that, you know, maybe I've picked up. I hope I've picked up some things by experience, but having a grounding in some sort of formal coursework in global health, I think, might have been helpful in cueing me to some things that perhaps I still don't know, or you know, could have developed a little bit sooner. Although I do think there are some advantages to coming to it from multiple perspectives and multiple disciplines, but maybe somewhere along the way having some key seminars or coursework or didactic or even experiential context in a learning environment, specifically around global health research, would be helpful.
Mehran?
So it's a good thing that I didn't go first, because it's allowed me to at least to think about the question. So first you said was what I went in with skills. So what I went in with, I guess, was the ability to be able to bring a fresh perspective into whatever the issue was, because I wasn't as involved with the particular issues that the folks were facing. So I was able to bring in that objective opinion and sort of thought and experience in. I guess the other part that I wish that I would have had more of, and I think that would be skills to have, is cultural competence. And that's just a skill. I think that's regardless of whether it's for global health setting. I think it's also even domestic work that gets done, is knowing exactly where you're going, what they're facing, and it gets a lot long in terms of the psychology. Is listening is one thing, but again, having the ability to understand the situation that you're going to be working in would allow you to be much more effective if you can understand those ahead of time as you're going in there.
For young people, I would say that really there's no particular skill or training you need to start. I think that could be very discouraging if someone told you that you had to have a PhD or an MD degree and this many years of training. Then probably less than 5% people will be doing this one. There's nothing. You can basically start by simply, well, you want to go and help out, maybe painting a home or building a home or cleaning a street. It doesn't really require any particular skill. So start somewhere. But I do agree with all the panelists who spoke before, respecting for their culture. I think it would be very rude for us to go in another country and basically dictate our values to them. And I agree with Debbie that you're being a partner, being a good listener, collaborate with them, respect and connect with them. I think once you connect, make friends, it's much more easier to get your job done. So I think all the way, really respecting the culture, having this culture competency Mehran talked about, those are all essential skills. And those really, you can't really learn in any particular school or something. Those come from basically your years of education, and those are soft learning. So I think that's pretty much it. For young folks, I will say that don't worry about it. You can start somewhere. You don't really need a particular training for it.
I really appreciate what Haq just said, is what I try to echo to my students, because they're asking, how do I do like this kind of stuff that you do? And I tell them, I didn't have a particular training in global health, and you have to just kind of do it, but you have to have, I think, an open mind, an open heart, a caring, a sense of caring about other people, and sort of that kind of basic, philosophical approach or what have you. I would say, for me, it's interesting, and I work a lot with clinical people, and I don't have a clinical background. Sometimes that's a little bit of a frustration for me. I feel like I wish I had a little bit more of a clinical background, but I agree with Haq. I don't think it's a requirement to do this type of work. I also get a little bit frustrated with myself about my lack of language skills, which kind of gets to Mehran's comments about sort of cultural competency. but I will surround myself with people that do have those fluency language skills so that there's, clear communication. It's a very important part. But for me personally, it's very frustrating that I can't directly communicate sometimes. And then also related to, I think, the cultural competency is I wish I had a course like in history I think you sort of want to prepare yourself as you're working in different communities in different countries. What is the historical background there? Goes to that cultural competency, but I think that's really important too. To be sort of ignorant of that, I think, is a little bit disrespectful. So taking the time to to learn that before you start working in a particular area, I think is important.
Thank you. So we have two more questions, but before we get on to that, I'd like to shift to the audience. And two things. First of all, you can ask any question about career development or research development of our 5 panelists, or you can offer something else that maybe you have from your own background or career that you think would be important for the group to know. And I'd like to ask if you could go to one of the microphones, and if you're watching us online, you can ask a question on the YouTube site, and then one of our staff can relay that to us. So any questions for our panelists in terms of preparation, in terms of research preparation, or in terms of career preparation? Yes? Rajiv?
So my name is Rajiv Ramachandran. I'm a clinician by training. What type of training opportunities are there, or we have K awards for research. Are there anything like that to develop global health research interests?
Who would like to take a start on that?
Well, I can answer some of it through Fogarty. There are various kinds of training grants available for U.S. investigators along the way who are beginning careers in global health, and also for partner investigators in other countries. There's sometimes those kinds of awards that will become available. Certainly within NIH, there are various grant opportunities that, as PI, we can bring on students or trainees as a part of that kind of a system. And with NIH, some of the institutes have, as you know, global portfolios, and from the standpoint of trying to benefit the relationships with other countries and health status in other countries, and also to look at what kinds of lessons learned we can bring back to the U.S. So some of the traditional funding mechanisms through NIH will have those opportunities, and then some of the agencies in Canada or in other countries may have opportunities for bringing researchers either way, from the U.S. to other countries or other countries to the U.S. for partnerships or for conferences to bring people together.
I would add to that, look into USAID. They have a Global Health Fellows program, which apparently is very highly rated. It's a bit of longer commitment, but I think it's well worth it.
And then I'm familiar with Fulbright as if you're in a sort of academic setting.
Right, and then as you're in an academic setting with CDC, there are IPA relationships, so taking a sabbatical, it's oftentimes folks who are in universities actually can come to CDC depending on where they might be interested in working. And then a more formal kind of training is obviously the EIS program has assignments on a global setting looking at applied epidemiologic kind of work.
And I will have to say that for international students, it depends on the countries, but there are also international organizations like the states of the OEA, Organización de Estados Americanos, for instance. They have scholarships, and there's different pathways. So it's always good to ask, I would say.
A question?
My name is Mary Chiswick. I co-chair HL2 with Don Bataille under the able leadership of Steve Barnett here at the Rochester PRC. And the NCDHR is dealing with people who are deaf, and HL2 has to do with another population of people who have hearing loss. And statistically, the numbers are 1 out of 10 in the United States who have hearing loss. And I'm wondering what kinds of interventions or how you are making it accessible for people who have hearing loss to be participants in studies that are being undertaken here. I spoke with 3 lovely ladies at the poster contest for Italy, Dolomite. And I asked them what kinds of things they were using to attract people who had hearing loss to be part of their study. And I was told none of our participants had hearing loss. If we know that 1 out of 10 people in this room has a hearing loss, you have someone likely that's in your study group who has a hearing loss. We're the poor stepchild that people tend to forget about.
I think you're raising a really excellent point from multiple standpoints when we think about this globally. I know with my Dominican partners, we've talked over the years about, might there be something we can do from the Dominican Republic side in terms of addressing hearing loss or deafness in a cross-cultural kind of way. I mean, I think methodologically, much of the lessons that we learn in community-based participatory research kind of go both ways. NCDHR here, the National Center for Deaf Health Research, has really been a leader in community-based participatory research with deaf and hard of hearing populations for generating surveys and now interventions. And I think those methods and the expertise that's been developed within NCDHR can really help inform projects domestically and also globally going into populations that have traditionally been underserved. But you do raise the interesting side in terms of even like as part of our research teams, what do we, can we have better outreach for research here locally and globally, not for research focusing on deaf and hard of hearing issues, and also for incorporating people from that community as members of the teams as we address issues in other populations, particularly those who have been involved in the community-based participatory research here, who may have unique skills and understandings to help, other researchers understand and have better approaches, more culturally sensitive perhaps, or approaches to addressing populations about whom we're just beginning to, with whom we're just beginning to develop partnerships. So I actually am hoping over time, I have a foot in both worlds. I have a piece of my time on NCDHR now, as well as in the global arena, and hopefully that will be an opportunity to build some bridges.
Even in developed countries, in our own CDC, many of the surveys of the population were telephonic. And I personally will self-exclude just out of pure frustration. So you will not get data on me using the telephone. So we need to think about other ways to obtain data.
Other comments from the panelists? Any other experiences to share?
Sure. So I hear your point, and I think that the fact that there are 2 PRCs, Prevention Research Centers, addressing some of these issues, specifically one in Rochester, and there's also the PRC in Oregon looking at noise-induced hearing loss among Native Americans. So I think it's an issue that what we need to do is to ensure that we have a clear story to be able to tell. And I think some of the efforts that Rochester is doing, I think are going to be helpful in getting the message out that it is an important public health issue, that more efforts need to be addressing the point that you just said is about surveys. It is not just the deaf community, it is also a lot of folks who have no phones and are oftentimes underrepresented with any of the types of surveys that are done via the phone. So there are also marginalized populations. So I think there's a lot to be gained by looking at some of the things that are unique and also some things that are related to those types of populations. So maybe thinking about it in that sense as well might help us to be able to better tell the story of why this population should not be feeling isolated.
I do want to say that I appreciate the University of Rochester for providing all the technological services for us today. My co-chair, Don, and I self-disclose, we have a hearing loss, and we want to know what's going on. And I would encourage you in the future, if you're making housekeeping policies for different kinds of events, seminars, that you offer that these services are available, because people who have hearing loss, they don't like to tell you, they don't like to ask. So it's wise to just have those things and be ADA compliant right from the beginning. Thank you very much.
Thank you. I might just add one comment to that. For me, in doing research, it's specifically Steve Barnett and Tamala David who bring this up regularly. So when we neglect to think of the deaf and hard of hearing population, they will ask. So I think so we end up being sensitized here at the University of Rochester. I don't think every place has the level of resources that we have here, but it's advocates in those populations and other populations that may be difficult to reach as well. That's the advocates in those populations that continually bring it up, so the rest of us start to think more, without being prompted in the future. That's a good point. Next question? Comment? Yes, Dr. Cordero?
I think that one of the things that I see is that most of you, I think that I would say our generation, actually global health has been something we learned as, so it was something learned through working and through experience. And so I guess the question is, do we have a need for developing training, or perhaps call it educational training programs to begin to train people or students or young people in terms of global health? Is that the direction we need to go, versus we stay the way we are, we work out of experiences for everyone?
Comments?
So there were at least 2 posters I saw out in the hall related to this question about doing surveys of current educational opportunities related to global health. So it was kind of nice to see that. I'm on the Associations of Schools and Programs of Public Health's global education initiative. So at our institution, we just started an undergraduate degree that has 2 global health courses in it, which I'm very happy about. At the master's level, it's a little bit more common, but I think at the undergraduate level, it seems to be the most popular major now, kind of in the U.S. From what I understand, global health. So that's kind of encouraging. That's my understanding.
Right, and I think one of the points, I guess, Dr. Cordero, you were talking about is getting, how do we get to students sooner? And I think that I've had the opportunity and pleasure of going to middle school students as well. And I think that's the whole issue of STEM research, on getting people involved in the fields, and of course we're in public health, so we want them to be involved in public health. I think that although it's great, and this is the enthusiasm that Karen was talking about, is obviously many of the universities' public health degree now is becoming fast becoming one of the top majors in many of the universities as bachelors. So one can then think about is the enthusiasm then keeps going back. How do we then mature, think through broadly at an earlier age, to not just make sure that it's available, but ensuring that it's available for boys and girls, and then also ensuring that it's available for all of the minority populations as well, because oftentimes they may not be brought through the efforts. So I think that would be a key thing, to start earlier on in the educations.
At the slightly older age group, let me point out we have 2 pediatric residents here. If you could wave. And they're on a specific global health track as part of their pediatric residency, and they were telling me a little bit about it. So I think that's terrific, and I'm glad that they're here.
Thank you. Dr. Palafox.
What is the difference between an interest in global health and doing research versus doing international health and doing missions to do medicine? So I think from a standpoint of a student looking at, I'm interested in traveling abroad to do health work, I think there's different ways that can be expressed. One is, I think what this has been about is about doing development and some research versus doing mission work, which may or may not be different. And then also, if you do the academic route, are you forever kind of casted to write grants or become part of the CDC? No, so that's a real question. So I'm just wondering the practicalities of defining it for the youth who want to do work abroad.
Question. Panelists, who'd like to go first?
I could take a stab at it. I don't think so really. I think more of a semantic difference. As I said, you can start anywhere. I started off with exactly doing that. I think in academic setting, you have more focused effort in maybe one region or a few countries. And when you see mission-based work, you often see more episodic work, which initially starts at episodic work. That's how I started with, okay, well, maybe a month here, maybe a week here, 2 weeks here. And then it becomes sort of you kind of gravitate towards one or two main sort of foci that you want to focus on. So I don't really see any difference. I think that any experience is worth it. And people should not start just because they're not organized, or it's not research, or it's not grant-based. I would say you get a chance to do a week, take that chance.
I think, oh, go ahead. Thank you. I think there's value to both and a fair opportunity for crossover. I guess from where I sit, I like the research side because there's, to the extent that it involves sustainability, because I think sustainability of partnered efforts, with the possible exception of like going in for emergency, for crisis relief situations, but for long-term change, to really have a situation where there's a sustainability of the partnership that develops, so that we're not just going in and do something that may be right or wrong and then leaving, but really as a partnership developing something that can produce improvements at the community level that's adopted by the community or the government or the country in a sustained sort of way. And it's harder to do that with one-offs. It's not impossible. I mean, if you have like a mission-based kind of an approach with a broader objective that's community partnered, and you may just have different people going over time because of the time that they can spend there, then I think that still has that sustainability piece to it. But it's, if efforts that go in to kind of go in and see and then come out may be missing the mark. I'm thinking of, I was talking to an ophthalmologist who had been with a group of ophthalmologists who wanted to do good in a low-income country from an ophthalmologic standpoint. So they got donations of glasses to bring down that they could then fit the population with who were having vision problems. They could screen and they could provide them with free glasses. Well, in the U.S., the primary ophthalmologic concern is nearsightedness, so they brought down these glasses that would help people see distances better. But they went down to an agrarian community where farsightedness was the problem. They needed glasses to help them, to help them read. So they brought down the wrong kind of glasses because it was this one-off kind of a mission approach. So I'm sure, we certainly have those pitfalls in research as well, the parachute or helicopter research where people go in, collect data, leave, and the community's not better for it. But I think kind of a cross-cutting theme is just some sort of a sustained effort with some way of evaluating, is it working or is it not working?
Any additional comments from the panel?
Yeah, I think I would like to add that as globalization with all the technology we have right now is changing. So, and actually I've seen it since I started here doing the MPH and how research was done, and with the Dr. Dai's team and everybody, the advent of WhatsApp, email, all the technology there is for communication. We're broadcasting live on YouTube. So it is changing, and it's changing fast, and I don't think the change is gonna stop happening. So I agree with what Dr. Osip is saying, and I think Dr. Palafak's question is very well directed at. It depends on what your goal is, but I do think that in returning to previous questions, we need to be aware of the culture, and we need to be respectful of the cultures, and I think if we do that, then we'll do a good job.
One thing, I think that the two are closer to one another, and they have to coexist. So in terms of, I'll give you the example of when we were, after the Haiti earthquake, when we went there, it was basically 3 days after. So there were medical response teams who were there actually providing clinical care. And so we were there to also then look to see what the needs were on the public health side of things, but then to also collect data on the types of patients that were coming in. And so what we were able to identify from that was that, A, the already taxed system that Haiti had was completely devastated. And then where the normal process takes place is that you treat the acute cases that are coming from the actual response. And what was happening is that it got to a point where those people who were there to provide care for the immediate things of, crush injuries or things like that, they were then getting to the point of delivering babies or looking at the infections that were taking place after the work that was done. That, I think, was helpful to some of the folks who were processing this in terms of in government and also political areas, to know that that needed to continue, some of the care that they were providing, because they were now actually taking the place of where their routine care would have been taking place. So I think that had there not been that sort of research part of looking at those numbers, the people providing the medical care would have just continued doing the work that they were doing, because that's what they're there to do, is to treat patients. But having another set of group there working working with them, looking at it as an issue to see that there has been a change in pattern of the types of people that are coming through, would allow for more sustained efforts and funding and supports for the issue at hand.
The partnerships, I think that's really an important issue, that it's not an either or, I agree. And I think maybe like our colleagues at University of Illinois in Chicago have a really interesting partnership between the researchers and Peace Corps in Africa. And there are probably all sorts of good partnerships that could be developed. And I know, Dr. Halifax, you've had a lot of experience kind of working in both worlds, really, from the more mission or seeing that process of one-off kind of contacts or contacts through NGO sort of, as well as from the research side. And I mean, I was wondering if you had some comments on that.
No, I just think it can be blended, but I think there's different sets of events, and it can be blended through this type of work. But I think, they have different purposes for different people, and one can lead to the other, certainly.
Yeah, I was going to just comment. You sort of, part of your question was, are you sort of always forever tied to grant writing if you're an academic? I think that there's some truth to that in some sense, but I think you can also get involved in other, kind of fraternal groups like Rotary or Lions or what have you, where they have their own kinds of projects. Some of them can be very kind of partner focused. We're working a lot now with Rotary because they'll, they have funding and those sorts of things. And the other thing that I've seen happen among academics is to start to set up their own, nonprofit organizations as another mechanism to be able to continue the work should the grant funding kind of disappear.
I would add, though, I think that there's inherent danger in either approach of being insensitive and also causing harm. So I think first rule of thumb, which I often tell students, is that first do no harm. I have seen through medical mission, post-disaster, where people ship a lot of donations and medication which have expired. I've also seen people over-treating basic illnesses, and they will give them maybe a 2-week supply of antihypertensives or antidiabetics, and they will basically walk away, and that's basically not sustainable. And that probably is, in the long run, cause more harm than this episodic drop-in, give medication, then get out. And that doesn't help either. And same for research. If research is insensitive, does not really care for the culture's values, that could also harm your relationship.
I do have one final question to ask the panelists before we wrap this session up, and that is, what do you see as the at least one major gap in global health in the near future that either you are going to be addressing or that you hope others address? So one gap that you think you or others should be addressing in the near future in global health. And maybe, Hak, we can start with you, please.
Well, there are a lot of gaps. I think one of the gaps is basically lack of coordination. I often find that, let's say, post-disaster, I've been in a situation post-disaster, and there's utter lack of coordination among different NGOs, even WHO or other agencies, even among US NGOs. And there's really no good way to do this, and I have no idea how to really improve that one unless sort of a governmental agency or WHO takes more control of it. I remember being post-tsunami in Sri Lanka. Even the Sri Lankan government tried to handle that, and they weren't able to do that. I remember being in Pakistan after the large earthquake there, where government basically pretty much confiscated every supply came through the planes because they wanted to coordinate and reroute where supplies are needed rather than basically every NGO carrying their own trucks to different areas. I think that's a huge problem, especially in a post-disaster segment.
Karen?
I would say, because we've talked a lot in this symposium about technology and all of its virtues, and I'm very supportive of that, but I do see in our work the digital divide, or however you want to sort of phrase that. In our case, working in rural Senegal where there are no laboratory services, it's projected that HPV vaccine is not going to be available 6 to 10 years. And they ask us, why is that? Why don't we have access to that? Why do we have to, why are we being screened and treated with this VIA? And trying to, to really address that in an honest and an upfront way keeps me awake at night about that sort of disparity. It's a gap.
Debbie, would you like to go next, please?
Yeah, I think it's really completing the translational continuum. So finding ways to get evidence-based and feasible interventions to where they're needed in ways that they can be adopted and sustained, almost irrespective of content area. So that whole issue of infrastructure, connecting the dots, resourcing, community engagement, but in ways that are feasible and realistic, and sustainability, maintaining sustainability.
Esteban?
So I will have to say multidisciplinary work. For instance, here we've been talking a lot about politics and economics and all that, and I think it will be interesting to see higher participation, between multidisciplinary works and we could discuss here with economists and politicians and other people from other fields and what their thoughts are and what we could all do, to solve all of the issues that we've seen.
Miran?
I think the issue that I see isn't lacking is that trained workforce who's trained in the ability to be able to recognize evidence-based practices that then can be brought to the government, the ministry, and to be able to direct funds towards those efforts that are most likely to result in measurable outcomes. And so that's an issue actually for this country as well. Public health workforce is shrinking. Many people are retiring and are not being replaced. And so it's not just a global health issue, it is a issue for our own healthcare system, our public health system in the U.S. as well.
Please join me in thanking our panel this afternoon, and thank you very much for your participation. I'd like to ask you to stay up here, though. We're going to do the awards for the student posters, and Karen is our new photographer, so. After, okay, good idea. Great. Okay. And we'd like the Global Network folks to stand with our student winners, if the students are here. So I do have the envelope in here.
Do we have the drum roll?
Yeah. Oh, the
That was
Ghanaian
early
drummers
today,
have one,
right,
sorry. So we had 3 awards. We had a lot of posters this year, and they were all very good. And the student, any poster that was presented by a student was eligible to be ranked, and we did that and tallied them up, and we have 3 winners, although they're all winners because they were great, and it was really interesting for us to read them. These were the 3 that the judges decided upon. So we'll start with Best Science. And I don't know if these people are here, so I will just read it. And if they're here, please stand up so we can cheer you. So the Best Science poster winner is Claire McCarthy. Is Claire McCarthy here? Doesn't seem to be her. Her poster was toll-like receptor ligands and airway epithelial cells in mice. So I don't exactly know what all that is, but the judges thought that was the best science, and we're happy to congratulate Claire for that. So congratulations, Claire. Let's see, the next one is Best Visuals, and the Best Visual poster goes to Karen Chung. Is Karen here? Doesn't seem to. I think all the students have gone back to class is probably what we've seen. Karen's poster was relationship between age and ASQ3 scores for each screening interval in Peruvian infants. So we will also applaud Karen, and we'll give her a certificate later. And the best overall presentation is to Zishan Pan. Is Zishan Pan here? Okay, for sure, all of our students have gone back to class.
We hope.
Yes. Zishan's, yeah, Zishan's, they're probably on YouTube cheering themselves, hopefully. So Zishan's poster was towards understanding how news coverage affects public perception during epidemic outbreak. So congratulations, Zishan. So thank you very much for sticking out this long day to the very end. We hope you found this useful and informative day. Everything is on YouTube. You can get to it and show it to your classes, show it to your friends, use it as motivation for other people who may become involved in global health. Thank you very much for all of our people who participated as speakers, and to all of our organizers and people who've helped out with our technologies and everything else we've done today. So thank you again, safe travels, and we'll see you next year.